Hi, afternoon friends, afternoon everybody, afternoon everybody. I guess we know each other pretty well. I am Dr. Sushanth Soni, MBBS MAMC, MD Pathology, Resident Hemato-Oncology, AIMS Delhi. And let us start. Let us start with our remarkable rapid revision of pathology 2.0. Let us start with pathology. Now, this is the index. The next 5 to 6 hours, it will be sort of a roller coaster ride. I'll speak more, I'll speak faster. Secondly, this is the content that we will be covering in the next 6 to 7 hours. बच्चे पैथ हमेशा एक ऐसा सब्जेक्ट है जो ना अपनी नैया पार कराता है, in the sense that we have about 23 to 24 questions which come from pathology. Absolutely, Keval, absolutely. So, we have 23 to 24 questions which come in pathology, out of which the breakup is such that 8 to 10 questions are from general path, around 6 to 7 questions are from hematology, and the remaining 7 to 8 questions are from systemic path. If you know your systemic path well, you will be very comfortable with 7-8 questions of medicine also. So on this note, let us start with one of the easiest topics in general pathology, that is cell injury. So I am not even getting into hypertrophy, hyperplasia, the cell adaptations. You very well know that hypertrophy is an increase in size of cell versus hyperplasia, that is an increase in number. You are comfortable with that. So let us start with our first important topic in cell injury, that is necrosis versus apoptosis. This is where questions come from. When we talk of apoptosis, what is the first word that comes to our mind? Apoptosis, which it is programmed. Which proteins play a role in apoptosis? Caspases. So it is programmed caspase dependent cell death. Apoptosis, it can be both physiological and pathological. What do I mean by physiological apoptosis? That is the one which is occurring during embryogenesis. During embryogenesis, that is when we are in the womb of the mother. We had notochord, we had a tail. Unfortunately, now we don't. We had a notochord, thyroglossal duct. It undergoes physiological atrophy. So it is both physiological and pathological, versus necrosis, which is non-programmed and is only pathological. Very, very important. The main difference between necrosis and apoptosis is apoptosis में inflammation नहीं होती. Apoptosis, inflammation is not seen. If you know this, you will know everything. मतलब अगर inflammation नहीं हो रही, if inflammation is not seen, so plasma membrane integrity is maintained and leakage of cell contents is not seen. खुद सोचो, this is the plasma membrane of the cell. Plasma membrane integrity is maintained, so leakage of cell contents does not occur. It is not associated with inflammation. Versus necrosis, which has inflammation, उसमें inflammation होती है. So plasma membrane integrity is lost and leakage of cellular contents is seen. Next, recent NEET PG PYQ, apoptosis. Apoptosis is not associated with cellular swelling. All of the following are features of apoptosis except cellular swelling. Recent NEET PG PYQ. Easy NEET PG PYQs are often asked in your FMGE exam. Your this mid-year FMG, that is the July 2025 FMGE exam, had 4 questions from the March NEET PG paper. So easy NEET PG questions are always asked in our FMGE. Next point. So let us start with our first pattern of cell injury, that is necrosis. Which is the most common cause of cell injury? Ischemia. So I can safely say that the most common pattern of necrosis is coagulative necrosis, which is associated with ischemia of organs. Ischemia of any organ of the body. It is the most common pattern of necrosis. And ischemia of any organ of the body is coagulative necrosis, except brain, which is liquefactive necrosis. Except brain, which is liquefactive. Next, the minute I see this diagram, you are very comfortable with the fact that what is the organ? It can either be kidney or spleen. I am okay with either, which is showing the presence of a well-defined wedge-shaped infarct. एक ये अच्छा सा well-defined infarct आ रहा है. It is a well-defined wedge-shaped infarct where thrombosis of the vessel is at apex of the infarct. देखो बच्चे, this was the vessel, this was the blood vessel which underwent thrombosis. As a result, जो भी area, whichever area was supplied by this vessel is undergoing coagulative necrosis. Plain and simple. Versus, you keep on telling me the answers side by side. Fatafat say, I'm sure you know this. This is one of the easiest topics. Parent organ, brain. Parent organ, brain. The minute you know it is brain, it becomes liquefactive necrosis. As such, liquefactive necrosis, it is associated with bacterial or fungal infections. It is associated with pus formation. Pus ban rahi hai, liquefaction ho rahi hai. Bacterial or fungal infections and coagulative necrosis of brain, as you already told me. Next, now tell me this. Parent organ, lungs. Parent organ, lungs. So do not worry, you will have the annotated PDF with you. Absolutely do not worry. What we see here is the presence of caseous necrosis. Now, which are the diseases associated with caseous necrosis? It is showing the presence of a cheesy white material. In the lungs, caseous necrosis. जब भी बच्चे हम caseous necrosis की बात करते हैं, the first disease that always comes to our mind is TB, tuberculosis. Other than TB के अलावा, which is the other disease associated with caseous necrosis? Please put a star. It is also associated with histoplasmosis. Caseous necrosis. Other than TB, it is also associated with histoplasmosis. Whereas, अब इसको उल्टा सोचो, think of it the other way. Non-caseating granulomas with bilateral hyalymphadenopathy, which is the first disease that comes to your mind? Sarcoidosis. So, I'm not concerned with sarcoidosis, hypersensitivity pneumonitis, Hodgkin's lymphoma. Nobody is going to talk about Hodgkin's and all with respect to necrosis with you guys. Not at all. So, caseous necrosis, TB and histoplasmosis versus non-caseating granulomas with bilateral hyalymphadenopathy, sarcoidosis. Other than that, it is also associated with hypersensitivity pneumonitis. We'll see that. Next, what do we see here? This is mesentery. This is mesentery. ये पूरा mesentery नजर आ रहा है. This is all fat, which is associated with calcifications. It is showing me calcifications due to saponification of fat, making this as a case of fat necrosis. 2-3 points here only. When we talk about fat necrosis, who has more fatty tissue? Young female or older female? Fat necrosis of the breast is more common in. It is more common in young female, old female. It is more common in older females. Sejal, young female has more fibrous tissue. That is why young female, the breast is more firm. Versus older female, she has a softer sagging breast. So fat necrosis or fatty tissue as such is more common in older females. So fat necrosis is more common in older female. So it is next point. Now we have already seen that older female, the breast is softer. Now the breast is softer. As a result, it is a palpable lesion. So now think of it as an older female presented to your OPD with a palpable lesion in her breast. Diagnosis: old female presented to OPD with a palpable lesion in her breast. It is a differential diagnosis of carcinoma breast also. We have two main DDs, fat necrosis and carcinoma breast. So there are two questions now. I want everybody to tell me this. What is the screening test of choice? What is the screening test of choice for fat necrosis? We are talking about young female breast mouse, that is fibroadenoma. Suppose a young female reproductive age group comes to an OPD with a lump in breast which is movable, that is fibroadenoma. Older female, we will never ever think of fibroadenoma, वो तो blunder हो जाएगा. So screening test of choice, mammography. Screening test of choice is mammography. Versus what is the investigation of choice for breast lesions? Investigation of choice being biopsy, CT, ultrasound, FNAC. What will be the investigation of choice? Lucky agreed, Lucky Dinesh agreed, FNAC. It is not ultrasound, but we need to see the cells on a slide to be sure whether it is benign or malignant. Fine needle aspiration cytology, FNAC. Biopsy of the breast is much more painful. Why will you like to give the patient that much pain? So investigation of choice being FNAC. These two questions are important. Next point. So which all patterns of necrosis have we seen? Coagulative, liquefactive, caseous, fat necrosis. Next, the most important and the most aggressive pattern. I'm good those, and I hope so are you. The most aggressive pattern of necrosis being fibrinoid necrosis. Very, very important. Please have a good look at this and tell me the diseases associated. The minute I see this, I'm comfortable with the fact that these are RBCs in the lumen. It's a blood vessel. Blood vessel की wall टूटी हुई है. It is showing disintegration of vessel wall with fibrin-like material, fibrinoid necrosis. Associated with which vasculitis? PAN. Polyarthritis nodosa. PAN. PAN has two phases, acute and chronic. It is seen in PAN acute phase. But if fibrinoid necrosis is aggressive in nature, na, so it is seen in an aggressive condition, that is acute phase of PAN. Next, PAN acute phase. Next, fibrinoid necrosis, it is seen in RHD. It is seen in RHD. That is, yes, it is. Anirudh, and the end of the session today only, in this session only, we'll have a look at the previous 2 years papers also, and you will see that majority of the questions with respect to pathology, it's a very balanced paper, the topics are repeated. So these 6-7 hours will absolutely take care of your path questions for your FMGE exam. Next, RHD. Next, it is seen in SLE. You have a history of a young female presenting to OPD with malar rash, butterfly-like rash, that is, there is rash on cheeks and bridge of the nose with photosensitivity. SLE. SLE affecting the kidney is called as lupus nephritis, whereas SLE affecting the heart is called as LSE. It is called as LSE, Liebman-Sack endocarditis. So examiner instead of writing SLE can also write LSE. LSE क्या है? Liebman-Sack endocarditis. Next, it is seen in which are the other diseases associated with fibrinoid necrosis? Polyarthritis nodosa, PAN, RHD, SLE, hypertension. कौन सा hypertension? Benign या malignant? Malignant hypertension because it is more aggressive in nature. Malignant hypertension. And lastly, graft rejection. I took the graft, my body rejected it. Graft rejection. ये 3 type, it is of 3 types. Hyperacute, acute, chronic. Which is the most aggressive type? Occurring immediately. Hyperacute type. Graft rejection, hyperacute type. Graft rejection, hyperacute type. So these are the diseases associated with fibrinoid necrosis. Please have a very good look at this slide. An important slide, important list of diseases with fibrinoid necrosis. We have 5 main causes. So this was with respect to necrosis, the patterns of necrosis. And this gets us to the other side, other and the more important side, that is apoptosis. Apoptosis, but it occurs by 2 pathways. Firstly, have a look at this image. The minute I see this, I am comfortable with the fact that these are large cells with abundant granular cytoplasm. Large cells with granular cytoplasm with presence of a nucleus. Which are these cells? All of these are hepatocytes. इसमें abnormal hepatocyte कौन सा है? Which is the abnormal one? This one. As compared to others, is it smaller or larger as compared to normal? It is a smaller, contracted apoptotic hepatocyte. कैसे पता? Because it even has a larger नहीं है, smaller. It is eosinophilic smaller. Agreed. अब देखो larger लिख के delete भी कर दिया. गलत आंसर कभी delete नहीं करते. Because more you go wrong in this session, more you speak, more you go wrong, higher will be your recall in the paper कि मैंने session में गलत किया था, so I will remember. It is a contracted apoptotic hepatocyte called as Councilman bodies. Called as Councilman bodies, which is a feature of acute hepatitis. Very, very important, bache. Councilman bodies are seen in acute hepatitis. Recent FMG PYQ versus the presence of ground glass hepatocytes. Before I write this, you tell me. Ground glass hepatocytes. Ground glass hepatocytes is a feature of ground glass, bache. Which chronic hepatitis? Miss Mill. Which chronic? That was the chronic hepatitis B, C, D. All three options are given. You know that there are three main chronic hepatitis. Hepatitis B, C, D. A and E are acute hepatitis. So ground glass hepatocytes are feature of chronic hepatitis B virus infection. Recent FMG PYQ. Next point. So again an important slide. Acute hepatitis, Councilman bodies. This is what it looks like. Chronic hepatitis, ground glass hepatocytes. Which chronic hepatitis? Chronic HBV. So when we talk with respect to apoptosis, bache, it occurs by two pathways. The intrinsic or the mitochondrial versus extrinsic. Extrinsic का दूसरा नाम क्या है? Also called as the fast ligand or the death receptor pathway. मतलब, अब इसका मतलब क्या है? देखो बच्चे, if this is the plasma membrane of the cell has fast ligands. Plasma membrane के ऊपर fast ligands होते हैं. Fast comes and binds to it. तो इसको extrinsic या fast ligand pathway भी बोलते हैं. Extrinsic or the fast ligand or the death receptor pathway. ठीक है, fair enough, agreed. Which is the major pathway of apoptosis? The intrinsic pathway. देखो first one, पहले वाला all the first, अब मैं प्यार तो नहीं बोलने वाला, but all the first are always the main. So this is the major pathway. This is the major pathway of apoptosis, that is the intrinsic or the mitochondrial pathway, which is associated with, this statement is very important, it is associated with leakage of cytochrome C from mitochondria. एक बार have a look at this statement. देखो, हम सब में, in all of us, we have cytochrome C in mitochondria. Mitochondrial cytochrome C normal होता है. What is the role of mitochondria? It is the powerhouse of the cell. It is needed for synthesis of ATP by electron transport chain. So mitochondrial cytochrome C plays a role in synthesis of ATP. When it leaks, leakage of cytochrome C from mitochondria, that is this cytoplasmic cytochrome C. This cytoplasmic cytochrome C binds with apoptosis activating factor leading to apoptosis. This binds with APF, apoptosis activating factor leading to apoptosis. This is the intrinsic path. It was associated with leakage of cytochrome C from mitochondria. So when it came in the cytoplasm, वो apoptosis activating factor से bind कर गई, leading to apoptosis. So which are the proteins associated with apoptosis? An important table. Any protein, कोई भी protein जिसमें L आता है, that is BCL2, BCLXL, MCL1, flip. Any protein with L in it is anti-apoptotic. BCL2, BCLXL, MCL1, flip. It is anti-apoptotic. देखो L आ रहा है. Except BCLXS, which is pro-apoptotic. Except BCLXS, which is pro-apoptotic. तो सिंपल याद रखते हैं, जिसमें भी L आया, that is anti-apoptotic. अब L से for the Hindi speaking, कोई this was recent PYQ, perfect, totally agreed केवल. जिसमें भी L आया वो anti-apoptotic है, except BCLXS, which is pro-apoptotic. बाकी pro-apoptotic proteins कौन से हैं? BED, BEM, Puma, Noxa, BAD, BAC, SMAC Diablo. SMAC Diablo, I know, sexy name for a protein. All these are pro-apoptotic. These are the proteins associated. Next, Remember apoptosis caspase activation के कारण हो रहा था. It was because of activation of caspases. So this gets us to the caspases associated. दो टाइप के पाथवेज हैं, इंट्रिंसिक, एक्सट्रिंसिक. So caspases, बच्चे, we can divide them into initiator and executioner. Intrinsic pathway, the initiator caspase is caspase 9. Easy to remember. Extrinsic are 8 and 10. मैं घर पे बैठा हूँ, two friends 8 and 10 came from outside. It is a party at my place, so I will sit in the center. Caspase 9. Caspase 9 is the initiator caspase of intrinsic pathway. 8 and 10 are the initiator of extrinsic. 8 and 10 extrinsic के हैं. अब obviously पार्टी मेरे घर पे है तो बीच में तो मैं ही बैठूंगा. दो दोस्त 8 and 10 बाहर से आए. अब पार्टी में everybody will eat the same food. So executioner caspases are caspase 3 and 6. These are the caspases associated. Which is the main initiator caspase of extrinsic pathway? मुझे एक मार्क करना है. What will I mark? Caspase 8. Main being caspase 8. Whereas which is the main executioner caspase? Caspase 3. Main executioner caspase being caspase 3. हमेशा पहले वाला, मतलब उसको तो कभी लाइफ में भूलना ही नहीं है. So these are the caspases, और हम भूल भी नहीं पाते. I mean, I guess they remain as a password. Their year of birth remains as password of our phone. But these are the caspases associated. Next point. This gets us to gel electrophoresis. देखो बच्चे, again a very important slide. Gel electrophoresis. If I have to make a diagnosis of apoptosis के लिए marker कौन सा है? Which is the marker of apoptosis? Annexin 5. Annexin 5. This is a dye which is a marker of apoptosis. ठीक है, मान लिया. Next, for making a diagnosis of apoptosis, we use gel electrophoresis. हम लोगों ने सैंपल यहाँ पे डाला. This is the application of the sample. मुझे नहीं पता कि सैंपल में क्लिनिशियन ने क्या भेजा है. Suppose sample is normal DNA. Look at column C first. बच्चे, this is normal DNA. This is normal DNA. We see a single band. DNA heavy होगा ना. It will migrate less. So we see a single band close to point of application of sample, normal DNA. Versus suppose the sample that clinician has sent me, उसमें necrosis हो गया. Necrosis is non-programmed. DNA randomly कटेगा. It will get spliced randomly, giving rise to fragments of all sizes. That is diffuse smearing pattern. This is the diffuse smearing pattern which is seen in necrosis. Versus, as you very rightly told me, versus if it is a case of apoptosis is programmed caspase dependent cell death. That means endonucleases are cutting DNA at particular points, giving rise to the classical stepladder pattern. Giving rise to the classical stepladder pattern. That is apoptosis. And lastly, normal RNA. We see two bands, 28S and 14S, slightly away from DNA. This is gel electrophoresis. And majority of you were right. This is gel electrophoresis. Necrosis, diffuse smearing, apoptosis, stepladder pattern. DNA तो बिल्कुल intact था ना, तो heavy है. Single band close to point of application of sample. DNA, RNA के दो bands. Perfect. This was gel electrophoresis, and this takes care of necrosis and apoptosis. Marker of apoptosis बचे annexin 5, CD95. If you are talking about the molecular marker of apoptosis, that is CD95. The extrinsic pathway, the marker is CD95. Next, so let us have a look at this. देखो caspase independent है ना, so apoptosis is out. Programmed है, so necrosis is out. What is left? Necroptosis. It is showing you features of both necrosis and apoptosis, necroptosis. Let us see what we mean by that. Suppose extrinsic pathway of apoptosis is activated. Suppose extrinsic pathway of apoptosis is activated. Which is the initiator caspase of extrinsic pathway? Initiator caspase being caspase 8. This in turn leads to activation of caspase 8, which will go to executioner caspases and apoptosis. This is normal. But suppose there is failure of activation. Suppose there is failure of activation of caspase 8. Caspase 8 did not get activated. This in turn will lead to mitochondrial damage, reduced ATP and necrosis. But this is called as necroptosis. It is programmed. It started as apoptosis. It is programmed caspase independent cell death. So biochemically it is apoptosis because it started as apoptosis, but morphologically it is necrosis. This is necroptosis. Versus pyroptosis. Pyro is fever. So the minute you have these words, fever, inflammasome formation, it is associated with fever. Inflammasome formation. Which is the main cytokine responsible for fever? Which is the main pyrogen? Interleukin 1. Caspases associated are caspase 1 and 11. The minute you have these options, it is a case of pyroptosis. So the minute you have these words, that is pyroptosis, fever, inflammasome formation, interleukin 1, main cytokine with fever, interleukin 1 followed by interleukin 6, and caspases associated, caspase 1 and 11, it is a case of pyroptosis. Plain and simple. Next point. So this gets us to our last two miscellaneous topics in cell injury, pigments and calcification. Calcification से शुरू करते हैं. Simple straightforward topic. Calcifications are of two types, dystrophic, metastatic. D से dystrophic, D से dead or damaged tissue. So dystrophic calcification is seen in dead or damaged tissue versus metastatic calcification, which is seen in normal tissue. Which is the most common normal tissue where metastatic calcification occurs? Most common is lungs, followed by kidney and stomach. Metastatic calcification, most common is lungs, followed by kidney and stomach. मान लिया. Next point, dystrophic calcification. Serum calcium. Understand this point. If you know this, you will be very comfortable. बच्चे, calcium levels in blood in dystrophic calcification are normal. Calcium normal है, but वो जाके damaged tissue में deposit हो जाता है. Versus metastatic calcification where calcium is high. That is why it goes and gets deposited in normal tissue. Next, examples. Dystrophic calcification, the examples being it is seen in RHD, rheumatic heart disease, RHD. Atherosclerosis. Next, what is calcification in muscle layer of blood vessel called as? Monkeberg medial sclerosis. Even if you don't remember this, I am okay with it. What you have to know is it is seen in RHD, rheumatic heart disease, RHD. Atherosclerosis, Monkeberg medial sclerosis, and calcifications associated with tumors. Which bodies? Also seen in TB. I agree. It is seen in TB, tubercular lymph node. It is associated with dystrophic calcification. And which bodies? Semoma bodies. Bodies are important. हम लोग end में एक table बना लेंगे. It is associated with semoma bodies. Which are the tumors associated with semoma bodies? They are an important list. PTC, papillary thyroid carcinoma, papillary renal cell carcinoma, papillary RCC, papillary renal cell carcinoma. Which ovarian tumor? Serous ovarian tumors. Next, recent FMGE PYQ, you had a history of a young female, 18-year female presenting to OPD with severe throbbing headache, the kind she has never experienced before. MRI shows the presence of dural thickening. CT scan shows a tumor. Which is the most trouble diagnosis? Which is the most common primary CNS tumor? Meningioma. So microscopically it shows whirling and calcifications. Recent FMGE PYQ, This was the answer to be marked. Microscopically, it shows whirling and calcifications. This is what we mean by whirling. Recent PYQs: meningioma, mesothelioma, and prolactinoma. These are the examples of dystrophic calcification associated with seminoma bodies. Versus metastatic calcification. Versus metastatic. In metastatic calcification, serum calcium is high. Which hormone is needed for elevated serum calcium? Parathyroid hormone, PTH, parathyroid hormone. So hyperparathyroidism for any cause, whether it is because of cancer, adenoma, does not matter. Next, अच्छा ये बताओ मुझे, this is important. Elderly with low back pain, which blood cancer? You get 300 questions in your paper. Out of those 300 questions, if you don't mark the answer to this as 1, it means एक question तो गलत हो गया. Every paper has 1-2 questions from this topic. Elderly with low back pain, which blood cancer? Multiple myeloma. You cannot afford to go wrong in multiple myeloma. It is a cancer of plasma cells. It has increased number of plasma cells with any one CRAB features. CRAB मतलब calcium is increased. Calcium बढ़ा हुआ है ना, तो metastatic calcification है. R which organ? Renal insufficiency. A anemia. B bone lytic lesions. Multiple myeloma. Which is the most common immunoglobulin associated with multiple myeloma? Multiple myeloma, immunoglobulin IgG. On protein electrophoresis, it has M band. M stands for monoclonal band. Recent PYQ, FMGE PYQ, you were given a history of bone lytic lesions, malignancy of plasma cells, M band. Answer: multiple myeloma. Elderly with low back pain, multiple myeloma. Next, in urine, it is associated with Bence-Jones proteinuria. This was written in the question only. Presence of Bence-Jones proteinuria. Every paper has 1 question from multiple myeloma. इसमें गलत नहीं जाना. We'll do it in blood cancer. Next, so examples of metastatic calcification. Calcium high था, hyperparathyroidism, multiple myeloma, and lastly, non-caseating granulomas with bilateral hilar lymphadenopathy, sarcoidosis. You already told me that sarcoidosis, calcium is high because these granulomas secrete vitamin D3. These granulomas secrete vitamin D3, so calcium was high. First class. This was dystrophic versus metastatic calcification. You know the examples, you know the calcium levels at the bottom. And this gets us to our last topic in cell injury, that is pigments. Which is the aging associated pigment? Lipofuscin. Color? Golden brown. Please don't call it as brown. Lipofuscin, bache, it is a golden brown. It is a golden brown perinuclear pigment associated around the nucleus. It's a golden brown perinuclear pigment associated with aging. We'll come to the stains. Not to worry. सारे stains एक साथ list बनाएंगे. Next point. So, which are the main organs associated with aging? Heart and brain. So, because of aging, lipofuscin deposition in the heart is called as brown atrophy of the heart. A very common mistake we do is we know that brown pigment is hemosiderin. So brown atrophy of the heart में हम hemosiderin mark कर देते हैं. No, please don't do that blunder. Brown atrophy of the heart, the pigment getting deposited is lipofuscin. Next is melanin. Now we are dark skinned because of melanin. Melanin is black in color. Which is the stain used for melanin? M for melanin, M for Mason-Fontana stain. M for Mason-Fontana. Melanin secreting tumor is called as melanoma. So which are the markers? Which is the IHC immunohistochemistry for melanomas? It is HMB45 and S100 positive. HMB45 and S100. More specific stain for melanin being HMB45. It is black in color. So kahan hai? What all is black? No double meanings. Skin, hair follicles, iris of the eye, substantia nigra in the brain. These are the normal sites for melanin. Fair enough, I am not even writing that. Agreed. Lastly, अच्छा टेल मी दिस, सब कुछ छोड़ो, अब मिलान है तो ऑब्वियस है ना, उसमें मिलान आ रहा है तो मिलान है. अच्छा मुझे ये बताओ, विच इज द सेक्सी स्किन कलर? ब्रॉन्ज. When we talk of bronze diabetes, which pigment comes to your mind? Hemosiderin. Bronze diabetes, this is because of excessive iron deposition. That is hemochromatosis. Excessive iron deposition in the body, hemochromatosis. So the next endogenous pigment is hemosiderin. Hemosiderin. Hemochromatosis, recent FMG PYQ, gene mutation, HFE. HFE gene mutation present on chromosome. HFE and HLA, they are present on the same chromosome, chromosome 6p. P for petite, short arm of chromosome 6. Most common organ affected is liver, followed by pancreas. Because pancreas is getting affected, so diabetes हो रहा है. And hemosiderin deposition in the skin. देखो melanin black है, hemosiderin brown है. तो जब black और brown color mix होते हैं, so which color do we get? Bronze. It is bronze diabetes. So HFE gene mutation, chromosome 6p, which all these are recent PYQs. HFE and HLA, both of them are present on the same chromosome, chromosome 6p, short arm of chromosome. Perfect. So this finishes our first small topic. Stain used for iron. Pearls or the Prussian blue. Girls, you wear necklaces made of pearls. Pearls or the Prussian blue stain. Perfect. So everybody done. Next. So bache, this starts us with our next topic in general pathology, that is inflammation. Starting with, I'm not even writing the 4 basic words, rubor, collar, dollar, tumor. Those 4 words of inflammation, they were given by Celsus. The fifth word, rubor, collar, dollar, tumor, that is redness, heat, pain, swelling. Fifth word, that is functionio or loss of function, was added by Rudolf Virchow. If suppose my wrist joint is inflamed, there will be a loss of function. It was added by Rudolf Virchow. ठीक है, मान लिया. So let us start with our first topic, that is components of inflammation. Let us start with components of inflammation. Inflammation, which there are 3 components. Vasodilation, blood vessel dilate हुई. As a result, the permeability of the vessel wall increases. There is increased permeability of the vessel wall. So WBCs come out. That is emigration of leukocytes from circulation. So there are 3 components. Vasodilation, the vessel wall dilates. So permeability increased permeability, so WBCs come out. First question, what is the first change seen in blood vessels? Answer, vasoconstriction or dilatation. What is the first change? First change seen in blood vessels is vasoconstriction. Let me just write this properly. Bache, the first change is vasoconstriction, which is transient in nature. थोड़े से time के लिए, followed by vasodilation. The first change seen in blood vessels is vasoconstriction. Next point. Emigration of WBCs from the circulation. ये जो WBCs बाहर आते हैं, this has a special name to it. This is called as diapedesis. Emigration of WBCs from the circulation is diapedesis, which is mediated by CD31 or PCAM. Diapedesis कौन करवाता है? It is mediated by CD31 or PCAM. PCAM is platelet endothelial cell adhesion molecule. So अब अपने 3 components हैं. These are the highlighted components. Vasodilation, so permeability increases, and there is diapedesis, which is the hallmark of acute inflammation. If this thing has occurred, I'm sure it is acute inflammation. What is the hallmark? Increased permeability. Increased permeability of the vessel wall is the hallmark. It is the hallmark of acute inflammation. And this permeability increases by 3 mechanisms. There are 3 mechanisms of increased permeability, which can be immediate, transient. Permeability immediately बढ़ी थोड़े से time के लिए. Immediate, transient. Immediate prolonged. Permeability immediately बढ़ी for longer time, immediate prolonged, and lastly delayed prolonged. So what we have seen is there are three mechanisms of increased permeability. They are immediate transient, immediate prolonged, delayed prolonged. These are the only three things which can happen. Which is the most common mechanism of increased permeability? Most common कौन सा है? पहले वाला, immediate transient, brought about by histamine, which increases the permeability, by endothelial contraction. इसने permeability कैसे बढ़ाई? It increases the permeability by endothelial contraction. Immediate transient, immediately बढ़ी थोड़े टाइम के लिए. Next is immediate prolonged, immediately बढ़ी ज़्यादा टाइम के लिए. क्यों? Because endothelium got burnt. It is associated with burns or endothelial damage because of bacterial or viral products. बच्चे अगर burn ही हो गया तो permeability immediately बढ़ेगी ज़्यादा टाइम के लिए, immediate prolonged. And lastly is delayed prolonged, which occurs because of sunburns or radiation injury. I am sure all of you would have been to beautiful beaches. Next, कोई बात नहीं. अच्छा, इसमें मैं एक चीज़ और बोलूँगा. Now that you have talked about the score केवल, coming back, this starts us with steps of inflammation. देखो, you already know what was happening in inflammation. Vasodilation. Blood vessel was dilating. So WBCs which are flowing in center of the vessel come to the margination. Then it starts rolling on the vessel wall. That is rolling. It's like a football rolling. Followed by permanent attachment. That is adhesion. Adhesion के बाद it is coming out of the vessel. What is it called as? Diapedesis. It comes out. Diapedesis, which is mediated by CD31 or PCAP. Diapedesis. After coming out, it has to go to the site of inflammation. What is migration of WBC to the site of inflammation called? Chemotaxis. After reaching the site of inflammation, it has to recognize that this is the microbe. Recognition of the microbe. Eat it up. Recognition of the microbe. Next, eat it up. Phagocytosis, phagolysosome formation and killing. These are the steps of inflammation. We'll do them one by one. Rolling से शुरू करते हैं. Rolling and adhesion. WBC vessel wall पे roll कर रहा है. मतलब एक WBC receptor is binding to an endothelial receptor. We will do the names. So what is the name of the WBC receptor? Rolling. But this occurs because of sialyl Lewis X glycoprotein. This table is important. इसमें दो diseases हैं. Please have a good look. WBCs have sialyl Lewis X glycoprotein, which binds to selectins on endothelial cells. कुछ भी नहीं है. Like all of us have names, these are the names of WBC receptor and endothelial receptor. Rolling leads to permanent attachment, that is adhesion, which is mediated by integrins present on WBC binding with integrin ligands or endothelial. Now it is important क्योंकि दो diseases हैं. Defect in adhesion is called as LAD1, leukocyte adhesion defect 1, versus defect in rolling, that is LAD2, leukocyte adhesion defect 2. Opposite है. Rolling पहले होती है followed by adhesion, but LAD1 is a defect in adhesion, LAD2 is a defect in rolling. दोनों में WBC receptor खराब है. So LAD1, this occurs because of a defect in integrins. LAD2 occurs because of a defect in sialyl Lewis X glycoprotein. दोनों में WBC receptor खराब है. Both of them are autosomal recessive in nature. We'll see that. Next point. Selectins, बच्चे, they were of three types. P-selectin, E-selectin, L-selectin. P-selectins, they are present on platelets and endothelial cells, versus E-selectins, which are present on endothelial cells. L-selectins are present on leukocytes. So selectins तीन टाइप के हो गए. E-selectin, L-selectin. Which plays a major role? In inflammation? Always the first one, that is P-selectin. पी सेलेक्टिव. सो अब मुझे देखो अनिरुद्ध, इतनी इंग्लिश नहीं आती, इंग्लिश प्रीमियर लीग मुझे नहीं पता, लाइफ में पिलना नहीं है. सो PEL विच प्लेज अ मेजर रोल, पी सेलेक्टिव. हमेशा फर्स्ट वाला इज द मेन वन फॉर इन्फ्लेमेशन, पी सेलेक्टिव. तो पिलना नहीं है, इन्फ्लेमेशन नहीं कराता, पी सेलेक्टिव. नेक्स्ट पॉइंट, आफ्टर रोलिंग एंड एडिशन विच इज द नेक्स्ट स्टेप, diapetesis. Diapetesis which is mediated by CD31 और PCAM. Diapetesis. उसके बाद chemotaxis. Very very important. Chemotaxis, it is migration of WBCs to the site of inflammation. तो chemotaxis बच्चे रैंडम है कि यूनिडायरेक्शनल है? यूनिडायरेक्शनल है. तभी तो इन्फ्लेमेशन तक पहुंचेगा. रैंडमली यहाँ वहाँ घूमता रहता है तो कभी इन्फ्लेमेशन तक जाता ही नहीं. इट इज यूनिडायरेक्शनल. इट इज यूनिडायरेक्शनल. Mediated by actin polymerization. मतलब cytoplasm has actin which polymerizes so the cell moves forward. Doesn't matter. अब point ये है that there are two chemotactic agents, two types of chemotactic agents, endogenous versus exogenous. Exogenous chemotactic agent are the bacterial or viral products. Wherever bacteria or virus is present, WBC will go there. Not important. What is very important are the endogenous chemotactic agents. Very, very important. Which complement protein? C3A, 3B, 5A, 5B. C5A. C5A. Leukotriene B4, LTB4. Interleukin 1, interleukin 8 and TNF alpha. Tumor necrosis factor alpha, TNF alpha. Which is very important. Which is the most potent chemotactic agent? मतलब chemotactic agents, opsonization agents, इसमें तो गलती करनी ही नहीं है. Which is the most potent chemotactic agent? Leukotriene B4. Complement protein में most potent है C5A, but overall most potent chemotactic agent Leukotriene B4. You already know most potent pyrogen जो fever कर रहा है, interleukin 1 followed by interleukin 6. ये तो हम सबको पता था. All of us knew this. Followed by PGE2. Followed by prostaglandin E2, PGE2. Very, very important. Recent NEET PG PYQ so can be asked in our paper. Interleukin 8 plays a major role in ARDS. Acute respiratory distress syndrome. Interleukin 8, ARDS versus TNF alpha. Tumor necrosis factor alpha, TNF alpha, which plays a role in sepsis. Sepsis is an infection of the whole body. These are the chemotactic agents. Now WBC has reached the site of inflammation. अगला step क्या है? Recognition of the microbe. It has to recognize this is the microbe. उसको क्या कहते हैं? Opsonization agents. Opsonization agents, बच्चे, they are the substances which make the bacteria tasty for phagocytosis. WBC has to recognize that this is the microbe. Opsonization agent. कैसे recognize करेगा? Which are the opsonization agents? They have mannose. Microbes, their cell wall has mannose. हम सब के ऊपर mannose नहीं है. Bacterial cell wall has mannose on it. So what is making the bacteria tasty? Mannose. Which complement protein? C3b. C5a is a chemotactic agent. C3b is an opsonization. C3b. FC fragment of IgG. CRP. C-reactive protein. CRP and fibrinogen. These are the opsonization. There is no way we can go wrong in chemotactic versus opsonization agent. बहुत important. बहुत ही important list. So, these are opsonization. Bacterial cell wall पे mannose था. Mannose, C3b, FC fragment of IgG. मतलब देखो, let us assume कि ये एंटीजन है. एंटीजन इज अटैच टू एंटीबॉडी. एंटीबॉडी के दो पार्ट हैं, फ्रैगमेंट एंटीजन बाइंडिंग और एफसी एंड. एफसी एंड वो टेल है. ये टेल किससे बाइंड करती है? इट बाइंड्स टू एफसी रिसेप्टर्स प्रेजेंट ऑन WBC. सो व्हाट इज मेकिंग द एंटीजन टेस्टी फॉर फेगोसाइटोसिस? WBC ने एंटीजन को कैसे खाया? विद द हेल्प ऑफ एफसी एंड, दैट इज एफसी फ्रैगमेंट ऑफ IgG. जस्ट अ वे टू रिमेंबर. इफ यू अंडरस्टैंड दिस डायग्राम, फेयर इनफ. इफ नॉट, कोई बात नहीं, अपन को याद रखना है. दीज आर द ऑप्सनाइजेशन. Now WBC is recognized, this is the microbe. Next step, it is going to eat it up, phagocytosis, phagolysosome formation and killing. Killing occurs by three pathways. That is the NADPH oxidase, also called as the phagocyte oxidase pathway, lysosomal enzymes, and nitric oxide synthase, NOS pathway. So there are three pathways of killing. NADPH oxidase or the phagocyte oxidase pathway, lysosomal enzymes and nitric oxide synthase. Main pathway कौन सा है? हमेशा पहले वाला, NADPH oxidase pathway. What happens is oxygen is acted upon by NADPH oxidase, leading to the formation of superoxide anion. उसने O2 minus बनाया, superoxide anion. This superoxide anion is acted upon by superoxide dismutase, SOD. SOD मतलब superoxide dismutase. It is acted upon by superoxide dismutase, leading to the formation of H2O2, hydrogen peroxide, leading to the formation of H2O2, which is acted upon by myeloperoxidase, MPO, myeloperoxidase and chloride, leading to the formation of hypochlorous anion, HOCl. This is NADPH oxidase. तो क्या हुआ? ऑक्सीजन था, NADPH oxidase acts on it, leading to superoxide anion. Superoxide dismutase converts it into H2O2, myeloperoxidase and chloride, hypochlorous. तो मुझे सबसे पहले तो ये बता दो, which free radicals are formed by NADPH oxidase pathway? कौन से फ्री रेडिकल बने? सुपरऑक्साइड एनायन एंड हाइपोक्लोरस एनायन. फ्री रेडिकल मतलब जिसमें माइनस है ना, अनपेयर्ड इलेक्ट्रॉन है. दो फ्री रेडिकल बने, सुपरऑक्साइड एनायन एंड हाइपोक्लोरस. नेक्स्ट, recent FMG PYQ, superoxide dismutase is pro-oxidant या antioxidant? I want all of you to tell me this. Superoxide dismutase, which is recent PYQ था, it is pro-oxidant या antioxidant? वो क्या कर रहा है? It is converting superoxide anion, it is converting O2 minus to H2O2. तो वो एक free radical को remove कर रहा है, leading to the formation of H2O2. Catalase will act on H2O2, leading to H2O plus O2. So it is an partial antioxidant. It is a partial antioxidant. Both nahi, it is an antioxidant. Pinky agreed. It is a partial, Laki, Teki agreed. It is an antioxidant. Partial इसलिए बोला because H2O2 के बाद catalase will act on it, leading to H2O plus O2. Agreed. This is the NADPH oxidase pathway. Second pathway is nitric oxide synthase pathway. तीन टाइप का है. Endothelial nitric oxide synthase, neuronal nitric oxide synthase and inducible nitric oxide synthase, INOS. Which plays a major role in inflammation? 1, 2, 3. फिर से you guys tell me. तुम बताओ. Which plays a major role in inflammation? Endothelial, neuronal, inducible. 1, 2, 3. 3. देखो बच्चे, I know normally here the answer is endothelial, but सबको पता है कि blood vessels में endothelial nitric oxide, it is a vasodilator. Neuronal acts as neurotransmitter. Inducible, नाम बता रहा है, I से inducible, I से inflammation. It is getting induced, it is getting activated in inflammation. वो उसमें एक्टिवेट हो रहा है. इट इज गेटिंग इंड्यूस्ड एंड एक्टिवेटेड इन इन्फ्लेमेशन. आई था ना इन्फ्लेमेशन, लीडिंग टू द फॉर्मेशन ऑफ ONOO माइनस, लीडिंग टू द फॉर्मेशन ऑफ peroxynitrite free radical. This is nitric oxide synthase pathway. I know majority of us go wrong in this question, so टेंशन नहीं लेनी. अब याद रख लेंगे, I से इंड्यूसिबल, I से इन्फ्लेमेशन. And the last pathway of killing, last pathway being lysosomal enzymes. Lysosomal enzymes are तीन type के granule हैं, primary, secondary, tertiary. Primary are eosinophilic granules, which are myeloperoxidase and proteinase 3, versus secondary or the specific granules, that is ALP, alkaline phosphatase. ALP, alkaline phosphatase. Tertiary granules are the gelatinases. First class. So this takes care of components and steps of inflammation. बच्चे हम लोगों के दो टॉपिक हो गए एक्यूट इन्फ्लेमेशन में, components and steps of inflammation. I'm going faster in this because we'll be covering a lot of content in our this crash course thing. I sincerely hope that you are comfortable with the speed of the session and all the content. Next, so अब हम आते हैं diseases of inflammation. Important topic है, 4 diseases हैं. तुम्हें पहली दो LED1 और LED2 तो पता ही है. LED1 is a defect in addition. क्या प्रॉब्लम थी? Remember WBC receptor में it was a defect in integrin. कौन सा integrin? It is a defect in beta 2 integrin. Remember LED1 and LED2. Let me show it to you. दोनों में प्रॉब्लम कहाँ थी? WBC receptor में. LED1 was a problem in addition because of a defect in beta 2 integrin. LED2 is a defect in rolling. Why? Because of a defect in CLI Lewis X like. ठीक है ना? So LED1 it is a defect in beta 2 integrin. ठीक है, मान लिया. So clinically अगर addition ठीक से नहीं हो रही, so it is associated with increased risk of infections. Obviously you will have a history of a child. Examiner ना कभी भी increased risk of infection नहीं लिखेगा. He will give you a classical clinical history of a 6-year child who had 3 episodes of strep pneumonia last year, now presenting to the OPD with otitis media. मतलब there is increased risk of infections with delayed separation, of umbilical cord stump. This is LED1. Leukocyte addition defect 1 LED1 versus LED2, which was a defect in rolling. Remember LED1 and LED2 both were autosomal recessive. It was a defect in CLI Lewis X glycoprotein. ठीक है, मान लिया. Clinically associated with increased risk of infections. Obviously rolling ठीक नहीं हो रही तो there is increased risk of infections along with mental retardation and Bombay phenotype. Dinesh totally agreed, dost. Along with mental retardation and Bombay phenotype. This is LED2, leukocyte addition defect. LED2. ये ना हमें याद रखना है. LED1 was delayed separation of umbilical cord stump versus LED2, which is mental retardation and Bombay phenotype. Next, and a very important disease of inflammation being Celiac Higashi syndrome. CHS, Celiac Higashi syndrome, which is a defect in phagolysosome formation. Phagocytosis हो गया, but this phagocytosed material is not able to bind to lysosome. It is a defect in phagolysosome formation. Why? Because of a defect in lysosomal transport protein called as LEST protein. Because of a defect in LEST protein. Phagocytosis हो गया, but it was not able to bind to lysosome. Defective phagolysosome formation because of a defect in LEST protein. Disease का क्या नाम है? Celiac Higashi syndrome. So it is associated with CHS1 gene mutation present on chromosome 1. CHS1 chromosome 1. Most characteristic feature क्या है? You tell me. Phagocytosis हो गया, but phagolysosome नहीं बना. So this toxic material is present as such. Most characteristic feature is the presence of giant granules and neutrophils. Neutrophils ने ये toxic matter खाया, but lysosome नहीं बना. So it is present as giant granules and neutrophils. Versus most common feature क्या है? तुमने किसी से पंगा लिया, thinking you will beat the person. Neutrophil ने toxic matter खाया, thinking it will kill that. But phagolysosome ही नहीं बना. So this toxic matter now kills the neutrophil. Most common feature being neutropenia. Neutrophils reduce in number. Please put a star. Very, very important. It is next. It is also associated with albinism. First class. This was Celiac Higashi syndrome, defect in phagolysosome formation, Celiac Higashi syndrome. And lastly, the last disease of inflammation being CGD, chronic granulomatous disease. CGD, chronic granulomatous disease, which is a defect in killing. It is a defect in killing. Which was the main pathway of killing? NADPH oxidase pathway. It is a defect of NADPH oxidase pathway, and this is X-linked recessive in nature. So first three diseases were autosomal recessive, LAD1, LAD2, Celiac Higashi syndrome, autosomal recessive. अपना जो लास्ट वाला है CGD, chronic granulomatous disease, X-linked recessive. First class screening test, NBT, nitroblue tetrazolium test. X-linked recessive screening, nitroblue tetrazolium test, NBT test for CGD, chronic granulomatous. Perfect, dosto, perfect. So this finishes components, steps and diseases of inflammation, and this gets us to the other side, that is inflammatory mediators. Inflammatory mediators के बाद अपना ना acute inflammation खत्म हो जाएगा. Inflammatory mediators. Which is the main inflammatory mediator? Arachidonic acid metabolite. Arachidonic acid, this is something you study everywhere. Biochemistry, path, pharma, medicine, physio, everywhere. Arachidonic acid metabolism के दो pathway हैं. COX, cyclooxygenase pathway, and LOX, lipoxygenase pathway. There are two pathways, COX and LOX. Cyclooxygenase pathway से शुरू करते हैं. वो तीन मेटाबोलाइट बनाता है. Prostaglandins, that is PGD2E2, prostaglandins, prostacyclins, that is PGI2, and thromboxanes, TXA. तीन मेटाबोलाइट बनाए. अब सबसे पहले मुझे बताओ, thromboxane, थ्रोम्बस बनाएगा. So it causes vasoconstriction. It causes vasoconstriction and increases platelet aggregation. उसने तो थ्रोम्बस बनाना है ना, thromboxane थ्रोम्बस बनाएगा. So it causes vasoconstriction and increases platelet aggregation. Versus बाकी दोनों, prostaglandins and prostacyclins, इनका opposite role है. They cause vasodilation and reduce platelet aggregation. They cause vasodilation and reduce platelet aggregation. Recent NEET PGPYQ, which of the following is associated with vasodilation? Prostaglandins, prostacyclins, thromboxanes, both A and B. Answer to be marked was both A and B. This is COX, cyclooxygenase. And the next pathway of arachidonic acid metabolism is LOX, lipoxygenase pathway, जिसने फिर से तीन मेटाबोलाइट बनाए. Leukotriene B4, which is the most potent. I want you to tell me this. Leukotriene B4 is the most potent chemotactic agent या opsonization agent? It is the most potent chemotactic agent. It is the most potent chemotactic agent. Leukotriene C4D4E4 play a role in asthma. Asthma में क्या होगा? It causes bronchoconstriction. It causes bronchoconstriction and increased mucus secretion. Bronchoconstriction and increases mucus secretion. This is what happens in asthma. Bronchoconstriction हो रही है, the patient is coughing a lot. Mucus secretion बढ़ रही है. Most important बच्चे है lipoxins. Please put a star. Repeatedly asked. Lipoxins, they are anti-inflammatory in nature. Very, very important. जब भी हम लोग इन्फ्लेमेशन की बात करते हैं, वी ऑलवेज टॉक ऑफ प्रो इन्फ्लेमेटरी मीडिएटर्स. जो इन्फ्लेमेशन कर रहे हो, तीन एंटी इन्फ्लेमेटरी हैं. कौन कौन से? दे आर इंटरल्यूकिन 10, TGF beta, transforming growth factor beta, TGF beta. This times NEET PGPYQ, please put a very good star on this. Chances are very high TGF beta अपने पेपर में भी आएगा. Interleukin 10, TGF beta and lipoxins. These three are anti-inflammatory in nature. They are interleukin 10, TGF beta. Whereas both pro एंड एंटी इन्फ्लेमेटरी, जिसके दोनों रोल हैं प्रो एंड एंटी इन्फ्लेमेटरी, इज इंटरल्यूकिन 4 एंड इंटरल्यूकिन 6. They are both pro and anti. This was arachidonic acid metabolite. अपने दो पाथवे थे, COX cyclooxygenase pathway and lipoxygenase pathway. अपने दो pathways थे arachidonic acid metabolite. Next inflammatory mediator कौन सा है? ये वाली slide important थी. I'm again saying this. Anti-inflammatory mediators which are very, very important. Next, the next inflammatory mediator being cytokines. We can divide cytokines into two types, acute versus chronic. Asha, you tell me this. Acute cytokines will play a role in activation of which cell? Which is the cell of acute inflammation? Acute cytokines कौन से cell को activate करेंगे? Main cell being neutrophils versus chronic cytokines. Chronic cytokine, which is the main cell of chronic inflammation. Macrophages. They play a role in macrophage activation. So chronic cytokines, which they are associated with which hypersensitivity? वो कौन सा hypersensitivity reaction कराते हैं? देखो 4 main hypersensitivities है ना. 1 तो हो गई asthma allergy immediate type. 2 antibody mediated. 3 antigen antibody immune complex. 4 सेल mediated और delayed type. नाम ही बता रहा है it is associated with cell mediated और delayed type. Delayed है ना, chronic hypersensitivity है, cell mediated और delayed type of hypersensitivity. So chronic cytokines, macrophages activate करते हैं. Cell of acute inflammation neutrophil, cell of chronic inflammation macrophage. Simple. Cell of chronic inflammation macrophages followed by T cells. बच्चे ये point ना important है. Chronic inflammation causes which hypersensitivity? Type 4. Type 4 hypersensitivity, that is cell mediated or delayed type of hypersensitivity. Which are the chronic cytokines? So it is associated with type 4 hypersensitivity. And which are the chronic cytokines? They are interleukin 2, 12 and interferon gamma. Chronic cytokines कौन से हैं? Interleukins 2, 12 and interferon gamma. Versus which are the acute cytokines? Interleukin 1, 6, 8 and TNF. These are the acute cytokines. So this is acute versus chronic. The cytokines associated. Next, the next inflammatory mediator being the complement pathways. अपने 3 main complement pathways हैं. There are 3 complement pathways: the classical, alternative and Mannose lectin binding pathway. 3 complement pathway. Classical pathway, बच्चे, it starts from C1, activates C2 and C4, goes to C3, C5 and MAC, membrane attack complex, MAC. I'll repeat. Classical pathway C1 से शुरू हुआ, activates C2 and C4, goes to C3, C5 and MAC. MAC is membrane attack complex. MAC किससे composed है? Recent PYQ. What is MAC? Membrane attack complex C5 A या B? C5B to C. C5B 6, 7, 8, 9. C5B to C9. Recent FMGE PYQ. C5A is a chemotactic agent versus C5B, which is a part of MAC, membrane attack complex. This is the classical pathway. बाकी दोनों alternative and Mannose lectin binding pathway, they converge on C3. So you tell me this, कौन से complement protein का defect most severe होगा? Most severe will be deficiency of, where is everything converging? C3. Most severe defect is C3 deficiency. Most common is C2. Doesn't matter. Most severe C3. Dinesh Nirisha agreed. Most severe C3. Early complement defects. Early complement कौन से हुए? C1, C2, C4. These are the early complement. Increase the risk of SLE. Early complement protein defects increase the risk of SLE. Main question है late complement protein defects. Late complement protein क्या है? Deficiency of MAC. That is C5B to C9. What was MAC? C5b to C9, C5b, 6, 7, 8, 9 increases the risk of infections by Neisseria and toxoplasmosis. बच्चे बहुत इंपॉर्टेंट है, बहुत ही इंपॉर्टेंट है. लेट कॉम्प्लीमेंट प्रोटीन डिफेक्ट्स. लेट कॉम्प्लीमेंट प्रोटीन है मैक, increases the risk of infection by Neisseria and toxoplasmosis. Next, again put a star. C1 esterase inhibitor deficiency. C1 esterase inhibitor deficiency causes HAE, hereditary angioneurotic edema. इंपॉर्टेंट है, बहुत रेयर कंडीशन है बट इंपॉर्टेंट है. इट इज एसोसिएटेड विथ हेरिडिटरी एंजियोन्यूरोटिक एडिमा. C1 esterase inhibitor deficiency causes HAE, hereditary angioneurotic edema. And lastly, deficiency of CD55 and 59 as PNH, paroxysmal nocturnal hemoglobinuria. PNH. Nisha agreed, Dinesh Jani agreed. HAE and 20. Perfect. So this takes care of acute inflammation, the components, the steps and the diseases and inflammatory mediators associated. अपने चारों टॉपिक acute inflammation के हो गए. Next point, neutrophil extracellular traps. So this gets us to net, that is neutrophil extracellular. देखो, the name tells you everything. Neutrophil trap हो रहे हैं extracellularly. Neutrophil extracellular traps. Neutrophil क्यों trap हो रहे हैं? It is seen at sites of inflammation और sepsis, जहाँ पे बहुत ज़्यादा infection हो रहा है. Seen at sites of infection or sepsis. Inflammation की जगह भी let us write it as infection. It is seen at sites of infection or sepsis. Body कोई भी काम करती है ना, any place where body works, body अच्छा काम करना चाहती है. Infection हुआ है, body wants कि neutrophils come there and they stop the infection. So it is a body's response against infection seen at sites of infection or sepsis. But the problem is when neutrophils are fighting the infection, neutrophils also get killed. So the DNA of neutrophils, the nuclear DNA, this was recent NEET PG PYQ. कौन सा DNA फंस रहा है? Nuclear DNA of neutrophils. This gets entrapped. ये फंस जाता है. This gets entrapped in fibrillary meshwork. देखो इसका नाम यही है. न्यूट्रोफिल ट्रैप हो रहे हैं. न्यूट्रोफिल extracellular traps. Neutrophils are getting entrapped in fibrillary meshwork. Neutrophils were fighting the infection, but neutrophils also got killed, so they get entrapped in fibrillary meshwork. So what is the problem because of this? This nuclear DNA acts as site of autoimmune antibody formation. Which is the most common autoimmune antibody? ANA, anti-nuclear antibody. तो न्यूक्लियस के अगेंस्ट एंटीबॉडी कैसे बनी? क्योंकि न्यूक्लियर डीएनए फंस गया था, न्यूक्लियर डीएनए एंट्रैप हो गया था फिब्रिलरी मेशवर्क में. न्यूट्रोफिल एक्स्ट्रासेलुलर ट्रैप्स. Recent PYQ NEET PG segment. It has not been asked in FMG till now. I talked about this because Keval said it. Bruton's X-linked A gamma globulinemia, बच्चे will do it in immunity. अभी नहीं. So this was net. First class. So this finishes acute inflammation, and this gets us to the other side, that is chronic inflammation. Chronic inflammation हमें बहुत अच्छे से पता है. Which is the main cell of chronic inflammation? Macrophages followed by T cells. Which T cell help in granuloma formation? Helper T cell. CD4 positive मतलब helper T cell help in granuloma formation. ये चीज़ हमें पता है. पूछा भी जाता है और हमें पता भी है. They help in granuloma formation. So main cell of chronic inflammation is macrophages followed by T cells. Macrophages of the kidney, they have a special name to it called as mesangial cells. Macrophages of liver, recent PYQ, Kupffer cells. सबको पता है. Kidney, mesangial cells, liver, Kupffer cells. Liver का पता नहीं क्यों पूछा भी गया था. Macrophages of the blood, monocytes. Macrophages of the blood, monocytes. ये तीन हमें पता थे. ब्लड में तीन ही तो सेल हैं, 3-4. लिम्फोसाइट, मोनोसाइट, न्यूट्रोफिल, बेसोफिल, इओसिनोफिल. मैक्रोफेज कौन सा है? मोनोसाइट. मैक्रोफेजेस ऑफ द स्प्लीन, littoral cells. Macrophages of the spleen, littoral cells. Littoral cells versus placenta of Bayer cells. देखो हमें प्रेगनेंसी से हॉफ है, डर लगता है ना, हॉफ है. So macrophages of the placenta, of Bayer cells. No double meanings. Of the CNS, microglia. Please, a common mistake we do is we say it as glial cells. Macrophages of the CNS, which is glial cell नहीं है. It is microglia. It is microglia. These are the fancy names of macrophage. Followed by giant cells. अब macrophages कैसे activate होते हैं? By cytokines. Chronic cytokines कौन से थे? Interleukin 2, 12, interferon gamma. ये तो हमें पता ही है ना. These are the chronic cytokines. Macrophages कौन से hypersensitivity reaction में role play करेंगे? 1, 2, 3, 4. I want everybody to tell me this. You know this. We have just covered it. Macrophages will play a role in which hypersensitivity? Chronic. That is cell-mediated or the delayed type of hypersensitivity. They play a role in type 4 hypersensitivity. You know this. Chronic cytokines थे interleukin 2, 12, interferon gamma, and they play a role in type 4 hypersensitivity. Perfect. These was macrophages. Next cell of chronic inflammation is giant cells. Giant cells, इसकी फटाफट से images भी देख लेते हैं. Cell with multiple nuclei is called giant cell. तो giant cell दो टाइप के हो गए, physiological, pathological. Physiological giant cell of the bone is osteoclast या clast? Osteoclast. Physiological giant cell. Physiological giant cell of the bone, osteoclast. Bone marrow. Bone marrow में 3 सेल हैं, RBC, WBC, platelet. Platelet कौन बनाता है? Megakaryocyte. It is a giant cell. It is a giant cell of the bone marrow. Megakaryocyte. Megakaryocyte. Which is a giant cell of the placenta? अच्छा मुझे ये बताओ. You tell me this. A 19-year-old unmarried girl comes to your OPD with secondary amenorrhea. She comes with her mother and is suffering from secondary amenorrhea. Which is the next test you will perform? Secondary amenorrhea means the girl was bleeding earlier, now she is not. Which is the next test you will perform? She is unmarried. तो यूरिन प्रेगनेंसी टेस्ट यूपीटी कराएंगे कि नहीं? कराएंगे. मैरिटल स्टेटस has nothing to do with UPT firstly. So which hormone do we test in UPT? Beta HCG, secreted by syncytiotrophoblast. Syncytiotrophoblast. Syncytiotrophoblast are the ones which secrete beta HCG, human chorionic gonadotropin, which is detected by urine pregnancy. नाम ही बता रहे, प्लेसेंटा में 2 सेल हैं, साइटोट्रोफोब्लास्ट विच आर यूरिन्यूक्लिएट एंड सिंसिशियोट्रोफोब्लास्ट. वो सिंसिशियम से बने हैं, सेल्स के ज्वाइन होने से. दीज आर फिजियोलॉजिकल. पैथोलॉजिकल, टीबी से शुरू करते हैं. व्हाट इज द फैंसी नेम ऑफ जाइंट सेल सीन इन टीबी? लैंगहैंस जाइंट सेल. टीबी लैंगहैंस जाइंट सेल. लैंगरहैन मत बोलना, टीबी लैंगहैंस. मल्टीपल न्यूक्लिया अरेंज्ड एट पेरिफेरी गिविंग इट horseshoe shaped appearance. TB Langerhans. मीजल्स के जाइंट सेल का क्या नाम है? Waldenfinkel जाइंट सेल. TB Langerhans, मीजल्स, Waldenfinkel जाइंट सेल. नेक्स्ट, xanthogranulomatosis रिएक्शंस. xanthogranulomatosis रिएक्शंस में कौन सा जाइंट सेल मिलता है? टाउटन जाइंट सेल. xanthogranulomatosis रिएक्शंस तो टाउटन जाइंट सेल. टाउटन जाइंट सेल में बहुत सारा फोमी साइटोप्लाज्म होता है. टाउटन जाइंट सेल. RS सेल, रीड स्टर्नबर्ग सेल, सीनन, हॉजकिन्स लिम्फोमा. ये तो मुझे बोलने की भी जरूरत नहीं है, हॉजकिन्स लिम्फोमा. It is a large cell which is binucleate. दो nuclei हैं with prominent pink nuclei, giving it owl-eye appearance. Hodgkin's lymphoma. Recent FMG PYQ. Owl-eye appearance other than Hodgkin's lymphoma is also seen in which infection? Cytomegalovirus, CMV. You and me, we will not get cytomegalovirus infection. ये opportunistic infection है. Immunosuppressed individuals में होता है. Which is the most common site of CMV infection? Lungs. So CMV pneumonia. CMV pneumonia. So owl-eye appearance. बच्चे एक तो RS cell, Reed Sternberg cell, Hodgkin's lymphoma, and दूसरा CMV pneumonia. Difference ये है. The difference is in Hodgkin's lymphoma, they are eosinophilic nuclei. Cytomegalovirus has basophilic, blue color के nuclei होते हैं. It has basophilic nuclei or inclusions. Basophilic inclusions लिख लेते हैं. They have basophilic blue colored inclusions. So these are the giant cells. तो मुझे फटाफट से diagnosis बताते जाओ. Tell me the diagnosis. Starting with the first image. देखो giant cell है ना. Multiple nuclei arranged at periphery. Horseshoe shaped appearance. Langerhans giant cell TB. Langerhans giant cell TB. Next. HSV has on Zank smear shows the presence of multinucleate giant cells. That is Zank smear. Next, अच्छा मुझे ये बताओ, recent FMG PYQ, you had a history of a young male presenting to the OPD with bony swelling. X-ray findings were given. There was periostal reaction, this, that. एक दो X-ray finding दे दी थी, fever दे दिया था. Histopathological image shows this. Diagnosis: osteosarcoma, giant cell tumor of the bone, enchondroma, chondrosarcoma. Actual question. Diagnosis: giant cell tumor of the bone. This was not a question from ortho. ये general path का question था. You are able to see giant cell. ये giant cell है जिसके nuclei are exactly the same as that of tumor cell. Giant cell tumor of the bone. Perfect. These were giant cell. Next, ये तो मुझे बताने की भी ज़रूरत नहीं है. owl-eye appearance, RS cells, Reed Sternberg cells, RS cells, Hodgkin's lymphoma. Other than this, it is also seen in CMV pneumonia. RS cell के marker बता दो. Tell me the markers associated with RS cells. They are CD 1530. They are 15 positive, 30 positive. 1530. Other than this, it is also seen in CMV pneumonia. You know this, owl-eye appearance. Next question, they are CD 1530 positive. Next, again, the minute I see this slide, I'm very comfortable with the fact कि ये Langerhans giant cell है. They have horseshoe shaped appearance, Langerhans giant cell. और ये जो center में necrosis हो रहा है, all this is caseous necrosis. All this is caseous. Caseous necrosis, Langerhans giant cell, again making the case as TB. This is TB, tuberculosis. And lastly, chronic inflammation, the abnormality is associated. What do you see here? This is excessive scarring beyond boundaries of the wound. That is keloid. Beyond boundaries, it is keloid. More commonly seen in blacks, that is genetically predisposed individuals, more commonly seen in Africans. Most common site being sternum or the chest, followed by earlobes. Most common site being sternum or the chest, followed by earlobe. क्योंकि Africans में even males go for ear piercings ना, so this is keloid. Excessive scarring beyond boundaries of the wound, keloid. Versus, now have a look at this. Excessive scarring limited to boundary of the wound, that is hypertrophic scar. What is the first thing you are going to say to this patient? Don't worry, life is going to be much better than expected. Most probably this is a self-inflicted wound, hypertrophic scar. इसमें scarring is limited to boundaries of the wound. This was beyond the boundary. Keloid and hypertrophic scar. Next, ये देख के ही पता चल रहा है that this is not a scar. This is excessive. This is exuberant granulation tissue. Excessive granulation tissue. Exuberant granulation tissue or proud flesh. The problem in this is excessive granulation tissue which is above the level of surrounding skin. देखो देख के ही पता चल रहा है, it is above the level of the skin. So this prevents reepithelialization. It is above the level of surrounding skin. So it prevents reepithelialization. Exuberant granulation tissue or proud flesh. And lastly, diagnosis, contractures. Contractures which are associated with burns and which this limits joint mobility. We are able to move our wrist joint. यहाँ पे the patient is not able to move the wrist at all. This limits joint mobility, burns. Will it be painful? No, this is a 3rd degree burn. Won't be painful at all. All the nerve endings, everything is gotten first class. So this finishes acute and chronic inflammation along with the abnormalities. So we are done with our 2 main topics in general path: cell injury, inflammation. Before we wrap up inflammation and go to our next topic, that is genetics, which is miscellaneous topic है, collagen and stains used in pathology. So before we start with types of collagen, देखो हर बार ना इसमें से क्वेश्चन आता है types of collagen, stains and fixators. Before we start with that, and then we'll go to genetics, pedigree chart analysis, percentage analysis. Let's do it with a fresh mind. So let's start with our next set of extremely important session. The next 40 minutes you get lots of questions from this session. That is, we'll have a look at types of collagen, following it up with genetics, the pedigree chart and the percentage chart analysis. Percentage analysis, you always get questions on that. So starting first with the miscellaneous topics, that is the types of collagen. 5 main collagen hai. Type 1 collagen, which it is present in skin, bone and cornea. It is the most common collagen. Type 1, it is the most common collagen in the body. Next, bone में है ना, so it is the most common constituent of organic या inorganic bone. Organic bone. It is the most common constituent of organic bone. Inorganic is the calcium phosphate minerals. It is the most common constituent of organic bone and has a high or low tensile strength. High क्योंकि bone में है, so it has more strength. It has a high tensile strength. Type 1 collagen. Type 2 collagen, syn cartilage. देखो, if we just write it with slight spelling error, you will never go wrong in it. Cartilage and vitreous humor of eye. Cartilage and vitreous humor of eye. That is type 2 collagen. Bone is type 1, cartilage type 2. Granulation tissue, type 3 collagen. Granulation tissue, type 3. Remember the last time you were hurt physically? Emotionally तो we get hurt every day only. Physically, first there is scab formation. एक वो पतली सी पपड़ी बनती है, scab. Next, neutrophils come in, then macrophages, and then healing starts. That is, it is associated with soft red granulation tissue formation. That is type 3 collagen. And when granulation tissue progresses to scarring, granulation tissue is soft and red. Scarring is firm. Scarring which has type 1 collagen. Scarring, which collagen had the maximum tensile strength? Type 1. So 1 was in skin, bone, cornea. It was the most common collagen in body. Cartilage, type 2. Granulation tissue, type 3. Granulation tissue progresses to scarring. Type 3 collagen is replaced by type 1. Type 4 collagen is the fine collagen, which is seen in basement membrane. Type 4 collagen, वो कहाँ मिलता है बच्चे? It is seen in basement membrane and islands. Basement membrane and islands. Type 4 collagen. And lastly is type 5 collagen, which is seen in placenta. Easy to remember. Whatever you do in life, don't have more than 5 affairs. So type 5 collagen, placenta. These are the types of. So eye में 3 थे. 1 cornea, 2 vitreous humor of eye, 4 eye lens. These are the types of collagen you need to know. Next point. This gets us to our next topic in miscellaneous topics, that is the stains used in pathology. पहले kidney से शुरू करते हैं. Which is the stain of choice for renal diseases? Which is the most useful renal stain? Periodic acid shift. Pass. Most useful. If I have to use one stain in kidney, I will use periodic acid shift. Pass. In kidney, बच्चे it stains glomerular basement membrane. In kidney, other than glomerular basement membrane, it also stains mesangial matrix. It is the most useful renal stain. मान लिया. In liver, it stains glycogen. I did not write glycogen in kidney because glycogen is not seen in kidney. In liver, it stains glycogen. In GIT, which infectious disease is stained by pus? Whipple's disease. Extremely important. Please put a star. In GIT, periodic acid shift pus is used for staining of Whipple's disease. In blood cancer, which blasts are stained by periodic acid shift? Lymphoblast या myeloblast? Lymphoblast. Lymphoblasts are pus positive. That is, it is seen in ALL, acute lymphoblastic leukemia. Myeloblasts are myeloperoxidase and Sudan black B positive. We'll see that. So most useful renal stain, nobody is going to ask you what it stains in kidney. It is the most useful renal stain. Liver में glycogen, GIT Whipple's disease, blood cancer में AL, periodic acid shift, pass. Next category of stains are the liver stains, hepatic stains. For bile, we use modified Faucett stain. Bile, modified Faucett. Even if you don't remember it, I am okay. Calcium, बहुत important है. The most common stain for calcium is von Cosa stain. Easy to remember, calcium को कोसा. Most common von Cosa. Calcium को कोसा. But the most specific stain for calcium being alizarin redis. वो जरा से calcium को भी stain करता है. Most specific alizarin redis. Calcium. Next is fat. For fresh or the frozen section, fat, बच्चे we use oil redo versus fixed fat. Fixed fat, the stain used is Sudan black. So again, I am laying a lot of emphasis on this. See the question carefully. Fresh fat food पूछा. Fresh is the frozen section. Oil redo, fixed Sudan black. Fat. Next, for mucins, we use Alcian blue. Recent NEET PGPYQ. Alcian blue. Next, you have already told me for iron. You have told me this iron. We use Prussian blue or pearl stain. Prussian blue or the pearls. Girls, you wear necklaces made of pearl. For melanin, you have already told me melanin, Mason Fontana stain. What is excessive copper deposition in body called as? Wilson's disease. That is ATP7B gene mutation present on chromosome 13. What is ATP7A gene mutation? All these are recent PYQs. Menkes disease. ATP7A, Menkes disease. ATP7B, Wilson's disease, chromosome 13. For copper, stain used or seen and modified rhodamine stain. I'm again saying this, I'm not here to increase your knowledge. I'm here to make sure that you pass this paper, and bache, all these are the questions which are asked in your pathology FMGE exam. You need to know this. Next point. So mucins, Alcian blue. Iron, Prussian blue or the pearl stain. Copper, or seen or the modified rhodamine stain. Next, which is the most characteristic stain for amyloid? For amyloid, we use Congo red. I'll be very glad if you tell me what is the color of amyloid with Congo red. Extremely important. Yellow, red, apple green, or blue. What is the color of amyloid with Congo red? Congo red other stains are PAS, periodic acid shift and thioflavin T. With thioflavin T, amyloid is yellow on immunofluorescence. ठीक है, मान लिया. I'm sure you know Congo red has apple green birefringence under polarized light with Congo red. What is the color of amyloid? You wrote both red and green, but the answer to be marked. When color is being asked, the examiner is talking of light microscopy. He's not talking of polarizing microscope. The normal light microscope, वो जो ऐसे करके देखते हैं नीचे बल्ब जल रहा होता है, that is light microscopy. The color of amyloid with Congo red being salmon red or brick red in color. That is amyloid. It is red in color. It is red. Simran Bache, your answers were all wonderful, but this was the first answer you went wrong in. Apple green is the birefringence under polarized light. So till the time examiner is not talking about polarizing microscopy, अगर color की बात हो रही है ना, light microscopy की बात हो रही है, amyloid is red in color with Congo. These are the stains used in pathology. Last time's FMGE PYQs, silver stains are used for spirochetes. They are used for silver impregnation technique, spirochetes, fungi, H. pylori, all of the above. For fungi, we use grocotes or Gomorrhees methenamine silver stain. Grocotes or Gomorrhees methenamine silver stain. Versus H. pylori, Helicobacter pylori, Waldenstari stain. You know this. Spirochetes, silver impregnation technique. Spirochetes. Other than this, so answer to be marked was all of the above. Silver stains, which is the most common cause of dementia in elderly? Alzheimer's disease. Silver stains, they are also used for Alzheimer's disease. These are the stains used in pathology. So calcium, von Cosi alizarin redis, fat, oil red or Sudan black, silver stains, fungi, H. pylori, Alzheimer's disease, spirochetes, iron, copper, amyloid, and these are the stains used in pathology. Most commonly used stain or the most single stain or the stain of choice for renal biopsies, PAS, periodic acid shift. You know that. These are the stains used. These were the types of collagen. And lastly, this gets us to the fixatives used in pathology. When you visit a path lab, we have a bad smell that is coming because of the fixative. Which is the most commonly used fixative for light microscopy? Formalin. That is, we use 10% formaldehyde. Versus for electron microscopy, glutaraldehyde. Next, two recent PYQs. Screening test of choice for cervical cancer. Pap smear, Papa-Nicolau smear, Pap smear. Fixative used, guys, easy to remember. Alcohol, Pap smear. Kitna percent? 95% ethyl alcohol. Alcohol, Pap smear, that is 95% ethyl alcohol. Next question, this was first one. Next PYQ was, which is the cost-effective method for screening cervical cancer? Cost-effective method for cervical cancer. All these are recent PYQs. Answer? Pap smear में क्या हो रहा है? Patient went to obs-gynae. Obs-gynae took a smear from squamocolumnar junction, put it on a slide, and pathologist saw it. So there are two doctors, obs-gynae and path. You have to remove one doctor. Whom will you remove? Obs-gynae को हटाओगे कि path को? I know, we poor pathologists, we are the ones removed. Patient goes to obs-gynae. She puts acetic acid and sees if there is a white patch or not. Visual inspection by acetic acid, VIA. That was the answer to be marked. Visual inspection by acetic. Is it a good method or a bad method? It's bad because by the time it is visible to the naked eye, cancer has already metastasized. So अगर इस पे white patch आ रहा है, then we go for a biopsy. VIA was the answer to be marked. First class. So बच्चे, this finishes cell injury, inflammation, and the miscellaneous topics associated with pathology. And this gets us to our next extremely important topic in path, that is genetic. Genetic diseases 4 टाइप की हो गई. Mendelian inheritance, that is autosomal recessive dominant. X-linked recessive dominant. Mendelian inheritance. Non-Mendelian inheritance, which is of 3 types. Genomic imprinting, trinucleotide repeats, and mitochondrial inheritance. Non-Mendelian inheritance, it is of 3 types. Genomic imprinting, trinucleotide repeats, and mitochondrial. We'll do it one by one. Lastly, chromosomal abnormalities, which can either be in number or structure of chromosomes. The last category of genetic diseases being multifactorial inheritance. Multifactorial means multiple factors play a role. Genetics plus lifestyle. So coronary artery diseases, myocardial infarction, hypertension, atherosclerosis, all these are multifactorial. Lifestyle. Girls, bache, you found your soulmate. You got married also and are planning to have a baby. Which tablet will you take prior to conceiving? I'm very curious. Which tablet is taken prior to conceiving? Folic acid. It is taken 3 months prior to conceiving to prevent neural tube defects. This was the PYQ that was asked. Neural tube defects. That is spina bifida and anencephaly. Neural tube defects. It is multifactorial. Perfect. Multiple factors play a role now. Along with lifestyle, along with genetics, lifestyle also plays a role. So neural tube defects was asked. I am sure if multifactorial is asked, you will never go wrong in this. So let us start with our understanding based topics, pedigree chart and percentage analysis. सबसे पहले autosomal recessive disorders. Classical example of which is thalassemia. Each gene locus has 2 alleles. So normally we have beta. This is normal. We have 2 alleles. If the patient is heterozygous is the carrier state, that is thalassemia minor. One allele is normal, beta, the other is abnormal, beta 0. Versus homozygous मतलब दोनों एलील खराब हैं, that is the diseased state thalassemia major, which is beta 0. Both alleles are abnormal. What is the classical clinical history of thal major? The classical clinical history being 5-year child with history of repeated blood transfusions. This is the classical clinical history of thal major. 5-year child with history of repeated blood transfusion. So you tell me this. Asha, have you ever gotten yourself checked for thalassemia minor? Can any one of us be thal minor? Yes. It has mild anemia, microcytic hypochromic type. Any one of us can be thal minor. Have you gotten yourself checked? No. कब करवाओगे? It can be at any point. Boyfriend, girlfriend, horoscope matching. But it has to be done by end of first trimester of pregnancy. Why? Because if mother is thal minor, father is normal, what is risk of child to be thal major? I want you to tell me this. 0, 25, 50, 75 या 100%. What is risk of child to be thal major? This is how you get questions. Tell me the answers side by side. Mother is thal minor, father is normal. So mother is thal minor, beta 0. Who mates with father is normal. Who are the 4 kids? Do not get biased by what Keval Abdeki are saying. Think, apply your own mind. Who are the 4 kids? Beta 0, beta 0. This beta 0 goes with both beta. How many are thal major? Thal major was beta 0. Bache 0%. 0%. Lucky you're the first one, right? Agreed. 0. So in autosomal recessive disorders, if one parent is autosomal recessive, one parent is carrier, the other is normal, risk of child to be diseased is 0%. 0. Next question. Both parents thal minor. Next question. Now give me right answer. Both parents. Both parents thalassemia minor. What is risk of child to be thalassemia major? हाँ exactly. अब एग्जाम में मिस्टेक नहीं होगा. This is the whole purpose of this बच्चे. Bang on right. Now tell me, both parents thal minor, beta beta 0. When they mate, who are the 4 kids? Beta, this beta goes with both beta 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 0, beta beta 0, beta 0 beta 0. So what percentage are thal major? 25%. Bang on right. So both the parents were normal. They were not aware they are suffering from any disease, but their child is suddenly diseased. So autosomal recessive disorders skip generations. First point. And secondly, what are the chances that 2 random people will have disease? That they will be carrier. That is autosomal recessive. It is more common in consanguineous marriages. Marriage between family members, consanguineous marriages. More commonly seen in Muslims and South Indians. That is, it's pretty common in Karnataka. Recessive. This is autosomal. Next, recent FMGE PYQ. Father has achondroplasia. This was the exact question that was asked. Father has achondroplasia. Examiner expected you to know that achondroplasia is autosomal dominant. Mother is normal. Ready? गलत आंसर लिख के टेंशन नहीं लेनी. It's okay. It's okay. Mother is normal. What is risk of child to be diseased? We have seen autosomal recessive. This gets us to autosomal dominant. This gets us to autosomal dominant. Father has achondroplasia, meaning one allele is normal, the other is abnormal. In autosomal dominant, Abdullah nahi bache, I am glad we are doing percentage analysis. Ready? No. I am genuinely glad we are doing this. This is asked. Autosomal dominant diseases occur even if one allele is abnormal. तो एक नॉर्मल है एन, दूसरा एबनॉर्मल है एन ए. When he mates with NN, who are the 4 kids? This N goes with both NN NN. Who are the other 2 kids? NA NA. So what percentage of children are diseased? 50%. Both of these are diseased. Even if one allele is abnormal, it leads to disease. 50%. So think of it the other way around. If the child had the disease, he must have gotten the allele from one of the parents. So autosomal dominant disorders do not skip generations. Autosomal dominant do not skip generations. They would have gotten the allele from one of the parents. बच्चे में allele है तो आया तो parents से. Autosomal dominant. Next one, there is no gender bias. These were autosomal. So autosomal recessive, autosomal dominant, there is no gender bias. Sex-linked disorders, XLRs, X-linked recessive, obviously male predominant because male is XY. Even if one allele is abnormal, it leads to disease. X-linked dominant, female predominant. Female is XX. There are more number of X chromosomes. So chances of something going wrong will be higher. Next. Acha, suppose you are given a pedigree chart like this. I want everybody to tell me this. You are given a pedigree chart which is something like this. Inheritance. Your options are autosomal recessive, autosomal dominant, X-linked recessive, mitochondrial, Y-linked. 1, 2, 3, 4, 5. This is the pedigree chart given to you. First thing which I am able to see, you told me autosomal dominant, but look at this family. Look at this family. The child is diseased, but none of the parents are diseased. So it cannot be autosomal dominant, because if it was autosomal dominant, one of the parents had to be diseased. It cannot be Y-linked, because if it was Y-linked, this male had to be diseased. This abnormal will go to this male child also. When this male is Y-linked, then the child also has to be diseased. Y-linked affects all males. So Y-linked is out. It was not affecting all males. What is happening here? Agreed. This is affecting only males. This is affecting, firstly, only males. It is male predominant. Next, what is the relation between this guy and this guy? Mother's real brother. Who is mother's real brother? Mama. Bang on right, Lucky. Bang on right. Mama Bhanja deceased. Mama Bhanja deceased. That is X-linked recessive. This is classical X-linked recessive. Obviously, it is not mitochondrial. Mitochondrial is if mother is diseased, all the children are diseased. It's not mitochondrial. It's not autosomal recessive. Why? Because autosomal recessive, suppose this mother was carrier. If it was autosomal recessive, is this a consanguineous marriage? No. Consanguineous marriage is shown by a double line. This is a single line. It's not a consanguineous marriage. So even if the mother is carrier, father is normal. In autosomal recessive, if mother is carrier, father is normal. What is risk of child to be diseased? 0%. What is left? XLR, X-linked recessive. Next, tell me this. Acha, this was this times NEET PG PYQ. You were given exactly this pedigree chart. Which of the following is a disease associated? The answer to be marked was Wiskott-Eldridge syndrome. Answer was Wiskott-Eldridge syndrome. Wiskott-Eldridge syndrome. Keval haan dost. This was NEET PG PYQ. FMGE PYQ, autosomal recessive was asked. In FMG exam, you were given this pedigree chart. Carrier state is seen in autosomal recessive. When two carriers mate, then the child is diseased. Autosomal. Whereas, now tell me this. What do we see here? Males and females are equally affected. First point. Next point. If one parent is diseased, 50% children are diseased. Autosomal dominant. Perfect. This is percentage and pedigree chart analysis. Next point. With percentage as well as pedigree charts. Double line is consanguineous marriage. You know that. Acha, Keval, you tell me, agar bracket lagao, so then what does that mean? Very curious. Very, very curious. Next, that means the child is adopted. This is adopted. Perfect. Double line, consanguineous marriage. Double line, consanguineous. Sufficient. This is carrier state. This is carrier. Nihal, this is for you, dost. Perfect. Next, so carrier can be half circle also, it can be dot also. Done. So let us see the diseases associated, starting with autosomal recessive disorders. You need to know the list. The lists, again, they are asked. Do it category wise, you will never go wrong. All metabolic disorders are autosomal recessive. Some people make a mnemonic A, B, C, D, F, G, H, I. End में ना वो mnemonic याद रहता है, ये नहीं पता होता किसके साथ है. So all metabolic disorders like cystic fibrosis, alpha-1 antitrypsin deficiency, Wilson's disease, hemochromatosis, L-captonuria, phenylketonuria, Gaucher's disease. All metabolic disorders are autosomal recessive. Cystic fibrosis, the classical clinical history being salty sweat. How do you know that your sweat is salty? Patient has increased salt in sweat, increased sodium chloride in sweat. CFTR gene mutation present on chromosome 7. CFTR gene mutation present on chromosome 7. Cystic fibrosis. Delta F508 mutation. Agreed. But what do we mean by salty sweat? It is while kissing the baby. Baby, I don't mean you guys. Mother while kissing the baby. It is a disease of infancy and childhood. Alpha-1 antitrypsin deficiency, double of 7. That is 14. Chromosome 14. Wilson's disease. ATP7B gene mutation, chromosome 13. Hemochromatosis. बच्चे, all these are PYQs. HFE. देखो ये अमित तो बस एक वर्ड लिख के छोड़ देते, किसिंग द चाइल्ड कर लेते हैं. Hemochromatosis, HFE gene mutation, chromosome 6p. A very important slide. Menkes disease 7A, Wilson's 7B, HFE, hemochromatosis, cystic fibrosis chromosome 7, all these are PY. All metabolic disorders are autosomal recessive. The second category of autosomal recessive are hematological disorders. Remember thalassemia, beta 0. We did whole autosomal recessive on thalassemia. Sickle cell anemia, HB small s. It is how we write it. HB small s, autosomal recessive. Versus capital HS, hereditary spherocytosis, autosomal dominant. SLE nahi bache. SLE is acquired. Tranquil SLE is an acquired disorder. It is not Mendelian inheritance. Next, the first three diseases of inflammation, LAD 1, 2, Shinya-Higashi syndrome, autosomal recessive, versus chronic granulomatous disease, CGD, X-linked recessive. XLR. Remember, we just saw that. First three diseases of inflammation, LAD 1, 2, Shinya-Higashi syndrome, autosomal recessive, chronic granulomatous disease, X-linked recessive. Next, autosomal recessive being albinism. For the child to be very fair, both the parents have to be fair, albinism, and childhood PKD, childhood polycystic kidney disease, autosomal recessive, whereas adult polycystic kidney disease, the name tells you, adult and a autosomal dominant. First class. Next, these were autosomal recessive disorders. Next is autosomal dominant. Very important. All nervous disorders, tuberous sclerosis, neurofibromatosis. Recent FMGE PYQ. Patient presented to OPD with neurofibromas, capillate spots and dish nodules. What is the inheritance? Autosomal dominant. Both NF1 and NF2 are autosomal dominant. NF1, neurofibromin gene mutation. Neurofibromin gene mutation present on chromosome 17 versus NF2, Merlin gene mutation present on chromosome 22. NF2, chromosome 22, NF1, chromosome 17. So all nervous disorders, neurofibromatosis, both 1 and 2, tuberous sclerosis. Next, hematological disorders. Capital HS, hereditary spherocytosis. It's how we write it, capital HS. Capital VWD, von Willebrand disease, autosomal dominant. जैसे लिखते हैं ना वो inheritance है. Next, all colon cancers. Colon cancer can occur by two methods. First, polyp occurs and then cancer occurs. FAP. Familial adenomatous polyposis. FAP. Gene mutation chromosome. Recent PYQ. FAP. APC gene mutation present on chromosome. This was the question asked. I'll wait for your answer. So, colon cancer can occur by two methods. First, polyp occurs and then cancer. FAP. Chromosome 5. Or cancer can occur without polyp. HNPCC. Hereditary non-polyposis colon cancer. HNPCC. Autosomal dominant. Next, Asha, give me that history. Hyperpigmentation around oral cavity. 11-year child with intestinal polyps with hyperpigmentation around oral cavity. Peutz-Jeghers syndrome. Peutz-Jeghers syndrome. PJ syndrome. Peutz-Jeghers. Hyperpigmentation around oral cavity. Next, 5-year-old child with bleeding per rectum. 5 years is juvenile. Juvenile polyposis. All colon cancers are autosomal dominant. All are autosomal. So, all nervous disorders, capital HS, capital VWD, colon cancers. Next, adult PKD we have seen. Next, all skeletal abnormalities. You have history of a patient who is extremely tall. Who you have a history of a patient who is extremely tall with increased joint mobility. Diagnosis, this is written only Marfan syndrome. Patient is extremely tall with last year's PYQ with hyper extensibility of skin. With hyper extensibility of skin. That is Rubberman syndrome. Hyper extensibility of skin. That is Rubberman syndrome. Ehlers loss. Very right. This was the answer to be marked. Last time's PYQ, Ehlers loss syndrome. Next, patient is extremely tall with increased risk of fractures. that is brittle bone disease. Increased risk of fractures, that is brittle bone disease. Diagnosis, osteogenesis imperfecta. Osteogenesis imperfecta. And lastly, achondroplasia. Lastly, Pinky agreed, osteogenesis imperfecta, and lastly, which is achondroplasia. So, 3 PYQs out of these skeletal disorders. Achondroplasia was that percentage based question. Father has achondroplasia, mother is normal. Risk of child to be diseased, 50%. Next question, Marfan's, increased joint mobility. Marfan's, this is what Marfan's look like. We'll see that in just a minute. This was Marfan's. Hyperextensibility of skin, written PYQ, Ehlers loss, brittle bone disease, osteogenesis. First class. So very, very important topic, Mendelian inheritance genetics. You very well know this is Marfan's. Patient is extremely tall, increased joint mobility, long extremities, long fingers. Marfan, that is chromosome 15, FBN1 gene mutation, protein fibrillin 1, Marfan's. It is associated with CVS abnormalities. Which is the most common CVS abnormality with Marfan's? Mitral valve prolapse. Which is the most common cause of death in Marfan's? Aortic dissection. Most common cause of death in Marfan's being aortic dissection. So Marfan syndrome, it is associated with CVS abnormalities. Most common CVS abnormality being mitral valve prolapse. Most common cause of death being aortic dissection. So see the question carefully. Next, it is also associated with ectopia lentis. Ectopia lentis means eye lens is not in center. It is associated with ectopia lentis. Which side is the eye lens? Upwards and outwards. That is, it is associated with supratemporal. It is associated with supratemporal subluxation of eye lens. Supratemporal subluxation of eye lens. Perfect. Upwards and outwards. Marfan syndrome. This is what it looks like. Marfan's. This was autosomal dominant. Next is homocystinuria is downwards. Perfectly agreed. Perfectly similar. Totally right here. Next category of Mendelian inheritance being X-linked recessive. XLR. X-linked recessive. You very well know CGD. Chronic granulomatous disease. X-linked recessive. LAD-1-2 Celiac syndrome, autosomal recessive. CGD, chronic granulomatous disease, X-linked recessive. Next, you have a history of a child, a male child, while playing football. There is no trauma, but he presented with swelling of the knee joint with bleeding, hemarthrosis, hemophilia A and B, which occur due to deficiency of coagulation factors 8 and 9. Hemophilia, XLR. We write it as XH. Hemophilia कैसे लिखते हैं? XH. Next, which is the most common RBC? Enzyme deficiency, G6PD deficiency, X-linked recessive. Next, Bruton's X-linked agammaglobulinemia. XLR. This time's NEAT PGPYQ, combined B and T cell defect, Viscoehlers syndrome, XLR. Please put a star on this. Viscoehlers. Hemophilia C is AR. Agreed. But बच्चे AB से ऊपर हमसे पूछेंगे नहीं. मतलब hemophilia C हम पढ़ेंगे when we are doing NEAT PG segment. A and B, XLR. Viscoehlers syndrome was this time's NEAT PG PYQ. That pedigree chart. Mama Bhanja diseased. Which of the following can be the disease associated Viscoehlers? So Bruton's X-linked agammaglobulinemia. देखो नाम ही बता रहा है. Bruton's X-linked agammaglobulinemia and Viscoehlers syndrome, XLR. Next, we are colorblind. Red, yellow, green, blue. 4 कलर पता चलते हैं. गर्ल्स, you know, there are 14 shades of pink also. So color blindness, X-linked recessive, XLR. Next, extremely important, recent FMGE PYQ, you were given a history of a child who is having pain while walking at the age of 5 years, limping at 6 years, crutches at 7 years, wheelchair at 8 years. Pain while walking, limping, crutches, wheelchair. DMD, Duchenne's muscular dystrophy. DMD, Duchenne's muscular dystrophy, X-linked recessive. I sincerely hope everybody is okay with Mendelian inheritance. मतलब ये ना बहुत इंपॉर्टेंट टॉपिक था, बहुत ही इंपॉर्टेंट था. ऑटोसोमल रिसेसिव, ऑटोसोमल डोमिनेंट, एक्सलिंक्ड रिसेसिव. एक्सलिंक्ड डोमिनेंट you already know is female predominant, and 4 ही वो हैं. There are 4 diseases: Alport syndrome, hypophosphatemic rickets or vitamin D resistant rickets, Rett syndrome, and Charcot-Marie-Tooth disease. This is Mendelian inheritance, X-linked dominant. This is Mendelian. Everybody, बच्चे, you are going to get questions from this. Genetics, inheritance, diseases पूछा जाता है. This is asked. Pedigree chart, percentage, inheritances. Numerous PYQs. अच्छा, before we go further, before I tell you the topic, you tell me this. You tell me, what do we see here? Tell me this. Diagnosis. So this gets us to chromosomal abnormalities in number. This is a case of Down syndrome. Down syndrome, it is trisomy 21. Suppose I have to write your or my chromosome number. What will I write? What is normal? Total number of chromosomes, 46XX या 46XY, males 46X. You always write total number of chromosomes, comma sex chromosome. So in Downs, total number of chromosomes become 47. XX or XY depending on male female plus 21. This is how it is written. You always write total number of chromosomes, comma sex chromosome. Which is the most common cause of Downs? Third chromosome 21 came. How many chromosome 21 do you or I have? We have 2 chromosome 21, one from mother, one from father. Patient में there is a third chromosome 21. कहाँ से आया? Mother. Most common cause of Downs being maternal meiotic non-disjunction. In the mother, chromosome 21 did not separate during meiosis. Maternal meiotic non-disjunction. Why? What is the main risk factor of Downs? Increasing age of the mother. So girls say yes to guys. All guys are same only. ज़्यादा नहीं सोचना. Main risk factor, increasing age of the mother. Is age of the father important? To the mother, probably yes, but for Downs, no. So this is Downs. It is the most common genetic cause of mental retardation. Patient has epicanthic folds with a flat facial profile. Face चिपटा हुआ है, flat facial profile with abundant neck skin, which is seen radiologically as increased nuchal fold thickness. It is seen as increased nuchal fold thickness. Nuchal fold thickness is increased with a single transverse simian crease. This will be given in the question. Out of these 5 points, this will be given in the question. 3-4 will be given in the question. Face चिपटा हुआ है, flat facial profile, most common genetic cause of mental retardation, single transverse simian crease. What is asked is, it is associated with CVS abnormalities. Which is the most common CVS abnormality with Downs? Most common CVS, देखो ऊपर के 4 दिए होंगे. It will be given in the question. It is associated with CVS abnormalities. Most common being endocardial cushion defects, followed by VSD, followed by ASD. Most common CVS abnormality. It's not VSD, बच्चे, no. We tend to mark it as VSD, but the most common CVS abnormality with Downs being endocardial cushion. Next, Down syndrome, देखो. It is associated with intestinal stenosis. Where? At duodenum. Intestinal stenosis at duodenum. Increased gap between first and the second toe. That is called as saddle toe deformity. It's like a saddle. We sit on a horse, na, saddle toe deformity. Hypotonia. Hypotonia, the tone of muscles is reduced. Umbilical hernia, please put a star. Down syndrome is associated with umbilical hernia, not Turner syndrome. Recent FMGE PYQ, all of the following are features of Turner syndrome except umbilical hernia. Umbilical hernia is a feature of Down syndrome, not Turner's, not Turner's. Intestinal obstruction at duodenum, and increased risk of acute leukemia. So give me a good answer now. Which is the most common acute leukemia with Downs? Most common acute leukemia with Downs. AML M3, M5, M7, yeah, ALL. Which is the most common acute leukemia? Most common acute leukemia with Down syndrome. Okay. Most common acute leukemia with Downs being ALL. He's smart. Very nice though. So it's not M3, M7, no. Down syndrome is seen in children. Most common acute leukemia in children is ALL. Whereas, see the question carefully. Most common AML in Downs being AML M7. We divide AML into M0 to M7. M7, though it is the least common AML, but it is the most common AML in Downs. So see the question carefully. Most common acute leukemia in Downs is ALL. Most common AML in Downs is AML M7. You need to know this. Next point. I'm sure now nobody will go wrong in this. And antenatally, that is, if a patient of Down syndrome is born in your care, but it is our negligence, let's put it this way, we have antenatal screening of Downs. Antenatally, radiologically, we have increased nuchal fold thickness, abundant neck skin. Serologically, we look at 3 markers, triple screening: beta HCG, AFP, alpha fetoprotein, and UE3, unconjugated estriol 3. This was last year's NEET PG PYQ. UE3 was asked. So be very cautious at this. Be very cautious. Triple screening, we look at 3 markers: beta HCG, AFP, UE3. HCG increases in pregnancy. In Down syndrome, it is further higher. Beta HCG is increased in Downs versus AFP and UE3 reduce. This was recently asked, so it is important for us. Quadruple screening. कौन सा marker add कर दिया? It is performed at 10 to 13 weeks. Agreed, you know this very well from obs-gynae. Quadruple screening, inhibin A is added. Inhibin A increases in Down. So quadruple screening, 2 markers increase, 2 reduce. Acha girls, tell me this. You found your soulmate, got pregnant. Which screening will you go for? Triple screening or quadruple screening? I want you to tell me this. Everybody, 1, 2, A, B, कौन सा करवाओगे? Main risk factor for Downs is increasing age of the mother more than 30 years. I am sure you will like to get pregnant before 30, I mean, no doubt. So will you like to go for triple screening or quadruple screening? Quadruple, because we will not like to take a risk. More the markers we test, better is the sensitivity and specificity for detection of Downs. You will not like to risk it, na Laki? So quadruple. It will depend upon the trimester. You will start with dual screening, then do triple screening, then level 2 ultrasound, then quadruple screening. I totally agree. But अगर end में level 2 ultrasound के साथ, you will always go for quadruple. This is Downs. It is more accurate. Karyotype analysis. This is conventional cytogenetics. Or karyotyping. Conventional cytogenetics or karyotyping. The minute you see such an image, first thing you have to see is there are 22 pairs of chromosomes XX or XY. That is, this is nice normal 46XY. Total number of chromosomes, sex chromosome. This is normal. This was the exact image. There should only be one X. If there is no Y, suppose this is gone. Suppose this was what was given to you. Suppose this was the image given, then it is turned as 45XO. XO. This is Turnus. This is Turnus. Next point. Next point. This was the exact image that was given to you in recent FMGE PYQ. You are able to see everything are 2-2 except trisomy 21 makes it as Down syndrome. You already know trisomy 18. If chromosome 18 were 3, that is Edwards syndrome. Trisomy 18 Edwards. Trisomy 13 tRNA Patau's syndrome. Patau's, it has a T in it. Trisomy 13 Patau's. This is cytogenetic. Next, so now have a look at this image. Written PYQ. That was with respect to Klinefelters though, but just have a look. She is a young female presenting to OPD with short stature, low webbed neck, widely spaced nipples, streak ovaries. That is, there is fibrosis in ovary, so it is associated with primary amenorrhea. Streak ovaries. Cubitus valgus, that is, elbow is out. Cubitus valgus, the angle is increased. Cubitus valgus, and peripheral edema at birth, that is Turner's syndrome. That is Turner's. Now, out of these 4-5 points, 3-4 will be given in the question. Questions that are asked are IQ. Everybody. In Turner's syndrome, examiner will give you a history of a girl who is about 4 feet 2 inches in height, suffering from primary amenorrhea. What is the IQ? Low, normal, high. Guys, you very well know, more the number of X chromosomes, lower is the IQ. I know I keep on saying shit like this, which I should not say. After normal. So here X is less. This is 45 XO. एक X कहाँ गया, उसमें रिंग क्रोमोसोम बन रहा है. O के ऊपर छोटा सा रिंग बना देंगे ना, IQ is normal. टेक लो नहीं है, देखो लो लेकर डिलीट कर दे. IQ normal. Next point. FSH and LH. Low, normal, high. The girl is not bleeding. So hypothalamic pituitary axis is trying to stimulate the ovaries. So FSH and LH is high. The girl has to bleed, so hypothalamic pituitary axis is stimulating the ovary. Next point. FSH and LH high bache, high. Lastly, Turner syndrome is not associated with umbilical hernia, recent PYQ, and it does not increase the risk of malignancies. It is not associated with umbilical hernia and does not increase the risk of malignancy. While have a look at this. The minute I see this, I know he's a male. He has female type pubic hair with atrophic testis. Recent FMGE PYQ. Couple is trying to conceive for the past 5 years. On examination, the female is normal, but the male has unicoid body habitus. Unicoid body habitus means male has female-like body posture, narrow shoulders with wide hips. Males have broad shoulders. Females have narrow shoulders with broad hips. That is unicoid body habitus. Frontal baldness is absent. There is gynecomasia, fewer chest hair, poor beard growth. Secondary male sexual characteristics are reduced, making this as a case of Klinefelter syndrome. Most common Klinefelters being 47XXY. You know that. X chromosome is increasing, so this is low IQ. You again know this. FSH and LH, low, normal, high. Number of X chromosome is increasing now, so high. Agreed. So both Turner's and Klinefelters had high FSH and LH. The reason for that was different. FSH and LH high bache. Next, of course, Hussain, 24 weeks now, the upper limit for MTPS. Next and lastly, estrogen to testosterone ratio. is increased. X chromosome is increasing now, so estrogen is increasing. Estrogen to testosterone ratio is increasing. Perfect. This is Klinefelter's. This is Klinefelter's. 24 weeks बचे, 24 weeks. This is Klinefelter. एक बार check in obs-gynae once again, but it has been increased from 20 to 24 weeks is what I know. Next one. So these were the three main chromosomal abnormalities in number of chromosomes. Downs, Turner's, Klinefelter. This takes care of our main highlighted points that I wanted to discuss with respect to genetics, which is very, very important. Everybody, this was an important session. हम लोग immunity को फटाफट से देखकर, I'm sure immunity, lot of it would have been covered in immunology, in microbiology also. We'll have a look at hypersensitivity reactions. A lot of questions come from that. Amyloidosis, graft rejections and autoimmune disorders, that is SLE, systemic sclerosis and all. Perfect. So let us start with immunity. Let us start with our first topic in this, that is T cells. Cells of the immune system, T cells. You very well know T cells are of two types. Helper T cell, helper versus cytotoxic T cell. Helper T cell needs MHC2 for activation. It is MHC2 restricted versus cytotoxic T cell, which is MHC1 restricted. It needs MHC1 for activation. ठीक है, मान लिया, nothing major. 4 into 2 is 8. 8 into 1 is 8. So helper T cell is MHC2 restricted. Cytotoxic T cell is MHC1 restricted. Fair enough. Next, let us have a look at T cell activation. This topic is important, bache. Let us see. So understand this in one go. Let us have a look at T cell activation. Let us assume this is a CD4 positive T cell. The CD4 positive T cell or any T cell, it needs two signals for activation. The first signal is received when antigen binds to T cell receptor. T cells have a T cell receptor. The first signal for T cell activation is received when antigen binds to T cell receptor. Next, basic markers you need to know. How will the T cell get activated? When antigen will bind to T cell receptor. Who is presenting the antigen to the T cell receptor? Antigen presenting cell. So this is a professional antigen presenting cell. This is a professional APC, professional antigen presenting cell, who is processing and presenting the antigen to T cells. This was a CD4 positive T cell. This is CD4 positive. So professional APC has MHC2. Remember, CD4 positive T cells are MHC2 restricted. They need MHC2 for activation. It has MHC2. It has both MHC1 and 2. MHC1 is present on all the nucleated cells. So professional APCs, they have both. They have both MHC1 and 2. It is the MHC2 which plays a role in T cell activation. Which are the professional APC? There are three main professional APC, which are dendritic cells, macrophages, and B cells. The most potent professional APC being dendritic cell, the first one. There are three professional APCs: dendritic cells, macrophages, and B cells. Most potent, most active being dendritic cell. Which is the most mature B cell is called plasma cell. Dendritic cells, macrophages, B cells. Most potent professional APC, dendritic cell. This was first signal. But T cells needed two signals for activation. Second signal is received when something present on T cell binds with something on professional APC. I'm not concerned CD28 binds with B7.1 and so on. Not concerned. Not concerned. Mainly for our FMG exam, first signal is important. This is T cell activation. Very, very important. This was about T cells. Next, so T cells needed two signals for activation. Next, this gets us to our next cell of the immune system, that is antigen presenting cell, APC, which are of two types, professional versus non-professional APC. We just saw 3 professional APC hai. Professional APCs firstly express both MHC2 and MHC1. You know that. There are 3 professional APCs: dendritic cells, macrophages, B cells. Most potent dendritic cell of the skin has a special name to it called Langerhans cell. Langerhans cell was the giant cell of the skin. Langerhans क्या था? वो था giant cell of the skin. Langerhans cell is the dendritic cell of the skin. Langerhans was giant cell of TB. My mistake. Next, अब इसमें main question है non-professional APCs. They express MHC1. They only express MHC1. Which are the non-professional APC? They are thymic epithelial cells, thyroid epithelial cells, pancreatic beta cells. Unfortunately, this list needs to be remembered. Important. Glial cells and fibroblasts. Glial cells and fibroblasts. These are the 5 non-professional APC. Epithelial cell, thymic epithelial cell, thyroid epithelial cell, glial cell, microglia. Microglia is the macrophage of the brain. Glial cell is the non-professional APC. Glial cells, pancreatic beta cells and fibroblasts. Next point. So this was about antigen presenting cells or APC, cells of the immune. Next, so this gets us to our first miscellaneous topic in immunity, that is MHC or HLA. You already know it is present on chromosome 6p, short arm of chromosome 6. It is present on chromosome 6p. It processes and presents the antigen to T cell. MHC2 presents the antigen to helper T cell. MHC1 to cytotoxic T cell. You know that. In our day-to-day life, we are exposed to huge variety of antigens. So MHC, they are highly polymorphic. We are exposed to a huge variety of antigens. They are highly polymorphic. MHC are of 3 types, 1, 2, 3. Let us start with MHC1 and 2. MHC1, it is present on all nucleated cells and platelets. MHC1, it is on all nucleated cells and platelets versus MHC2, which is only on professional APC. You know that. कौन से genes ने MHC1 बनाया? Rank 1 है ना, single digit. HLA ABC make MHC1, ABC make MHC1, DP DQ DR make MHC2, double digit. ये सारे MHC कहाँ present हैं? They are present on chromosome 6p. They are present on short arm of chromosome 6, chromosome 6. MHC1 versus 2. ये तो मुझे बोलने की भी जरूरत नहीं that T cells, which T cells are activated by MHC1? Cytotoxic T cell versus helper T cell, which is activated by MHC2. You know that. इसमें जो अपन से क्वेश्चन पूछा जाता है ना, what is asked is MHC3. Very, very important, बच्चे. MHC3 secretes 4 things. It secretes, MHC3 secretes TNF alpha, tumor necrosis factor alpha, TNF alpha, tyrosine hydroxylase. It secretes TNF alpha, tyrosine hydroxylase, heat shock protein 70, HSP 70, heat shock protein 70, and complement factors BHI and propertin. Complement factors BHI and propertin. This is MHC. MHC3 चार चीजें secrete करता है. It secretes 4 things. This is very important. TNF alpha, tyrosine hydroxylase, HSP70, heat shock protein 70, and complement factors BHI. You have to know this. This was MHC. इसमें ना आपने दो इस स्लाइड में there are two main things. MHC1 is present on all nucleated cells and platelets. So examiner can ask you what is it not present on? It is not present on RBC. ठीक है, मान लिया RBC इस पे नहीं होता. Agreed. Second question, MHC3 it secretes 4 things. TNF alpha, tyrosine hydroxylase, HSP70, and complement factors BHI property. And the last question is diseases associated with MHC. Again, you have to know them. Most famous is HLA B27, which is associated with ankylosing spondylitis. हमें चाहे कुछ और पता है कि नहीं पता, we need to know HLA B27 ankylosing spondylitis. Other than this, it is also associated with reactive arthritis, Reiter's disease, and psoriatic arthropathy. HLA B27, ankylosing spondylitis, reactive arthritis, Reiter's disease, and psoriatic arthropathy. Next, HLA-DR2, Goodpasture syndrome. HLA-DR2, Goodpasture syndrome. हम लोग किडनी में देखेंगे बच्चे, सीलियाक नहीं, नॉट सीलियाक एट ऑल, नो. HLA-DR2, Goodpasture syndrome. This is the disease which affects kidney and lungs and is associated with the presence of anti-GBM antibody. Recent FMGE PYQ, anti-glomerular basement membrane, anti-GBM antibody. When we talk of celiac disease, which HLA comes to your mind? Celiac, every paper again you get a question. We'll do it in detail in GIT. Patient cannot have gluten, so he cannot eat bro, wheat, rye, oats, barley. What can he eat? Rice. So recent PYQ, instead of rice, pulao was mentioned with celiac. We'll see that. Celiac disease is associated with HLA DQ2/DQ8. Celiac disease or gluten sensitive enteropathy. Please have a look. The patient cannot eat bro, wheat, rye, oats, barley. He can eat rice, maize, potatoes, and tapioca. Recent PYQ, instead of rice, pulao was mentioned. Majority of the girls went wrong. Next. So coming back. HLA-DR2, Goodpasture. Lucky you have a pretty girlfriend. I mean, I know Lucky and stuff. So of course he has to know cooking. Otherwise his girl will run away. Next, anti-GBM antibody, Goodpasture syndrome. Recent PYQ. HLA-DR3, Sjogren's syndrome. Dry eyes, dry mouth, Sjogren's syndrome. HLA-DR4, Pinky, awesome. आना भी चाहिए, पता है? HLA-DR4. So, वाह, केवल. So, मतलब, no, I mean, I should not pull Keval and Pinky's leg together on this. So, fair enough. HLA-DR4, rheumatoid arthritis. देखो, easy to remember. HLA-DR2, Goodpastures. Good morning, it's a beautiful day. I'm going jogging. DR3, Sjogren's. Jogging के बाद rheumatoid arthritis हो गया. DR4, rheumatoid arthritis. Just a way to remember. Next, coming back, we'll get distracted very easily ऐसे, and I can chat more happily about random stuff. Next, DR2, Goodpastures. DR3, Sjogren's. Next, अच्छा, कौन सा vasculitis है which has the strongest association with smoking? Vasculitis with the strongest association with smoking. So coming back, vasculitis with strongest association with smoking, Tau smokes. thromboangiitis obliterans or Buerger's disease. Thromboangiitis obliterans or Buerger's disease. Buerger's disease. Cow smokes. Associated with HLA B5. Associated with HLA B5. उनकी बात नहीं हो रही, आ जाओ वापस. Next, Delhi, Bombay, most polluted city in India, Bombay. Delhi, Bombay. So Bombay though is waterfront, but Delhi, Bombay. HLA B5, thromboangiitis obliterans, so Buerger's. HLA B51. देखो इसमें कंफ्यूज नहीं होना है. B5 is Buerger's, thromboangiitis obliterans or Buerger's. B51 is Behcet's. Behcet syndrome, that is uveitis with genital ulcers, that is B51. अच्छा ये बताओ, which has a stronger genetic predisposition? Type 1 diabetes or type 2? Type 2 diabetes is lifestyle. Type 1 diabetes, genetic predisposition type 1. So it is non-specifically associated with everything. HLA, DR2, DR3, DR4, DQ2, everything, type 1 diabetes. Lastly, celiac तो हम लोगों ने देख ली. So these are the diseases associated with MHC or HLA. First class. And this gets us to our next very important topic in immunity, that is hypersensitivity reactions. Let us start with the first main one, that is type 1 hypersensitivity. Asthma or allergy, immediate type. Two recent PYQs. A 16-year-old girl goes to park, gets bee sting injury leading to anaphylaxis-like reaction. Which is the antibody associated? It is IgE mediated response. Next question. A 7-year-old child who is a known case of asthma while having seafood develops laryngeal spasm. Which is the main mediator associated? Histamine. Main mediator, histamine. These were two recent PYQs with type 1 hypersensitivity. Next point, type 1 hypersensitivity, that is asthma allergy. The immediate type of hypersensitivity reaction. The main cell of type 1 hypersensitivity being mast cell. Please do not say it as eosinophil. Main cell is mast cell. Followed by which WBC increases? Eosinophil, basophil and T cells. Main cell is mast cell, followed by eosinophil, basophil and T cells. Which is the main activator of eosinophil? Main activator, A, B, C, D, E. E is the fifth alphabet now. Interleukin 5 followed by 4. Versus main activator of basophil, B is the second alphabet now. Interleukin 3 followed by interleukin 4. All these are the PYQs. All of these are important. So I can safely say the main cytokine associated with asthma, main WBC that was increasing was eosinophil. So interleukin 3, 4, 5, which is the main one? Which was the main activator of eosinophil? Interleukin 5. This is type 1 hypersensitivity. Microscopically, asthma shows the presence of 3 Cs. That is Kirschmann spirals, Charcot-Leyden crystals and Crayola bodies. You know that. We'll see the images in lungs. This is type 1 hypersensitivity. Next is type 2 hypersensitivity. Let me add a page to this. Next is type 2 hypersensitivity, that is antibody mediated hypersensitivity reaction. Any disease showing the presence of an antibody, type 2. So I'll just keep on naming the disease. You tell me the antibody. Goodpasture syndrome. Any disease with an antibody. Goodpasture syndrome. Anti-GBM antibody. Type 2 hypersensitivity. ANCA vasculitis. The antibody is against cytoplasm of neutrophils. Antibody mediated hypersensitivity, ANCA vasculitis. It is a small vessel vasculitis. Vasculitis is a very important topic. We'll do it in CVS. It affects small vessels. So ANCA vasculitis, we will see it is of two types, C ANCA, P ANCA. C ANCA, COW cow, C ANCA, venous granulomatosis versus P ANCA, the vasculitis are microscopic pan and Churg-Strauss syndrome. Microscopic pan and Churg-Strauss syndrome. ANCA vasculitis. Antibody was against cytoplasm of neutrophils. Next disease with type 2 hypersensitivity. Next disease with type 2 is AIHA. Autoimmune hemolytic anemia. Autoimmune, antibody against self-antigen. In this, the antibody is against RBC membrane. And it is against which protein of the RBC membrane? The antibody is against band 3. RBC membrane, which it has many proteins. All of us have band 3. So antibody against band 3 lead to autoimmune hemolytic anemia. Next is pernicious anemia. Pernicious anemia, there is presence of antibody against intrinsic factor. What is intrinsic factor? It is secreted by parietal cells of stomach. What is its role? Intrinsic factor, it binds with vitamin B12, and this intrinsic factor vitamin B12 complex is absorbed from terminal ileum. So if there is antibody against intrinsic factor, vitamin B12 absorption reduces. Vitamin B12 absorption reduces, that is, it is a type of megaloblastic anemia. Next example of type 2 hypersensitivity is mismatched blood transfusion. Recent FMGE PYQ, mismatched blood transfusion or immune mediated hemolysis. I think this was the exact wording that was asked. Immune mediated hemolysis. Mismatched blood transfusion. Suppose I am A blood group. I have anti-B antibody in me. You give me B blood group. It is mismatched blood transfusion, antibody mediated hypersensitivity type 2. Immune mediated hemolysis, antibody mediated hemolysis type 2. So any disease showing the presence of antibody is type 2 hypersensitivity. ANCA vasculitis, mismatched blood transfusion, it was written. Next, Graves' disease. Graves' disease, which it is the most common cause of hyperthyroidism. Hyperthyroidism matlab T3, T4 are increasing. If T3 and T4 is increasing, which antibody will be present? Thyroid stimulating inhibitory. Thyroid stimulating antibody. It has long acting thyroid stimulating antibody. अब long acting है तो कौन सी होगी? IgG, IgM, IgG LATs. IgG long acting thyroid stimulating antibody. IgM is short acting. IgM is seen in acute infections. IgG is long term. It is long acting thyroid stimulating antibody. IgG. Next, myasthenia gravis. Next, let me write this here only. Next is myasthenia gravis. I am sure you know this. Myasthenia gravis from pharma also. You know, if this is the nerve ending with nerve end plate, these are the acetylcholine receptors. Acetylcholine comes and binds to it. So antibody against acetylcholine receptors. Antibody against acetylcholine receptors, myasthenia gravis. अब इसमें ना myasthenia gravis recently पूछा भी गया था. इसमें point ये है, point to be noted is Graves' disease and myasthenia gravis. The best answer for these two is type 5 followed by type 2 hypersensitivity. Please put a star. Please put a star. The best answer is type 5 followed by type 2. 2 and 5 both are antibody mediated hypersensitivity. इन दोनों का बेस्ट आंसर है टाइप 5 hypersensitivity followed by type 2. बाकी सारे अगर 5 ऑप्शन में नहीं है then the answer is type 2 hypersensitivity. Next, please give me a thumbs up एक बार if you have understood the antibody mediated hypersensitivities. Any disease with antibody in it is type 2 hypersensitivity. Just have a look once. Myasthenia gravis and Graves सिर्फ ऐसे थे जिसमें बेस्ट आंसर था 5 followed by type 2. Next is type 3 hypersensitivity, that is antigen antibody immune complex reaction. The classical disease in type 3 hypersensitivity is serum sickness. Bache, the classical disease is serum sickness. In olden times, if somebody fell ill, we used to take his blood and inject it in a horse. Horse uske against antibody banayega. So when you will take antibody of horse in human, it leads to serum sickness, type 3 hypersensitivity. It is obsolete. If now somebody falls ill, we don't go to horse, now we go to chemist. Localized experimental reaction is called as Arthus reaction. Localized reaction को क्या कहते हैं? Arthus reaction. Other diseases with type 3 hypersensitivity are PAN, polyarthritis nodosa, PAN, PSGN, post-streptococcal glomerulonephritis, PSGN and SLE. बच्चे ये ना एक बार याद रखना है. Antigen antibody immune complex reaction है. This antigen antibody immune complex reaction, you tell me, where is it getting deposited in PSGN? Recent NEET PG PYQ, so can be asked in our paper also. In PSGN, it has a subepithelial deposit called as humps. When we'll do kidney, I'll show it to you. Humps are seen in PSGN. Humps are seen in PSGN. Spikes are seen in MGN. Please repeat this with me. Spikes are seen in MGN. These are antigen antibody immune complex deposit. Antigen antibody immune complex कहीं deposit हो रहा है. PSGN और MGN दोनों में कहाँ deposit हो रहा है? सब epithelial region में. PSGN में humps मिलते हैं, MGN में spikes. PAN तो बच्चे पिंकी PAN तो vasculitis है ना. Polyarthritis nodosa, it's a vasculitis. It's a medium vessel vasculitis. SLE वो butterfly like rash वाला SLE type 3 hypersensitivity. Last है cell mediated hypersensitivity type 4. Diseases TB, hypersensitivity pneumonitis. Organic particulate matter के कारण होता है. This is because of inhaled organic particulate matter. Organic particulate matter मतलब वो bagasosis. कार्डबोर्ड टेबल पे बैठे हैं ना, वो कार्डबोर्ड टॉप है. फर्मेंटेड शुगर केन, बैगासोसिस, कॉटन फाइबर्स, बाइसिनोसिस. ऑर्गेनिक पार्टिकुलेट मैटर. नेक्स्ट कॉन्टैक्ट डर्माटाइटिस. ये अगेन इंपॉर्टेंट है, पूछा गया था. कॉन्टैक्ट डर्माटाइटिस, स्किन के कॉन्टैक्ट में क्या आया कि इचिंग हो गई? पॉइजन आईवी. पॉइजन आईवी. कॉन्टैक्ट डर्माटाइटिस, व्हाट केम इन कॉन्टैक्ट विद स्किन? पॉइजन आईवी. परफेक्ट. These are hypersensitivity reactions. Cortex, I seriously hope that you are able to recall the content at this point. So, in our this session, we finished genetics. We covered a lot of content of genetics. Immunity, which it is almost over. I know that is so sweet of you, Cortex. Seriously. So we have covered major chunk of immunity. What we are left with is we'll go to autoimmune disorders, SLE, Sjogren's syndrome, systemic sclerosis, antibodies पूछी जाती हैं. Autoimmune disorders. Then we'll see graft rejection, hyperacute, acute, chronic, graft rejection and amyloidosis. These are the three main topics. Again, very high yield topics. Amyloidosis, you had 2 questions in recent FMGE exam, that hemodialysis associated beta-2 microglobulin, medullary carcinoma, thyroid calcitonin. We'll see that. So let's have Simran बच्चे type 5 hypersensitivity के तो 2 ही example है ना, myasthenia gravis and Graves' disease. Nothing other than that. Type 2 and type 5 hypersensitivity are antibody mediated hypersensitivity. Perfect. Okay. So बच्चे let us start where we had left off. Now we were doing immunity. In immunity, let us start with autoimmune disorders. Starting with SLE. You very well know systemic lupus erythematosus. It is a female predominant disorder seen in late 20s, early 30s. Presenting to OPD with butterfly-like rash. There is presence of rash on cheeks as well as bridge of the nose, malar rash, photosensitivity. Kidney involvement by SLE is called as lupus nephritis. Serious involvement by SLE is called LSE. SLE, when it involves the heart, it is called LSE. Libman sac, endocarditis. You know this, that butterfly-like rash was recent FMGE image-based PYQ also. Next point. So the questions which are important for us now is, what was asked was the antibody associated in this 32-year-old female, and वो female का image था with butterfly-like rash. That is the most common or the most sensitive antibody being ANA, anti-nuclear antibody. Most common or sensitive ANA, anti-nuclear antibody. Whereas most specific, S for specific, S for Smith, anti-Smith, followed by anti-DS-DNA, followed by anti-double stranded DNA antibody. So most common is ANA, anti-nuclear antibody. Most specific, anti-Smith followed by anti-DS-DNA, double stranded DNA antibody. Drug-induced lupus. Answer: simple, straightforward topic which we need to know. Antibody से भी ना एक question आ जाता है usually कि this antibody is seen in which disease. So drug-induced lupus, anti-histone antibody. And lastly, neonatal lupus with congenital heart block. Neonate है ना, neonate रोता है, that is anti-Rho/LA, also called as anti-SSA/SSP antibodies. These are the antibodies associated with SLA. Very, very important. You need to know the list. Antibodies associated with SLA. Next, the next autoimmune disorder being Sjogren's syndrome. Sjogren's syndrome, it is dry eyes, dry mouth, Sjogren's. So in Sjogren's syndrome, it shows the presence of anti-Rho/LA antibody. Let me write this on the side once. Do we have a... Yes. So let us have a look at Sjogren's syndrome, which it is keratoconjunctivitis sicca, that is, and xerostomia. Zero is dry, stomia mouth opening, dry eyes, dry mouth. So organs affected, obviously lacrimal and salivary glands. What keeps our eyes and mouth wet? No double meanings. Lacrimal and salivary glands. ठीक है, मान लिया. The main point here is the main inflammatory cell of Sjogren's being lymphocyte. Main inflammatory cell of Sjogren's syndrome is lymphocyte. If you know this, you will know everything. So earliest microscopic feature in Sjogren's, lymphocyte आ जाएंगे, is periductal. Earliest microscopic feature being periductal lymphocytic infiltration, that is, around the duct of lacrimal and salivary glands, lymphocytes come in. Periductal lymphocytic infiltrate. This is Sjogren's. Antibodies associated. Again, it is associated with presence of anti-Rho/LA, that is anti-SSA/SSP antibody. This is the same जो neonatal lupus with congenital heart block में था. Neonate रोता है ना, neonate cries, anti-Rho/LA और SSA/SSP. Lastly, diagnostic prerequisite. To make a diagnosis of Sjogren's, this has to be done. Lip biopsy needs to be performed. Salivary gland biopsy, minor, major, minor salivary gland, that is, lip biopsy needs to be performed. This is Sjogren's. Irrespective of how painful it would be despite the anesthesia, lip biopsy is required. This is Sjogren's. Main point here, दो main point है. Main inflammatory cell is a lymphocyte, antibody, anti-Rho/LA. These are the main features. And lastly, this gets us to the antibodies associated with systemic sclerosis. Systemic sclerosis, which it is of two types, localized and the diffuse type. In localized type, it is associated with the presence of anti-centromeric antibody. Localized type, anti-centromeric antibody. Easy to remember. Guys, girls, हम लोगों को डांट ऐसे ही तो पड़ती है When you girls, when you are scolding us, what do you say? You are so centric to yourself. You are so localized to yourself. You just think of yourself only, nothing else. So localized type, anti-centromeric antibody versus diffuse, which shows the presence of anti-RNA polymerase 3. It shows the presence of anti-RNA polymerase 3 or anti-topoisomerase antibody. Anti-RNA polymerase 3 and anti-topoisomerase. Anti-topoisomerase, also called as anti-SCL70 antibody. Antibodies associated with autoimmune disorders are important. हम लोगों को antibodies पता होनी चाहिए. There is no doubt about it. We have seen the antibodies with SLE, Sjogren's syndrome. Let me rephrase this. This was SLE. SLE, for those of us who came slightly late, this was SLE. Just read them up once. Sjogren's syndrome again shows anti-Rho/LA and systemic sclerosis. Systemic sclerosis दो टाइप का था, localized and diffuse. Localized, you are so localized, you are so centric to yourself, anti-centromeric antibody. Versus diffuse, anti-RNA polymerase 3 and anti-topoisomerase, also called as anti-SCL70. These are the antibodies associated with systemic. Lastly, CREST syndrome. CREST syndrome is more common in localized type, rare in diffuse. So examiner also asks you the antibody associated with CREST syndrome, anti-centromeric antibody. These were the autoimmune disorders. You need to know these antibodies. These were the autoimmune. And this gets us to our next, again a very important topic, graft rejection. Let us start with types of graft. Recent PYQ. What is graft between same individual called as? Isograft. Isograft, like hair transplant, skin transplant in cases of burns. Same individual. My mistake. Say autograft. Same individual, autograft. Autograft. Identical twins, isograft. Same species, allograft. Different species, xenograft. These are the types of graft. I'm again repeating this. Same individual, autograft. Identical twin, isograft. अच्छा, इसमें examiner can ask you, what is mother to child graft? Mother to son, that is allograft. Mother to son graft, this is same species. Mother to son is same species. Use of pig heart valves, that is xenograft. I took the graft, my body rejected it, that is graft rejection. मेरी body ने reject कर दिया. Graft rejection, बच्चे, it is of three types. Hyperacute, which occurs within minutes to hours. Hyperacute. Acute, which takes days to weeks. Versus chronic, that is months to years. So graft rejection, it is of three types: hyperacute, acute and chronic. Hyperacute graft rejection is occurring within minutes. Why? Because of the presence of preformed antibody. It occurs within minutes because of preformed antibody in donor या recipient. किसमें antibody थी? I took the graft, my body rejected it. So I had antibody against the donor. So because of preformed antibody in recipient. So it is which hypersensitivity reaction? It is type 2 hypersensitivity. It is type 2 hypersensitivity. Antibody mediated hypersensitivity. मेरे में antibody थी ना. Type 1 मत बोलना. Nobody is allergic to anything. I know girls, you love to say I'm so allergic to this, that, whatever, but no, it is type 2 hypersensitivity, antibody mediated hypersensitivity. Next, microscopically, already agreed, microscopically showing the presence of fibrinoid necrosis. You already know this. The most aggressive pattern of necrosis is fibrinoid necrosis, hyperacute graft rejection. Next is acute graft rejection. Next is acute, which occurs within days to weeks. It is of two types: humoral, cellular. Humoral is antibody mediated hypersensitivity, that is, it is type 2 hypersensitivity, versus cellular, type 4, cell mediated in a type 4. Acute humoral, it is associated with deposition of C4D. What is getting deposited? C4D, complement protein 4D, deposition of C4D in peritubular capillaries. It is associated with deposition of complement protein 4D, C4D deposition around the tubular capillary. Versus cellular, which is the main cell associated with acute cellular? Who is always the culprit? T cells. Recent FMGE PYQ, T cell. Like in a relationship, it's always the guy's fault. तो हमेशा बच्चे T cell की गलती होती है, चाहे वो graft rejection हो. I took the graft, my body rejected. Graft rejection. Graft versus host disease. I took the graft rejected my body. GVHT. IBD, inflammatory bowel disease. IBD, sarcoidosis. कोई भी condition है, out in these four, the main inflammatory cell is T cell. Main inflammatory cell is T cell. This was recent FMGP. Versus chronic graft rejection. Chronic है, long term है. Chronic है. So again, it is of two types, humoral, cellular. I need not even ask you now that humoral is type 2 hypersensitivity versus cellular, which is type 4 hypersensitivity. You know that. Chronic tha na, so it is associated with fibrosis. This is graft rejection, an important topic. So types of graft followed by graft rejection. And this gets us to our last, but again a very important topic in immunity, that is amyloidosis. So what is amyloid? It is extracellular deposition of abnormally folded protein. Extracellular होता है. Classification से शुरू करते हैं. Primary amyloidosis, seen in multiple myeloma. The protein getting deposited is AL, amyloid light chain. Primary amyloidosis, AL, amyloid light chain. Versus secondary reactive amyloidosis, the most common cause of which is rheumatoid arthritis. Most common cause of which is rheumatoid arthritis. The protein getting deposited is AA. Primary amyloidosis is AL, amyloid light chain. Secondary, AA. Most common cause of which is rheumatoid arthritis, AA. Next, hemodialysis associated amyloidosis. How many kidneys do you have? Until we have not purchased iPhone, अपने पास 2 kidneys है ना? Beta 2 microglobulin. Hemodialysis associated. Recent FMGE PYQ, beta 2 microglobulin. Next question, again PYQs. Which thyroid cancer is associated with amyloid deposition? Medullary carcinoma thyroid. Which protein is getting deposited? ACAL, amyloid calcitonin. ACAL. So which is the tumor marker of medullary carcinoma thyroid? Calcitonin. एक ही बात है. It's the same thing. कान को चाहे ऐसे पकड़े या दूसरी साइड से. So the tumor marker with medullary carcinoma thyroid, calcitonin. And lastly, most common cause of dementia in elderly, Alzheimer's disease. Dementia in elderly is because of Alzheimer's. And which is the protein getting deposited? A beta. एक brain है ना, A beta. 2 kidney था. So hemodialysis associated amyloidosis, beta 2 microglobulin. Alzheimer's disease, A beta. Next point. Which is the most characteristic stain for amyloid? Before we go further, that is one of the most commonly asked questions. Most characteristic stain for amyloid? Congo red. We discussed this in our previous chapter only. Inflammation. What is the color of amyloid with Congo red? Red, yellow, blue, apple green. What is the color of amyloid with Congo red? It is red in color. It is brick red or salmon red in color. Apple green is the birefringence under polarized. Please don't go wrong in that. Perfect. It is brick red or salmon red. On electron microscopy, amyloid, which we see straight lines. That is, it shows non-branching fibrils 7.5 to 10 nanometers in diameter. Straight lines and non-branching. On X-ray crystallography or infrared spectroscopy, it shows the presence of beta-pleated sheets. On X-ray crystallography, Shrikant, again you said apple green. Nahi bache, it is red in color. Apple green was with polarizing microscope. Next point. On X-ray crystallography or infrared spectroscopy, we see beta-pleated sheets. Asha, now there are two statements. इनिशियल साइट ऑफ बायोप्सी, मोस्ट स्पेसिफिक साइट ऑफ बायोप्सी. रेक्टल बायोप्सी क्या होगी? इनिशियल या स्पेसिफिक? रेक्टल बायोप्सी is the most specific site. Think of it yourself. You went to the doctor for the first time. He says remove your pants. You will at least go for a second opinion. So most specific, rectal biopsy. Initial being abdominal fat. Initial site of biopsy being abdominal fat. Most specific, rectal biopsy. And lastly, amyloidosis in spleen. Morphologically, spleen has two areas, red pulp, white pulp. Amyloid deposition in red pulp. Red is lal now, which it is called as lardaceous spleen, versus amyloid deposition in white pulp, that is sacospleen. This is amyloidosis. Two important slides. The classification of amyloidosis. We had three important PYQs, recent FMGE exams from this slide, followed by the classification, followed by the one-liners. This was amyloid. And lastly, एक Digeos syndrome पे भी there was a recent PYQ. You had history of a young child presenting to the OPD with neonatal seizures. Patient has hypocalcemia, calcium is reduced, which can present as neonatal seizures. Thymic hypoplasia, congenital heart abnormalities, developmental delay and delayed milestone. This was given in the question. Thymic hypoplasia, thymus is hypodeveloped with neonatal seizures, congenital heart defects, developmental delay and delayed milestone. This was given. Diagnosis, Digeos syndrome. Digeos syndrome, it has two types of inheritance. Hereditary, acquired, familial, non-familial. Non-familial cases, they occur because of chromosome 22q11 deletion. Non-familial, catch 22 na bache, chromosome 22q11. Chromosome 22q11 deletion, non-familial. Familial cases, you know from anatomy, the pharyngeal pouches. That is, it occurs due to failure of development of third and the fourth phalange. This is Digeos. Acha, tell me one more PYQ. Suppose you are given a question, SCID. See, there were two questions with respect to immune defects. Rest would have been covered, the disease of immunity in micro. There were two questions with disease of immune system. First was with respect to Digeos syndrome. Clinical history was given and you were asked the diagnosis. Second question was SCID, severe combined immunodeficiency. The name tells you it is combined B and T cell defect. It is a combined B and T cell defect. It is a combined B and T cell defect, which occurs because of ADA deficiency. This was the answer to be marked. It occurs because of adenosine deaminase. It is because of adenosine deaminase, ADA deficiency. SCID. So, अपने तीन questions हो गए. Digeos syndrome, the clinical history was given. SCID, ADA deficiency, and the third question that we discussed earlier, pedigree chart of X-linked recessive was given. Which of the following disease is associated? Viscott-Eldridge syndrome, X-linked. Perfect. So this finishes immunity. And this gets us to our next topic in general pathology, that is neoplasia. Very, very important. Again, we have 3-4 tables in this. If you know these 3-4 tables, now you are set with respect to neoplasia. 3-4 tables hai, ek Warburg effect and so on. So starting with basic terms, hamartoma. This is disorganized growth indigenous to the site. Meaning, it is disorganized growth indigenous to the site. But Amit, the PYQs or the same topics are always repeated. Matlab, what we have covered in this, what we are planning to cover, we are done with more than half of our session. So I have taken care of the previous 3-4 year PYQs which have been asked in the FMGE exam. Same topics, simple, straightforward, classical clinical history based questions, 2-3 line history. Either they can ask the disease, inheritance or something or the other with respect to it, and that's it. Antibodies या कुछ वैसे आ जाता है. Next point. So starting with basic terms of neoplasia. Hamartoma. This is disorganized growth indigenous to the site. उसी जगह है. मतलब bile duct hamartoma in liver. Example, bile duct hamartoma in liver. Bile ducts are present in liver, but normally they are present in portal tract. Suppose they are randomly present in liver, that is a bile duct hamartoma. Versus the next basic term is choriostoma. Chori करके it went to another site. Choriostoma. That is it is present at an ectopic site. Example, pancreatic tissue in stomach. Pancreatic tissue in stomach. If pancreatic tissue is present in stomach, it is not a normal site. Choriostoma. Next basic term is dysplasia. Dysplasia, which is this is abnormal morphology of cells. Cells are not good looking. They have an abnormal morphology. So dysplasia, the cells are dense black, hyperchromatic, high NC ratio, nucleus is large, cytoplasm is less. Point is, dysplasia lacks invasion. Please put a star. Dysplasia lacks invasion. जैसे ही invasion हो जाती है ना, that is called as carcinoma. Dysplasia lacks invasion. Full thickness dysplasia. You know this term from obs-gynae. Full thickness dysplasia. Meaning, let us assume that this is the basement membrane with stratified squamous epithelium of the cervix. Now, dysplasia can be in upper 1/3, upper 2/3 or full thickness. Full thickness dysplasia is called carcinoma in situ. It is called as carcinoma in situ. In full thickness dysplasia, that is carcinoma in situ, basement membrane is intact. Basement membrane is intact. When these cancer cells, when they invade the basement membrane and come down, that is called as carcinoma. So in full thickness dysplasia, that is carcinoma in situ, the basement membrane is intact. These are the basic terms with respect to neoplasia. Fair enough, agreed. So let us start with our first very important topic, that is cell cycle. You know that there are 5 phases: G0, G1S, G2M. We consider dysplasia as irreversible because dysplasia is of 2 types: low grade dysplasia, high grade dysplasia. Low grade may be reversible, but high grade is irreversible. So if dysplasia is asked, it is considered as irreversible. It is not reversible. Next one. These are the 5 terms associated. These are the 5 phases of the cell cycle. Which are the main checkpoints? Cell cycle, which it has 2 main checkpoints. That is G1S, G2M. Which is the main cell cycle checkpoint? G1S. That is end of G1. This is the main cell cycle checkpoint. Why? All tumor suppressor genes act at G1S. There are 3 main tumor suppressor genes, which are P53, RB gene, RB, and P10. P53 is called as molecular policeman. I am writing this by my own hands because when you write or when you even scribble something on your page, you always remember, which it is called as molecular policeman or guardian of the genome, versus RB gene, that is governor of the genome. Don't ask me the difference between guardian and governor, I don't know. P53 is guardian of the genome versus RB gene, governor of the genome. P10 is new molecular policeman of the genome. It is new molecular policeman of genome. ठीक है, मान लिया, agreed. P53 chromosome. P53 chromosome 17p13. P53 नाम में P आ रहा है ना, तो short term 17p13 versus RB gene chromosome 1314. Rest everything is on long arm, chromosome 1314. P10 क्रोमोसोम 10q। देखो P53 शॉर्ट आर्म पे था, नाम में ही P था, 17 P13, अदर देन दैट एवरीथिंग इज ऑन लॉन्ग आर्म। RB 13q14, P10 10q। Most common malignancy with RB gene mutation is RB. Recent FMGE PYQ also, child presented to OPD with small round cell tumor of the eye, retinoblastoma. The most common malignancy associated with RB gene mutation, RB retinoblastoma. Fair enough. Followed by, so examiner can go a step further and ask you which is the second most common malignancy with RB gene mutation. Osteosarcoma. Most common being RB retinoblastoma, followed by osteosarcoma. These are the cell cycle checkpoints. So there were two main tumor suppressor genes. There were two main cell cycle checkpoints, G1S, G2M, main being G1S. Next point. How are these checkpoints crossed? Checkpoints, बच्चे, they are crossed by cyclins binding to cyclin dependent kinases. Again, a very important topic. The checkpoints are crossed. The checkpoints are crossed by cyclins binding to cyclin dependent kinase. Repeatedly asked. There are two main checkpoints. Learn to make this table with me. G1S, G2M. हम नीचे से लिखना शुरू करेंगे. Cyclin A and B help in crossing G2M. C नहीं है. Cyclin D and E help in crossing G1S. Cyclins bind with CDK, cyclin dependent kinase. Again, we'll start making it from below. CDK21, CDK1. CDK3 नहीं है. CDK46 and CDK2. These are the cyclins which bind with cyclin dependent kinase. Which is the main cell cycle checkpoint? G1S. Which is the main cyclin responsible for crossing G1S? Cyclin D, D for Delhi, cyclin D binding with CDK4. Which is the main cyclin responsible for crossing G2M? Cyclin B binding with CDK1. Delhi, Bombay, which is very, very important. Next, again, recent PYQ, what is the sequelae of cyclins? What is the sequelae? Cyclin D, this was the answer to be marked, D, E, A, B. Main cell cycle checkpoint was G1S. तो D सबसे पहले आया, D, E, A, B. This is with respect to cyclins and cyclin dependent kinases. Once you learn how to make this table, now you will never forget it. That is why I wrote it with you, bache. Both of these tumor suppressor genes that was stopping the cell cycle and then is crossing the cell cycle by cyclins binding with CDK. Perfect. Next point. This gets us to our next important topic in neoplasia, that is Warburg effect. Warburg effect. This is altered metabolism of tumor cells. This is altered metabolism of tumor cells. Meaning, tumor cells, even in presence of oxygen, convert glucose to lactic acid. Normally, in all of us, lactic acid is produced anoxidatively. That is in absence of oxygen. When we are running very fast, we get that crampy muscle pain in our legs because of formation and production of lactic acid, which is anoxidative. Normally, when lactic acid is produced, it is associated with generation of 2 ATP. When tumor cells form lactic acid in presence of oxygen, they generate 4 ATP. So tell me, are tumor cells doing a good job or a bad job? With respect to ATP only, they are doing a bad job. Because normally in presence of oxygen, glucose forms 32 ATP. Now remember, it forms 2 ATP in absence of oxygen when lactic acid is formed. In presence of oxygen, it forms 32 ATP. So tumor cells, they are wasting glucose. in presence of oxygen for forming lactic acid. So why are the tumor cells doing that? It is doing it. They undergo aerobic lactic acid formation. Agreed. Aerobic fermentation. It is not for ATP. It is for intermediate metabolites. It is for intermediate metabolites needed for growth of tumor. Needed for growth of tumor. This is Warburg effect. And lastly, what is the significance of Warburg effect? Significance. Warburg effect, which it forms the basis of PET scan. Positron emission technology, it forms the basis of PET scan. PET scan. It is used to detect sites of metastasis. PET scan is used to detect metastasis. So what we do is we give 18 FTG, 18 fluorodeoxyglucose to the patient. It is not getting metabolized. Wherever cancer cells are present, they take up more and more 18 FTG. So we'll be able to scan and know these are the sites where cancer is present. So what is the basis of PET scan? It is the glucose hunger of cancer cells. It is the glucose hunger of cancer cells. Cancer cells, they want to take up more and more glucose, not to form ATP, but for intermediate metabolites needed for growth of the tumor. This is Warburg effect. This is Warburg effect. It is for intermediate metabolites needed for growth. As a result, tumor cells keep on replicating. Perfect. So we have covered the cell cycle checkpoints, crossing the cell cycle, Warburg effect. And this gets us to microbial carcinogenesis. Which microbe is associated with which cancer? Starting with the main one, that is HPV. Human papilloma virus. This is a very important topic. Why? Asha, tell me this. Which famous personality recently, young famous girl, especially in North India, died of cervical cancer? And personally, when her news came out, I was sort of sad ki shit. PP, Poonam Pandey. So after 2 days, we came to know कि it was her publicity awareness generation protocol or stunt that people should know about cervical cancer, this, that. उसके बाद गुस्सा भी आया था सुन के कि she is still alive. But anyways, what changed? Why did she get up one fine day and thought, let me generate awareness about cervical cancer? But this is because Government of India has introduced pre-HPV vaccination for all school-going girls 9 to 14 years of age in National Immunization Program. Very, very important. Next point. HPV. It is of two types. Low risk versus high risk HPV. It is of two types. Which is more common? Low risk HPV, but it is controlled by immunity. It does not matter. The pathologically important low risk HPV are HPV 611 versus high risk HPV, which are HPV 1618, 31, 33, 45. Kohli is on 45, he hits a 6, but it was a no ball. 52, he again hits a 6, 58. These are the high risk HPV. 16, 18, 31, 33, 45, 52, 58. Which HPV has the maximum chances of cervical cancer or maximum predisposition for squamous cell carcinoma cervix? HPV 60. Next point. HPV vaccine. Again important hai. HPV vaccine. Cervarix is bivalent vaccine. That is, it is against two strains, 16-18. Gardasil is tetravalent vaccine. Gardasil is tetravalent. It is against 4, 611, 16-18. Gardasil is the one that is in the National Immunization Program. And next is the nonavalent vaccine, which is against all 9 strains of HPV. 2 low risk, 7 high risk. Nonavalent vaccine. HPV vaccine. Bache, it is made. Firstly, it is not a cervical cancer vaccine. It is an HPV vaccine. Cervical cancer, main risk factor is HPV, but there are other risk factors also. Multiple sexual partners, high risk behavior, lower socioeconomic status, poor hygiene, so on. ठीक है, मान लिया, agreed. HPV vaccine, this is against structural protein of HPV. It is against the structural protein of HPV. That is, it is against the L1 protein. It is against L1 protein. Remember when we took COVID vaccine? COVID virus had a structural protein, the spike protein. We wanted antibody against spike protein कि जब infection होगा तो उसके against antibody तो already है ही, तो infection नहीं हो पाएगा. We always want antibody against the structural protein. Which is the structural protein of HPV? L1 protein. So microbial carcinogenesis, the first is HPV. It causes cancer everywhere, wherever we have sex. Carcinoma cervix, vulva, vagina, anal canal, esophagus, so on. No double meanings. This is HPV. Next, EBV, Epstein-Barr virus. Recent FMGE PYQ associated with nasopharyngeal carcinoma. Other than nasopharyngeal carcinoma, it is associated with both Hodgkin's lymphoma and non-Hodgkin's. Which non-Hodgkin's? Burkitt's lymphoma. EBV, Epstein-Barr virus, EBV. Next, hepatitis B and hepatitis C virus, which are associated with hepatocellular carcinoma, HCC. Next, H. pylori, Helicobacter pylori. Obviously, it is associated with peptic ulcer disease, leading to, it is associated with which cancer? Stomach cancer, gastric adenocarcinoma. It increases the risk of stomach cancer. Stomach is which cancer? Squamous cell carcinoma, adenocarcinoma. HHV8, बच्चे very, very important. Please put a star, very important. It is associated with Kaposi sarcoma. Kaposi sarcoma HIV के साथ भी है. Most common malignancy, let me write this here. I want you to tell me this. Which is the most common malignancy with HIV? I'm giving you 2 minutes to tell me this. Suddenly very quiet. After the break, we were supposed to be more active. I know neoplasia थोड़ा सा chapter भी वैसा ही है. But fair enough. Which is the most common malignancy with HIV? NHL. NHL, non-Hodgkin's lymphoma. NHL, followed by Kaposi sarcoma. Most common malignancy with HIV is NHL, non-Hodgkin's lymphoma, followed by Kaposi sarcoma. वाह शुभम, इसको याद रखने की जगह, काउंट करने की जगह कापोसी सार्कोमा वाला आंसर देना था. So please do not say that ever that the most common malignancy with HIV is Kaposi. Never do that. It changed 7-8 years ago. Most common malignancy with HIV, NHL, non-Hodgkin's lymphoma, followed by Kaposi sarcoma. So I can rephrase this as Kaposi sarcoma is associated with which other virus? HHV8. Kaposi sarcoma दो viruses के साथ है, HIV and HHV8. HHV8, human herpes virus 8, HHV8, it is with 3 diseases. Kaposi sarcoma, primary effusion lymphoma. Kaposi sarcoma, primary effusion lymphoma, and Castleman disease. Please give me a thumbs up if you have understood this. So HHV8, human herpes virus 8, it is with 3 diseases. Kaposi sarcoma, primary effusion lymphoma, and Castleman. Lastly, the 2 parasites. Schistosomiasis, which is with bladder cancer. कौन सा bladder cancer? Squamous cell carcinoma, urinary bladder. Schistosomiasis, it is with bladder cancer, that is squamous cell carcinoma, urinary. And lastly, liver fluke, Opisthochus sinensis. It is with liver cancer. Which liver cancer? Cholangiocarcinoma. First class. This is microbial carcinogenesis. Which microbe is with which malignancy? This is microbial carcinogenesis. And this gets us to our next topic, that is tumor lysis. इसमें ना बस मुझे एक ही पॉइंट बताना है. The name tells you the tumor cells are getting lysed. So this is due to destruction of large number of tumor cells. Tumor cell lyse हो रहे हैं. क्यों destroy हो रहे हैं? It is seen during treatment of Burkitt's lymphoma and ALL. It is when Burkitt's lymphoma and ALL is getting treated. So tumor cells get lysed. Okay, fair enough. I agree. When tumor cells get lysed, it is associated with hyperuricemia. Uric acid increases. Potassium increases. Hyperkalemia, which is life-threatening because tumor cells are getting lysed, so potassium release हुआ. Hyperphosphatemia. Phosphate increases. Uric acid increase. Tumor cells get lysed, so uric acid increases, potassium increases, phosphate increases. But calcium reduces. It is associated with hypocalcemia. बहुत important है. So all of the following are features of tumor lysis syndrome except hypercalcemia. Calcium reduces. It is associated with hypocalcemia. Lastly, it is also associated with acidosis. Doesn't matter. The main point was hypocalcemia hota hai, hyper. This was tumor lysis syndrome. And this gets us to almost our last topic in neoplasia, tumor markers and IHC. मुझे फटाफट से बता दो. AFP, alpha fetoprotein, AFP. Next two systemic PAT topics will take care of every paper, minimum of 3-4 questions. So AFP, alpha fetoprotein, AFP किसका ट्यूमर मार्कर है? Liver cancer, HCC. Other than HCC, it is also seen in yolk sac tumor ovary, AFP. Next, recent FMG PYQ, CEA, carcinoembryonic antigen. CEA, carcinoembryonic antigen, which is seen in adenocarcinomas of the body. That is adenocarcinoma lung, colon, pancreas and ovaries. CEA, carcinoembryonic antigen, it is non-specifically seen in adenocarcinomas of the body. Adenocarcinoma lung, colon, pancreas and ovaries. This was recent FMG PYQ, CEA, carcinoembryonic antigen. Next, the CA markers. CA125, ovarian cancer. 125, ovarian cancer. CA72-4, 72 rupees की वो आइसक्रीम आती है ना ट्रिपल संडे. 72-4, gastric cancer. Just a way to remember. CA15-3, at 15 years breast development starts. Breast cancer versus CA19-9, that is pancreatic cancer. CA markers. These are the main tumor markers. I'm not even writing PSA, prostate specific antigen, prostate cancer, obviously. These are the tumor markers associated. AFP बहुत important था. Alpha fetoprotein, yolk sac tumor, HCC, hepatocellular carcinoma. CA, carcinoembryonic antigen was recent PYQ. CA markers can be CA125, 72, 490. These are the tumor markers. Followed by IHC, immunohistochemistry. Cytokeratins, but they are seen in carcinomas. Carcinomas are cytokeratin positive versus sarcomas, which are vimentin positive. A special sarcoma, that is alveolar rhabdomyosarcoma, which is desmin positive. Alveolar rhabdomyosarcoma, that is desmin positive. Carcinomas, cytokeratin, sarcomas, vimentin. Alveolar rhabdomyosarcoma, desmin. Lymphomas. Lymphoma is malignancy of lymph node. Lymphomas, बच्चे they are CD45 or LCA. ल्यूकोसाइट कॉमन एंटीजन पॉजिटिव। देखो लिम्फोमा कहाँ से ओरिजिनेट होगा? इट इज फ्रॉम लिम्फ नोड, WBCs. Which marker is always present on WBCs? Leukocyte common antigen, CD45 or LC, lymphomas. HMB45 and S100, it is seen in melanomas. HMB45 and S100, melanomas. Which is more specific for melanoma? HMB45 or S100? HMB45. More specific for melanomas, HMB45. And lastly are the gliomas, brain tumors, gliomas, which are GFAP, glial fibrillary acidic protein, GFAP positive glioma. Perfect. So this finishes neoplasia. This finishes the tumor markers and ISCs, immunohistochemistries, and this finishes neoplasia. Next point. अच्छा मुझे एक दो पॉइंट्स बता दो बिफोर वी गो फर्दर. टेल मी 1-2 points with respect to hemodynamics. Very simple, straightforward topic. You have a history of a deep sea diver presenting to your OPD with chokes and bends. कौन सा embolism है? Which embolism is seen in deep sea diver? If we are talking with respect to deep sea divers, it is associated with air embolism. You have a history of a young male presenting with fracture of the long bones, low platelet count, and dyspnea after 2 days of accident. 32-34-year male underwent road traffic accident leading to fracture of the long bones. Platelet count is low and he is having dyspnea. It is a case of which embolism? You know this, bache? Fat embolism. Agreed. Fat embolism. Perfect. You have a history of a postpartum female. The mother just gave birth to the baby. Postpartum female presenting to OPD with neurological defects. Neurological defects. It is which embolism? Amniotic fluid embolism. It is a case of amniotic fluid embolism. Which is the most common embolism? Overall, which is the most common? Pulmonary thromboembolism due to deep venous thrombosis. Most common is pulmonary thromboembolism. Due to DVT, deep venous thrombosis of the lower extremities, DVT, lower extremities. Perfect. So let us start with hemodynamics. We have already seen that pulmonary thromboembolism is the most common associated with DVT. Fat embolism, skeletal injury, fractures of long bones, soft tissue trauma. Chokes and bends, deep sea divers, chokes and bends, that is air embolism. You already know this. Point to be noted here is Caisson's disease. It is a chronic form. Of decompression sickness, which is associated with multiple foci of ischemic necrosis. Chronic form of decompression sickness है ना, तो बहुत सारे छोटे छोटे foci बन गए in long bones, that is femur head, tibia, humerus. Caisson's disease, chronic form of decompression sickness. Complication of labor, permanent neurological defects, amniotic fluid embolism. These are the embolism. Achha, another important topic in hemodynamics is have a look at this image. Have a look at these types of infarct. पहले नीचे वाला देखो image. You know this is either kidney or spleen showing coagulative necrosis. We have seen this image. This is the site where the vessel got thrombosed. So this is a well-defined wedge-shaped infarct. But this is white infarct. This is well-defined wedge-shaped white infarct. Versus now look at this image. This is a loose, ill-defined edematous hemorrhagic infarct, red infarct. So infarction is of two types: red infarct versus white infarct. White infarct is seen in end arterial occlusion. मतलब this particular area is being supplied by this blood vessel only, nothing else. सिर्फ वही blood vessel थी which is supplying that area. So if that blood vessel has undergone thrombosis, this area will undergo infarction. That is white infarct. It is seen in end arterial occlusion. That is in spleen, kidney, heart. Versus red infarct, which is seen in venous occlusions, ovarian torsions, loose spongy tissue like lungs, intestine, where the margins are ill-defined, versus white infarct, which have well-defined margins. Again, बच्चे, this is an important table, important topic, पूछ सकते हैं. White infarct versus red infarct. From forensic, you already know how do we differentiate in antemortem versus postmortem clot. Lines of Zahn किस में मिलती है? I want you to tell me this. Forensic. Lines of Zahn. Lines of Zahn are seen in antemortem clot or postmortem? RBCs are red. Platelets and fibrin are white. So red, white, red, white. Alternating red and white lines. That is lines of Zahn. That is called as lines of Zahn. Are seen in antemortem clot. They are a feature of antemortem clot. If it is a postmortem clot, firstly, it is not attached to underlying blood vessel. The body is hanging. वो dependent area में है. RBCs नीचे settle हो गए. RBCs have settled by gravity. So there is a dark dependent portion. There is a dark red dependent portion and upper yellow chicken fat portion. Upper yellow is chicken fat upper portion. That is postmortem. So वो RBCs, because of gravity, RBCs have settled. Upper platelets and fibrin is the chicken fat. That is postmortem clot. It is not attached to blood vessel. Antemortem clot is attached to the blood vessel and has alternating red and pale areas. That is lines of. Perfect, dosto. Absolutely and absolutely perfect. So this finishes general path in total detail. We have covered this in so much detail. I deliberately did that because systemic path portion, GIT, lung, CVS, that is usually covered with medicine also. And in the crash course of medicine, you had detailed medicine for I think about 14 to 15 hours. So we'll be able to go much faster in this area. But again, GIT is asked. मुझे फटाफट से बस बताते जाओ अब. I'm waiting for your answers on this. This is HND, hematoxylin and eosin. This is esophageal biopsy. You are clearly able to make out that this is the normal stratified squamous lining getting converted to columnar. Along with the presence of these large white goblet cells. That is normal stratified squamous getting replaced by columnar plus goblet cells. So first MCQ, PYQ, it is called as which metaplasia? It is called as intestinal metaplasia. Metaplasia is one lining being replaced by another. जो end lining होती है उसको लिखते हैं. Please don't call it columnar metaplasia. No. Normal stratified squamous getting replaced by columnar plus goblet. Goblet cells भी है ना. So it is called as intestinal metaplasia, Barrett's esophagus. Intestinal metaplasia, Barrett's esophagus. Main risk factor being GRD, gastroesophageal reflux disease, GRD. It is irreversible and is pre-malignant. It can progress to cancer. It is pre-malignant. For which carcinoma of the esophagus? Columnar cells है ना? Adenocarcinoma esophagus. It is pre-malignant. It is pre-malignant for adenocarcinoma esophagus. Perfect. Intestinal metaplasia, Barrett's. It can progress to malignancy, adenocarcinoma esophagus. क्योंकि columnar cells. It has velvety red mucosa. This is velvety red Barrett's. This is velvety red mucosa, Barrett's. Next question. Again, recent PYQ. FMG exam, recent PYQ, nothing was given. Diagnosis, you know this, bache. You know this. This is a case of Achilsia cardia. Food chal nahi raha hai. So, this is a case of Achilsia cardia. Food chal nahi raha hai. The food is not moving. Why is the food not moving? Because of increased tone of lower esophageal sphincter. the tone of the lower esophageal sphincter is increased. As a result, the food is not moving. Echelsia cardia. अच्छा मुझे बस एक चीज़ बता दो. In Echelsia cardia, dysphagia is more to solid or liquid? I want you to tell me this. In Echelsia cardia, dysphagia is more to liquids than solid, which at this point is again important. Dysphagia is more to liquid. It is more to liquid because solid will push through. There was increased tone of lower esophageal sphincter, solid will push through. Liquid will not be able to push. Dysphagia is more to liquid. Versus any carcinoma of the esophagus, any cancer, whether it is squamous cell carcinoma or adenocarcinoma, in carcinomas of the esophagus, dysphagia is more to solid than liquid. This is because cancer है ना, liquid will pass, it will seep through, पतला सा निकल जाएगा, solid push नहीं कर पाएगा cancer को. Eclasia cardia and stuff. Perfect. Next. So this gets us to a next important topic in GIT, gastritis. Gastritis दो टाइप के, acute, chronic. Chronic gastritis main है बच्चे. Most common cause of chronic gastritis, accounting for 90% cases, is H. pylori, Helicobacter pylori. 10% autoimmune gastritis. But H. pylori is called as type B gastritis, autoimmune is type A. देखो 90% was H. pylori, तो H. pylori को ये बोल सकते थे ना, नहीं. Most common cause of chronic gastritis is H. pylori, followed by autoimmune gastritis. H. pylori gastritis, the most common pattern of damage is the antral predominant pattern, 90% cases. Antral predominant, 10% is atrophic. Versus autoimmune gastritis, where the most common pattern of damage is the atrophic pattern. So, first question, which is the most common cause of atrophic gastritis? H. pylori, autoimmune. Which is the most common cause? Most common cause of atrophic gastritis. Answer बच्चे, H. pylori, autoimmune. Autoimmune gastritis. This is 10% of overall. H. pylori का atrophic is 10% of 90%. This is 10% of overall. So most common cause of atrophic gastritis, autoimmune gastritis. Autoimmune gastritis. Next point. H. pylori दो पैटर्न से था, antral predominant and atrophic. Antral predominant pattern में HCl है ना, H. pylori है, so HCl increases. Because of H. pylori, HCl increases. Which hormone is needed for HCl? HCl कौन सा hormone secrete करता है? Gastrin. So gastrin reduces. जब HCl high है, increased HCl gives a negative feedback to gastrin. So gastrin reduces. So H. pylori has hyperchlorhydria. HCl increased है ना, hyperchlorhydria with hypogastrinemia. HCl बढ़ा हुआ है, gastrin कम है. Versus atrophic pattern. Atrophic pattern, glands are undergoing atrophy, so HCl reduces. It is associated with fat gastritis. Doesn't matter. Next point. Which is the main test for H. pylori? We can do ELISA. In ELISA, we detect the presence of antibodies against H. pylori. Next is urea breath test. In urea breath test, we give C14 labeled urea tablet to the patient. हमने C14 labeled urea tablet दी. C14 is radio labeled. Normal molecular weight of carbon is 12, atomic number 6, 12, 6. We give C14 labeled urea tablet. If patient's stomach has H. pylori, it will have urease activity, which converts it into C14 labeled carbon dioxide plus ammonia. This carbon dioxide is secreted in breath of the patient. Urea breath test. तुमने urea tablet दी and you're detecting carbon dioxide in breath of the patient. Urea breath test. Next test is culture. Culture पे कुछ grow नहीं होता, it is less sensitive. Last is histology. I am seeing, after biopsy, I am seeing it under the microscope. So there are 4 tests. ELISA, urea breath test, culture, histology. Which is the diagnostic gold standard? Diagnostic gold standard, histology. We use silver stains. I want you to tell me which is the stain used for H. pylori? You know this बच्चे, PYQ recent FMG PYQ भी था ना, Waldenstern stain. For H. pylori, agreed. We use Waldenstern stain. Asha, tell me something very truthfully. I'll categorize it into 4 parts. How many of us have understood more than 80% content? Second number is 50 to 80%. Third is less than 50%. Your fourth option, sir, everything is in cloud only. I had not studied path earlier. I was doing the crash course ki ek baar ho jayega, but there's a lot to cover. Very, very truthful. देखो लाइफ में कुछ भी करना है, we have to be truthful to ourselves. I am very comfortable with both option 1 as well as 2. Those of you who are in option 2, बच्चे एक बार रिवाइज कर लेंगे तो we'll come in 1. We have covered in this crash course extensively. इसके बाहर से कुछ नहीं आने वाला with respect to pathology, so don't worry about it. Please do this well. You will have the annotated PDF with you also, so that you can revise much faster. अच्छा, मुझे ये बताओ, there were 4 tests. These are the options: ELISA, urea breath test, culture, histology. Which test will you use for monitoring residual disease after therapy? Which is the investigation of choice? I cannot keep on taking a biopsy again and again after therapy. Antibodies will be positive even after the patient is alright. So which is the test performed for residual disease? Urea breath test. Please put a star. Investigation of choice for monitoring residual disease post therapy, urea breath. This was H. pylori. This is what it looks like. There is a light brown background. The organism of interest is dark brown to black. Silver stain, Waldenstern stain, H. pylori. Helicobacter pylori, H. pylori. This was H. pylori. And this gets us to our last topic in GIT, intestines, the most important one. First question, main inflammatory cell, exact image. This was the FMG PYQ, exact image, exact question. Main inflammatory cell associated with this is, answer, T cell, B cell, macrophage, plasma cell. This is not celiac. Celiac was also asked as image based question, but देखो इसमें नजर क्या आ रहा है. It has crypts. What goes up is villi, what comes down is crypt. Small intestine में दोनों होते हैं. Small intestine has villi and crypts versus colon, which only has crypts. You know this. So this is colon. Where is the problem? This circle thing is the problem. This is a granuloma. So this is a case of granulomatous colitis. Which is the most common cause of granuloma in colon? Which is the most common cause of granuloma anywhere in the body in India? सबसे पहले कौन सी डिजीज सोचोगे? TB. Most common cause being TB, followed by IBD. Which IBD? Crohn's disease. So TB first. TB. So now tell me, which is the main inflammatory cell associated with TB? That was the question. Answer being macrophage. Main inflammatory cell being macrophage. Exact image, exact PYQ. I know that you already know that IBD, Crohn's disease, has granulomas. Main inflammatory cell of Crohn's disease is T cell. But examiner ने Crohn's का main cell नहीं पूछा था. Examiner had asked you the main inflammatory cell with TB, macrophage. Next. So IBD is of 2 types. It is of 2 types. That is Crohn's disease and ulcerative colitis. These two are opposite of each other. Crohn's disease, which it shows the presence of skip lesions. Involved normal. Skip lesions are giving it cobblestone mucosa appearance. Most common site being ileum. Crohn's में rectum is always spared. Versus ulcerative colitis में rectum is always involved. पहला point. In ulcerative colitis, rectum is always involved, rectum is always involved, and इसमें continuous lesion होता है. Ulcerative colitis has a continuous lesion. Skip lesion है क्रॉन्स में. क्रॉन्स का मोस्ट कॉमन साइट था इलियम. अल्सरेटिव कोलाइटिस मोस्ट कॉमन साइट है रेक्टम. रेक्टम इज ऑलवेज इन्वॉल्व और कॉन्टिन्यूस लीजन है. तो जब कॉन्टिन्यूस लीजन है तो पहले डिसेंडिंग कोलॉन इन्वॉल्व हुआ, फिर ट्रांसवर्स, फिर असेंडिंग. जब इलियम में गया तो इसे बोला बैक्वाशिलिटिस. कोलॉन डायलेटेड है क्योंकि कॉन्टिन्यूस इन्वॉल्वमेंट है ना, तो इट इज कॉल्ड टॉक्सिक मेगाकोलॉन, गिविंग इट लेड पाइप अपीयरेंस रेडियोलॉजिकली. दिस इज ग्रॉस. ठीक है, मान लिया. माइक्रोस्कोपिकली क्रॉन्स डिजीज में डीप नाइफ लाइक अल्सर्स हैं, डीप अल्सर्स हैं. सो क्रॉन्स डिजीज हैज ट्रांसम्यूरल इन्फ्लेमेशन, सीरोसाइटिस एंड ग्रैनुलोमास. डीप अल्सर्स थे ना. अल्सरेटिव कोलाइटिस में सुपरफिशियल अल्सर है. ये नॉर्मल एरिया है. अल्सर कौन सा है? रेड वाला. इट हैज ब्रॉड सुपरफिशियल अल्सर. तो जो नॉर्मल म्यूकोजा है इट लुक्स एलिवेटेड, वो उठी हुई नजर आती है. दैट इज कॉल्ड एज pseudopolyp. So ulcerative colitis is associated with pseudopolyp, which is the normal mucosa which looks elevated. This is the master table of Crohn's versus ulcerative colitis. Important है. Malignancy किस में होती है? एडिनोकार्सिनोमा, कोलोनिक एडिनोकार्सिनोमा किस में होता है? Crohn's या ulcerative? Ulcerative colitis. Ulcerative colitis shows malignant potential, that is, it is associated with colonic adenocarcinomas. It is present in ulcerative colitis. Lastly, antibodies. Crohn's disease में कौन सी एंटीबॉडी है? ASCA, एंटी सैक्रोमाइसिस सिरिविस एंटीबॉडी, ASCA. अल्सरेटिव कोलाइटिस में कौन सी है? ANCA, एंटी न्यूट्रोफिल cytoplasmic antibody. And which ANCA? The best answer is atypical ANCA followed by PANCA. अगर atypical options में नहीं है तो PANCA. This is Crohn's versus ulcerative colitis. Main inflammatory cell T cell है. But when this question was asked, main cause of granuloma in colon Crohn's नहीं है, TB है. तो main inflammatory cell बन गया macrophage. I sincerely hope everybody is okay with all the points of IBD. Next question. Now have a look at this. ये lumen of the intestine है ना. This is the intestinal lumen. आगे जाके lumen obliterate हो रहा है. The lumen is narrowed or obliterated. क्यों? Because of all this fibrosis. Obliteration of intestinal lumen. Because of fibrosis, Crohn's disease. This is called Crohn's disease. जिसको radiologically कैसे देखते हैं? String sign of Cantor. Perfect. Shubham, totally agreed दोस्त. This radiologically is seen as string sign of Cantor. Crohn's disease. वो string की तरह नजर आ रहा है. String sign of Cantor, that is Crohn's. You are clearly able to make out barium दोनों जगह था, बीच में string sign of Cantor, Crohn's. ये बताओ. Again a topic asked in every paper, including this times. Skin lesion पूछा गया था. So what do we see here? देखो left hand side image. What goes up is a villi. What comes down is a crypt. These are villi and crypts. This is normal. This is normal small intestine. Versus the second image, which has flattening of villi. ऊपर से flat हो गया. That is villus atrophy. Flattening of villi with crypt hyperplasia. Flattening of villi with crypt hyperplasia. So the total thickness is same. Total thickness is same, making this as a case of celiac disease or gluten sensitive enteropathy. Celiac disease or gluten sensitive enteropathy. Patient क्या नहीं खा सकता? Patient cannot eat wheat, rye, oats, barley. What can he eat? Rice, maize, potato, tapioca. We have already seen that. Rice is pulao, recent PYQ. We have seen the image. कौन से HLA के साथ है? DQ2/DQ8. This time's FMG PYQ, it is associated with which skin lesion? DH, dermatitis herpetiformis. This is celiac. Which are the antibodies associated with celiac? बच्चे ये सब बहुत important है. DH dermatitis herpetiformis. Which are the antibodies associated with celiac? 3 है, anti-endomysial, anti-gliadin and anti-transglutaminase antibody. There are 3 antibodies seen in celiac. Anti-endomysial, anti-gliadin, anti-transglutaminase. Again, recent PYQ. I think previous 2 years, 4 papers, 4 questions on celiac. Which is the best antibody, most sensitive and most specific? Anti-TTG antibody, anti-transglutaminase antibody. Perfect. Next benign disease of the intestine being Whipple's. यहीं देख लेते हैं. Whipple's disease. बच्चे, it shows the presence of PAS positive, periodic acid shift, PAS positive, diastase resistant granules. PAS positive, diastase resistant granules. कहाँ? In macrophages, most common location of which is lamina propria. This is Whipple's disease. PAS positive, periodic acid shift positive, diastase resistant granules in macrophages in lamina propria, that is Whipple's. So these were the 3 benign diseases of the intestine. IBD, celiac, Whipple's. Occurs due to infection by Trophidema whippleyi. Whipple's disease. Perfect. Next. So this gets us to the other side, that is intestinal. अब अगेन इंपॉर्टेंट टॉपिक है क्योंकि पॉलिप्स बच्चे 2 टाइप के हो गए. देयर ऑफ 2 टाइप्स, नॉन नियोप्लास्टिक वर्सेस नियोप्लास्टिक पॉलिप. विच आर मोर कॉमन? नॉन नियोप्लास्टिक मतलब वो कैंसर नहीं कर रहे. दे डू नॉट इंक्रीज द रिस्क ऑफ कोलॉन कैंसर. दे डू नॉट इंक्रीज द रिस्क ऑफ कोलॉनिक एडिनोकार्सिनोमा. सिंपल चीज़ है, नॉन नियोप्लास्टिक है. बट देयर इज अ स्पेशल नॉन नियोप्लास्टिक पॉलिप called as hamartomatous polyps. Hamartomatous polyp, it is a special type. It is a special non-neoplastic polyp which increases the risk of colonic cancer. वो colonic adenocarcinoma का risk बढ़ाता है. And there are 2 hamartomatous polyps. 2 hamartomatous polyps है. Which ones? They are Peutz-Jeghers syndrome, PJ syndrome, Peutz-Jeghers syndrome and juvenile polyposis syndrome. Juvenile polyposis syndrome. Both of these are non-neoplastic polyps and they increase the risk of colon cancer. Non-neoplastic है तो non-neoplastic तो colon cancer का risk नहीं बढ़ाना था ना. तो जब 70-80 ईयर्स पहले देखा गया तो सोचा नहीं बढ़ाते, बाद में पता चला बढ़ाते हैं. फिर 50 साल पहले पता चल गया था बढ़ाते हैं, बट कैटेगरी चेंज नहीं की. तो लेट अस सी व्हाट वी मीन बाय दिस. वेरी इंपॉर्टेंट बच्चे, वेरी वेरी इंपॉर्टेंट. Peutz-Jeghers syndrome. 11-year child presenting to OPD with polyp in jejunum, PJ. सेकेंड अल्फाबेट J है ना, jejunum में polyp है with hyperpigmentation around oral cavity. With hyperpigmentation around oral cavity. Peutz-Jeghers syndrome. ये क्वेश्चन में दिया होगा. What will be asked? This will be in the question. Question will be classical 3-4 line classical clinical history ना. What is asked is gene mutation STK11. Microscopically showing Christmas tree appearance. It is associated with STK11 gene mutation. STK11 microscopically it has the classical Christmas tree. Peutz-Jeghers syndrome. ऐसा नजर आता है Christmas tree की तरह. Christmas is right around the corner also. Hyperpigmentation around oral cavity, perioral melanosis. Perfect. Peutz-Jeghers syndrome. अब दूसरा क्वेश्चन सोचो. इफ यू जुवेनाइल क्या है? लेस देन 18 ईयर्स फॉर इंसेक्ट. बट जुवेनाइल पॉलिपोसिस सिंड्रोम 5-year child with bleeding per rectum, juvenile polyposis syndrome. So these are the 2 hamartomatous polyps which are non-neoplastic but they increase the risk of colon cancer. Next, now have a look at this image. I want you to tell me this. What is the parent organ? This is colon. Whole colon is diffusely replaced by polyps. पूरी colon ही polyp से replaced है. Diagnosis, FAP. बच्चे FAP, familial adenomatous polyposis. This is not pseudomembranous colitis. Pseudomembranous colitis is by Clostridium difficile infection. You will have a history of an old female with long-term broad-spectrum antibiotics leading to diarrhea. Clostridium difficile associated diarrhea, pseudomembranous colitis. ये तो whole colon is replaced by polyps. FAP, familial adenomatous polyposis, FAP. APC gene mutation, chromosome 5. APC gene mutation, chromosome 5. Inheritance, autosomal dominant. All colon cancers are autosomal dominant. Girls, think of your ex, think of FAP, think of your ex, think wicked. FAP. It is 100% associated with colon cancer. It increases the risk of colon cancer 100% at young age, old age, at young age. Young matlab less than 30 years of age. This is FAP. Familial adenomatous polyposis. It's a very bad disease. It's a wicked disease to have. It is associated with two syndromes. इसमें दो syndromes नजर आते हैं, Gardner's and Turcot's. Gardner's syndrome is more common. Gardner है ना, तो उसको रोस्टॉन प्रिक होंगे, epidermoid cyst, he has osteomas, hard face, supernumerary teeth. Gardner's is more common. Turcot's syndrome is rarer. This was recent PYQ. Turcot's syndrome में CNS tumors मिलते हैं. Turcot's, it is associated with CNS tumor. दो main CNS tumor हैं, glioblastoma and medulloblastoma multiforme. So recent FMG PYQ, glioblastoma and medulloblastoma multiforme are WHO grade 1, 2, 3, 4 CNS tumor. कौन सा CNS tumor है? 1, 2, 3, 4. लो ग्रेड होगा कि हाई ग्रेड होगा? हाई ग्रेड होगा. हाई ग्रेड होगा क्योंकि फैप के साथ है. फैप इज अ विकेड डिजीज. इट्स अ वेरी बैड डिजीज टू हैव. थिंक ऑफ योर एक्स ना, रिमेंबर? So it is WHO grade 4. Perfect. This finishes GIT. This finishes GIT. And this starts us with our next topic. Before CV special, I want to do kidney. And after kidney, because kidney is again a topic जो हम लोगों का गड़बड़ रहता है. And we get every paper, we get 2-3 questions from this. मतलब kidney is very, very important for us. There is no doubt about it. Every paper you get 2-3 questions. After kidney, we will take a well-deserved 10-minute break. And then we go on to hematology. हम लोग दो main topic करेंगे, bleeding disorders and blood banking. Small topics, but again commonly asked. And then we'll have a look at salient features of blood cancer, and we wrap up our today's session. That is how we go further. So let us start. Let us start with kidney. फटाफट से इसको देखते हैं. Kidney has 4 components. Glomeruli. It has 4 components. Glomeruli, tubules, interstitium, and blood vessels. Whenever we talk of glomerular diseases, we can divide glomerular disease into 3 categories. Listen to this very attentively. Disease of GBM, disease of the glomerular basement membrane. Which is the classical disease of the GBM? Goodpasture syndrome. The classical disease of GBM being Goodpasture syndrome. Goodpasture syndrome, that is anti-GBM antibody. Anti-glomerular basement membrane, anti-GBM antibody, Goodpasture syndrome. Disease of the GBM, nephrotic and nephritic syndromes. Nephrotic syndrome and nephritic. You always, every paper get a clinical history based question on this. Nephrotic syndrome has massive proteinuria, protein loss in urine, more than 3.5 grams per day. It is associated with massive proteinuria. Which is the first protein to be lost? Albumin. Hypoalbuminemia. Hypoalbuminemia. Edema. Oncotic pressure reduces, hydrostatic pressure increases, leading to edema or anasarca. Hyperlipidemia and lipiduria. Lipids बढ़ गए. Hyperlipidemia and lipiduria. Versus nephritic syndrome. which is mild protein loss with hypertension and hematuria. With hypertension and hematuria. Simple hai. This will be given in the question. Most common nephrotic syndrome in children. Most common nephrotic syndrome in children being MCD. Minimal change disease. MCD. Versus most common nephritic syndrome in children being PSGN. Post-streptococcal glomerulonephritis. There is no way we can go wrong in MCD versus PSGN. Most common nephrotic in child, MCD. Nephritic in child, PSGN. Most common nephritic syndrome in adults, IgA nephropathy or Burgess disease. IgA nephropathy or Burgess. इनको एक एक करके देख लेते हैं. Starting with Goodpasture's. Goodpasture's syndrome has anti-GBM antibody. Anti-glomerular basement membrane antibody. Antibody is on glomerular basement membrane. So it is a diffuse linear antibody. It is associated with mutation in alpha 3 chain of the GBM. Organs affected, kidney and lung. कुछ भी नहीं था. Main था anti-GBM antibody Goodpasture's. You already know कौन सी hypersensitivity है? Type 2 hypersensitivity. It is antibody mediated hypersensitivity. Now we have done this. We have done Goodpasture's, you know that. Next. Let us start with the main nephrotic syndrome, MCD. Minimal change. देखो बच्चे, the minute you have a light brown background, this is electron microscopy. This is glomerular basement membrane. This is GBM. GBM, glomerular basement membrane, showing the presence of foot processes of podocytes. Perfect. This is normal. This is normal. In the second image in electron microscopy, this is glomerular basement membrane, but the foot processes of podocytes are lost. There is loss of foot processes of podocytes, MCD. Minimal change. Minimal change. Minimal change. It is the most common nephrotic syndrome in children. बच्चों में देखा जाता है 2 to 6 years. Light microscopy is normal. Light microscopy is no change. Diagnostic hallmark is electron microscopy, which shows diffuse effacement of foot processes of podocytes. Very, very important. You need to know this. This is what diffuse effacement of foot processes of podocytes look like. MCD. So if a child presents to your OPD with nephrotic syndrome, diagnosis is MCD. So have a look at this question. This is how question will be asked in your paper. A 7-year girl is brought with complaints of generalized swelling, grade 3 proteinuria, no hematuria. Means child with nephrotic syndrome. This is a child with nephrotic syndrome. So what is the diagnosis? MCD. Child with nephrotic syndrome is MCD, which is true. Is it Alport's? No. Is it IgA nephropathy? No. IgA nephropathy is seen in adults and it is nephritic. Is it C3 low is seen in PSGN, hypocomplementemia is seen in PSGN, that is nephritic in children. This is nephrotic in child. So answer is MCD. Minimal change disease, answer is MCD. There is no immunoglobulin or C3 deposit. Light microscopy is normal. Electron microscopy is the hallmark, diffuse effacement of foot processes. It is seen in children. So it has an excellent prognosis. It is steroid responsive. Let's have a soft heart for kids. Has an excellent prognosis. It is steroid responsive in nature. बच्चे MCD versus PSGN बिल्कुल गलत नहीं करना. This was MCD, minimal change disease, MCD. Versus, now have a look at this image. अच्छा, इस image से पहले let us first see PSGN in detail. Let me first add a page. Let us see PSGN, post-streptococcal glomerulonephritis. Let's first see PSGN. PSGN, post-streptococcal, you already know it is the most common nephritic syndrome in children. Post-streptococcal. So it occurs after group A. It occurs after group A beta hemolytic streptococcal infection. तो it occurs after, अभी streptococcal infection कहाँ हुआ? After respiratory tract infections. It is seen after respiratory tract infections and skin lesion. What is the skin lesion of streptococci called as? Impetigo. It is called as impetigo. It is seen after respiratory tract infection and skin lesion. अब जब respiratory tract infection के बाद होता है, the incubation period after respiratory tract infection is 1 to 2 weeks versus after skin lesion the incubation period is 3 to 4 weeks. Now understand this very well. Somebody had a kidney disease 1 to 2 weeks after respiratory tract infection. Which is the kidney disease? PSGN. Somebody had a kidney disease 1 to 2 days after respiratory tract infection. Which is the kidney disease? IgA nephropathy or Buchan's disease. Very, very important. Please put a star. If renal disease occurs 1 to 2 weeks after respiratory tract infection, it is PSGN. If it is after 1 to 2 days, it is IgA nephropathy. Very important. PSGN. It has subepithelial. What is the site of antigen antibody deposit? Subepithelial antigen antibody deposit. And on electron microscopy, this is called as humps. You know this. Humps are seen in PSGN, spikes are seen in MGN. Antigen antibody immune complex deposit है ना? So it is type 3 hypersensitivity. Antigen antibody immune complex deposit, it is type 3 hypersensitivity. Type 3. And PSGN, it is associated with hypocomplementemia. C3 is reduced. It is associated with hypocomplementemia. On immunofluorescence, PSGN has the classical starry sky appearance. On immunofluorescence, it has the classical starry sky appearance. अच्छा मुझे ये बताओ, starry sky appearance in blood cancer is seen in? This is PSGN. This is what starry sky appearance, lumpy, bumpy granular deposits or starry sky appearance looks like. PSGN. In blood cancer, it is seen in Burkitt's lymphoma. Lymph node biopsy, Burkitt's lymphoma. Immunofluorescence, PSGN. Agreed. It is associated with hypocomplementemia. Complement is reduced, PSGN. तभी तो जो ये वाला क्वेश्चन था, in this question, C3 will be low. When we talk of hypocomplementemia, we are talking of which disease? PSGN. So MCD versus PSGN. Nephrotic syndrome in children, MCD. Nephritic in children, PSGN. Nephritic in adults, IgA nephropathy or Buchan's disease. Next point. These are the glomerular diseases. These are MCD versus PSGN versus IgA nephropathy. Next point. अब blood vessels पे आते हैं. Have a look at blood vessels now. दो डिजीजेस देखेंगे, हाइपरटेंशन और डायबिटीज. हाइपरटेंशन बच्चे दो टाइप की हो गई. malignant hypertension, that is BP is very high versus benign. If BP is very high, it is associated with rupture of capillaries on renal capsule. BP बहुत high है. So capillaries, they rupture on renal capsule, giving it the classical flea-bitten appearance of the kidney. They rupture on the renal capsule, giving it flea-bitten appearance. Versus benign hypertension, which has the classical leather grain appearance of the kidney. Malignant hypertension, flea-bitten appearance versus benign hypertension, leather grain. Light microscopy. Malignant hypertension had which pattern of necrosis? Which was the more aggressive pattern? Fibrinoid necrosis. It is associated with fibrinoid necrosis. Next, malignant hypertension, BP is very high. So if this is the blood vessel, the muscle layer undergoes concentric hyperplasia. That is onion skin appearance. तो तो malignant hypertension shows two things: fibrinoid necrosis and onion skin appearance, versus benign hypertension, which is associated with hyaline arteriosclerosis. Versus benign hypertension, which is associated with hyaline arteriosclerosis. Next point, light microscopy में which is more specific for malignant hypertension, fibrinoid necrosis या onion skin? Onion skin appearance is more specific. Why? Because fibrinoid necrosis we see with many conditions. More specific, onion skin appearance. And this is what it looks like. Have a look at these two images. देखो एक बार ना ये 5 points हैं hypertension के. Just have a look. Malignant versus benign hypertension. Malignant hypertension, flea-bitten appearance. Fibrinoid necrosis, onion skin appearance. More specific, onion skin. Benign hypertension, leather grain appearance and hyaline arteriosclerosis, and this is what it looks like. The minute I see the first image, I know that this is flea-bitten appearance of the kidney. BP was very high now, so capillaries rupture, giving rise to flea-bitten appearance of the kidney. Microscopically, we have seen this image earlier. This is RBC, vessel wall is disintegrated, fibrinoid necrosis. Flea-bitten appearance of the kidney with fibrinoid necrosis, malignant hypertension. Versus this, which is onion skin appearance, malignant hypertension. Onion skin appearance, malignant hypertension. Do not confuse flea-bitten appearance with leather grain appearance. देखो flea-bitten में ना बिल्कुल वो hemorrhagic spots आ रहे हैं, leather dull होता है, that is leather. Lastly, दो blood vessel diseases है, hypertension and diabetes. Recent FMG PYQ, diabetes microscopically cause nodular glomulosclerosis. Question यही था, nodular glomulosclerosis is associated with diabetic nephropathy. Diabetes is seen in obese adults. खुद सोचो, अगर obese adult है, think of it yourself, if the patient is obese adult, तो उसका पेट ना एक गोले की तरह लग रहा है, नोड्यूल की तरह लग रहा है. So nodular glomerulosclerosis, diabetes, and it shows the presence of KW lesions. It shows the presence of Kimmel-Stale-Wilson. It shows Kimmel-Stale-Wilson mesangial nodules or lesions. KW lesions, Kimmel-Stale-Wilson mesangial nodules or lesions. KW lesions, diabetes. ये सारे देखो, ये ग्लोमेरुलोस्क्लेरोसिस है ना, ये सब स्क्लेरोसिस हो रहा है और गोले की तरह लग रहा है. नोडुलर ग्लोमेरुलोस्क्लेरोसिस, KW lesions, diabetes. This is kidney. हमारा यूरिन एग्जामिनेशन बचा है. We are done with MCD, ESGN, IgA nephropathy, Goodpasture syndrome, and blood vessel diseases, hypertension and diabetes. बच्चे, every paper you get minimum 1-2 questions. 2 question तो किडनी के आ ही जाते हैं, मतलब there is no doubt about it. GIT kidney very very important. Okay, so बच्चे, this gets us to our last topic in kidney, urine examination, that is urolithiasis. Your very recent FMG PYQ, which is the most common renal stone? Most common renal stone, calcium oxalate. Plain and simple, calcium oxalate. It is the most common renal stone. Microscopically, it shows the presence of, देखो मुझे कोई लेना देना नहीं है, that calcium oxalate monohydrate crystals. Calcium oxalate monohydrate crystals are dumbbell shaped, whereas calcium oxalate dihydrate crystals are envelope shaped. Does not matter. More common is envelope shaped crystals of calcium oxalate. They are envelope shaped. This is what it looks like. Dekho, just look here. This is envelope. This is calcium oxalate. Next, it is the most common renal stone. Calcium है ना, so it is radio opaque in nature, obviously. Next, the next renal stone is triple phosphate. Next, which is triple phosphate. also called as struvite stones. Triple. So 3 salts: calcium, magnesium, ammonium phosphate. Triple phosphate. Calcium, magnesium, ammonium phosphate. Ammonia है. Ammonia is a weak base. So triple phosphate stones occur in alkaline urine. It is the only renal stone to occur in alkaline urine. All others occur in acidic urine. Triple phosphate, it is the only renal stone to occur in alkaline urine, and they are associated with proteus infections. They are associated with proteus infections, triple phosphate. Next, microscopically, this is, देखो triple था ना, नाम में ही triple था. So 3 to 6 sided prisms. Microscopically, they have 3 to 6 sided prisms or coffin lid appearance, and they are the largest of all renal stones. They are very large. So from renal pelvis, when it goes into the calyces, it looks like horns of a stag. It is called as staghorn calculi. It is called as staghorn calculi. All these points are important. This is triple phosphate or struvite. The first one was calcium oxalate. Calcium oxalate, next triple phosphate or struvite stone. Next. So triple phosphate, they were the only renal stones to occur in alkaline urine. Rest all occurred in acidic. The next renal stone is uric acid stones. They are rhomboid in appearance. It looks like a rhombus. They are rhomboid. That is uric acid crystals. They are rhomboid. And lastly is the hexagonal laminated appearance. It is like a hexagon and it looks laminated. Hexagonal laminated appearance. That is cystine stones. Perfect. So this is urolithiasis, presence of stones in urine. Plain and simple. And this gets us to urinary cas. Cas के बारे में भी एक बार यहीं देख लेते हैं. अच्छा चलो, let me show you an image. Have a look at this. This is an RBC cast. देख के ही पता चल रहा है these are RBCs. RBC cast seen in glomerulonephritis. Whereas WBC cast, WBC infections में मिलेगा. WBC cast is seen in pyelonephritis. RBC cast glomerulonephritis, WBC pyelonephritis. Recent FMG PYQ, which is the most common renal cast, most common, the one that is composed of TAM protein, hyaline cast. The one that is composed of TAM protein, that is hyaline cast. So most common renal cast, hyaline cast. तो अभी तक हमने क्या क्या देख लिया? RBC cast, glomerulonephritis, WBC pyelonephritis, hyaline cast, TAM protein most common. अब ये इंपॉर्टेंट है. प्लीज पुट अ स्टार. ग्रैनुलर कास बच्चे, दे आर सीन इन ischemic injury. Unfortunately, has to be remembered. Granular cas are seen in ischemic injuries. Whereas broad cas, broad है ना, बड़ी डिजीजेस में होंगे. Broad cas, बड़ी disease में seen in chronic renal failure. Just a way to remember. These are the casts. It was a recent PYQ. FMG segment also TAM protein. WBC cast pyelonephritis, NEAT PG segment also. So an important topic. देखो दो ना simple सी slides हैं. Casts and urinary crystals. But important. The most common cast here is the hyaline cast, the one that is composed of TAM protein. Hyaline cast. Next one. So this starts us with hematology. हम लोग hemat में we will cover the 3 main topics. Bleeding disorders, blood banking. Every paper 3 question इन दोनों से आते हैं. Blood cancer 2 question उसमें से आते हैं. We'll cover these 5-6 questions in this 1 hour. So be very cautious. Bleeding disorder simple सा topic है. बॉडी में कहीं से ब्लीडिंग हो रही है, बॉडी वांट्स टू स्टॉप इट. So सबसे पहले it is associated with formation of primary hemostatic plug, which has 3 steps. Platelet adhesion, which in turn leads to recruitment of platelets and release of granules, in turn leading to platelet aggregation. Platelet adhesion is mediated by von Willebrand factor secreted by endothelial cells binding with GP1B present on platelets. Meaning, if this is the blood vessel, it has endothelial cells which secrete von Willebrand factor binding with GP1B present on platelets. Adhesion. This leads to recruitment of platelets and release of granules, in turn leading to platelet aggregation. Platelets aggregate with each other, which is mediated by GP2B3A present on platelets. They aggregate. So primary hemostatic plug is an aggregate of platelets. There are 4 diseases associated. Deficiency of von Willebrand factor is von Willebrand disease. Capital में लिखा है ना तो it is autosomal dominant. Deficiency of GP1B is BSS, Bernard-Sollier syndrome. ABCD, B पहले आता है, BSS, Bernard-Sollier syndrome. Versus deficiency of GP2B3A, that is Glanzmann's thromboasthenia. Deficiency of GP2B3A, that is called as Glanzmann's thromboasthenia. Glanzmann's thromboasthenia. ये तो होगी deficiencies. Versus antibodies against platelets. Antibodies against GP1B and GP2B3A present on platelets. Antibodies against them is called as ITP. Immune, there is antibody, immune against platelets. So platelet count reduces, thrombocytopenic. Low platelet count leads to purpura, hemorrhagic spots on skin, ITP. This is primary hemostatic plug. Aggregation of platelets. Primary hemostatic plug is followed by secondary hemostatic plug formation, that is fibrin clot, which is formed by 2 pathways, intrinsic and the extrinsic pathway. Extrinsic pathway, but it begins from tissue factor, which activates factor 7 and goes to common pathway. The first coagulation factor of common pathway being conversion of factor 10 to 10A. 10A is activated form of factor 10. जिसको 3 चीजें चाहिए. It needs 3 things. Calcium, phospholipids. Calcium, phospholipids and factor 5. It needs 3 things. Calcium, phospholipids and factor 5. Activated form of factor 10 converts prothrombin to thrombin, which in turn converts fibrinogen to fibrin, So end point is formation of fibrin clot. Fibrinogen को coagulation factor 1 बोलते हैं, prothrombin को coagulation factor 2 बोलते हैं. ठीक है, fair enough, agreed. This is extrinsic plus common pathway. Versus the intrinsic pathway, which is mediated by coagulation factor 12, which activates 11, 10 to common में, 9, 8, and then it goes to the common pathway. 12, 11, 10 common में, 9, 8, and then it goes to common. Test for evaluation of extrinsic pathway is PT, prothrombin time. Normal PT being 12 to 16 seconds. Versus test for evaluation of intrinsic pathway being PTTK or APTT. Normal PTTK being 24 to 36 seconds. Agreed. इसमें जब normally दिया जाता है ना, let me highlight this normal also. Extrinsic pathway PT, ये सब पूछा जाता है. I'm again saying this, I'm not here to increase your knowledge. I'm here to get you past. All this is asked. You are given the questions like PT of a patient is 20 by 16 second. मतलब PT high है. 20 टेस्ट का है, 16 नॉर्मल है, तो पीटी हाई है. If the PT is 16 by 14 seconds, 2 सेकंड का गैप तो ठीक है ना. I say कि we take a 15-minute break, we take a 20-minute break. That's acceptable, that is on time. So 16-14 is normal, 20-16 is high PT. Similar with PTT के 4 सेकंड का गैप हो तो हाई. Next point. So this is primary and the secondary hemostatic plug formation. End point is the formation of fibrin clot, which is the main regulator of coagulation profile. Everything is regulated by thrombin. Main regulator of the whole coagulation profile being thrombin. Next point. All clotting factors are synthesized in liver. All of them, but they are synthesized in liver, except factor 8. Factor 8. This is factor 8A plus von Willebrand factor. You very well know that von Willebrand factor is secreted by endothelial cells. You know that. All are synthesized in liver except factor 8. Which coagulation factor has the least half-life? Factor 7. ये बहुत important है. Least half-life होती है just few hours, 4 to 6 hours. All are synthesized in liver. तो factor 7 भी liver में बन रहा है. So in early liver disease, which test will first become abnormal? PT. क्योंकि बच्चे factor 7 अगर least half life है तो in early liver disease factor 7 will be the first to be affected. अगर वो सबसे पहले affect होगा तो PT increases. Please understand this very well. Least half life factor 7. So the first test to become abnormal in early liver disease, PT increases. Whereas maximum half-life is factor 13. It is 11 to 14 days. कहाँ factor 7 की few hours थी versus factor 13 which is few days. Factor 13. This is also called as fibrin stabilizing factor. So I can safely say that if factor 13 is deficient, fibrin clot is not stable. So clinically it is associated with delayed bleeding. Acha, so you tell me, Simran, when was the first time you bled? Or girls, when was the first time you bled? Fibrin clot stable nahi hai to delayed bleeding hoga. When was the first time you guys bled? When we were born. Umbilical cord was cut. So the classical clinical history of factor 13 deficiency is delayed bleeding from umbilical cord stump. I hope you will never forget this now. It is delayed bleeding from umbilical cord stump. That when we were born, when the first time umbilical cord was cut, that was the first time we guys. And this is the classical clinical history. And because fibrin clot is not stable, so it is associated with delayed bleeding. And the test used for the same being urea clot lysis test. Test being urea clot lysis test. You add urea to the fibrin clot. If fibrin stabilizing factor is deficient, agar clot stable hi nahi hai, you added urea, it got lysed. Urea clot lysis test. Least half-life factor 7, longest half-life factor 13. This is pure understanding. Next point, vitamin K dependent factors are coagulation factors 2, 7, 9, 10. You know that vitamin K dependent 2, 7, 9, 10. So early vitamin K deficiency, which factor will be the first to become abnormal? Which had least half-life? Factor 7. Which had least half-life? Factor 7. So PT will increase first. Next, hemophilia ABC. Hemophilia ABC occurs because of deficiency of coagulation factors. It occurs because of deficiency of coagulation factors 8, 9, 11. ABC 8, 9, 11. Coagulation factor B, that is anti-hemophilic factor 9, is also called as Christmas factor. What is the inheritance of hemophilia? Everybody. मुझे ये मत बोलना कि hemophilia C is autosomal recessive. Not concerned at all. जिंदगी में कोई नहीं पूछने वाला. What is the inheritance of hemophilia? XH, XLR, X-linked recessive, first class. This was basics about coagulation factors. So let us see, and these 2 points are asked. So this gets us to examiner can give you such an image, that is a patient, young male, presented with hemarthrosis, bleeding in the knee joint, hemarthrosis, or deep thigh hematomas. That is, this is a case of hemophilia. This is hemophilia. This is classic hemophilia. So let us make the master table of bleeding disorders. PT, PTTK, platelet count, diseases associated. Isolated elevation of PT. Only PT is increased. Which coagulation factor is abnormal? 7. It had the least half-life. You already know this. Early liver disease, early vitamin K deficiency. You already know that it had the least half-life. It had least half-life. So early liver disease, early vitamin K deficiency. Isolated elevation of PT. Next, isolated elevation of PTTK. Meaning intrinsic pathway is abnormal. So isolated elevation of PTTK is seen in hemophilias. It is associated with hemophilia. Other than hemophilia, it is also seen in von Willebrand disease, VWD. Which is the main test used for VWD? RIPA test. VWD के साथ यहीं लिख लेते हैं. When examiner is talking of specific test for von Willebrand disease, we talk of RIPA. Ristocetin induced platelet aggregation, RIPA test. Next, both PT and PTTK are increased. Both PT and PTTK are increased. That means all the coagulation factors are deficient. Not only of intrinsic or extrinsic, all are deficient. Chronic liver disease. First to be affected in liver disease is 7. First to be affected is 7. Gradually, all coagulation factors are synthesized in liver, others also get affected. Late vitamin K deficiency. First to be affected is 7, gradually 2, 9, 10 also get affected. Manoj Bache, pharma faculty will be able to answer your query much better than. Next, there is total havoc. PT-PTK is high, platelet count is reduced. There is total havoc. This is seen in DIC. Disseminated intravascular coagulation. This is seen in DIC. There was total havoc. This is the master table of bleeding disorder. Nothing is to be memorized in this. If you just know the basics, if you know primary hemostatic plug, secondary hemostatic plug, you will be very comfortable with this table. Please don't sit and start memorizing them. This was bleeding disorder. This gets us to our next very important topic, that is blood banking. Again, simple, straightforward topic, but questions आते हैं. Bombay phenotype बहुत commonly पूछा जाता है. Bombay phenotype, H antigen is absent. देखो, which is the major blood group system? ABO is the major blood group system, which is present on chromosome 9. Chromosome 9 forms a basic chain, that is H substance. Chromosome 9, it forms a basic chain. On this H substance, if A product is added, it is A blood group. If B is added, it is B blood group. O is the amorph gene. Nothing is added to it. O is the amorph gene. But in O blood group, H substance is present. H substance तो होता ही है ना. What is Bombay phenotype? In Bombay phenotype, H substance is absent. H नहीं है तो A और B antigens भी absent है. जब H substance नहीं है तो A antigen और B antigen भी नहीं होंगे. Suppose I am B blood group. I have anti-A antibody. जो antigen नहीं होता उसके against antibody होती है. इसमें there is no antigen. So all the antibodies are present. Anti-A, H, anti-A, anti-B antibodies are present. सारी antibody है. तो Bombay phenotype, it can donate blood to everyone. Why? Because when we donate blood, we give antigen. This means there is no antigen. So it can donate to everyone, but can receive only from Bombay phenotype. It cannot receive O blood group also. Why? Because O blood group has H antigen. इसमें anti-H antibody है. It can donate to everyone, but can receive only from Bombay phenotype. And it is associated with which disease of inflammation? LAD2. Remember, increased risk of infections with mental retardation and Bombay phenotype, LAD2. Which was a defect in? Which was a defect in adhesion or rolling? It was a defect in rolling. Defect in adhesion, LAD1. Defect in rolling, LAD2. Bombay phenotype. So this starts us with blood grouping. I am sure all of us, हम सब ने, all the girls you would have pricked the finger of a guy. हम लड़के लोगों ने उसके बाद on a white tile we would have put 3 drops of blood. Add anti-A antibody, anti-B antibody and anti-RH. That is forward grouping. All of us would have done this. Please tell me, हमने ये किया है ना forward grouping. It detects antigen on RBC surface. White tile पे we put 3 drops of blood. Add anti-A antibody, anti-B antibody and anti-RH. That is forward grouping. Versus reverse grouping, in which we detect antibody in serum. We detect antibody in serum. देखो समझते हैं इसको. Let us first have a look at forward grouping. We detect antigen on RBC. We detect antigen on RBC surface. In reverse grouping, we detect antibody in serum. Forward grouping से शुरू करते हैं. White tile पे 3 ड्रॉप ब्लड के डाले. I add anti-A antibody, anti-B antibody, anti-RH. Anti-RH को anti-D antibody भी कहते हैं. I'll speak out the first one, then I want you to tell me. Suppose somebody is B positive. उसमें कौन सा एंटीजन है? He has which antigen? B antigen and RH. तो जब मैंने एंटी बी एंटीबॉडी डाली एंड एंटी RH तो एग्लूटिनेशन हो गई. पॉजिटिव मीन्स एग्लूटिनेशन हैज अकर्ड. जब मैंने एंटी ए एंटीबॉडी डाली एग्लूटिनेशन नहीं हुई. ए एंटीजन तो था ही नहीं ना. ए एंटीजन वाज नॉट देयर. ठीक है ना. फॉरवर्ड ग्रुपिंग. रिवर्स ग्रुपिंग. बी ब्लड ग्रुप हैज विच एंटीबॉडी? बी ब्लड ग्रुप हैज एंटी ए एंटीबॉडी. तो व्हेन आई पुट ए सेल्स एग्लूटिनेशन हो गई, बी सेल्स तो एग्लूटिनेशन नहीं हुई. You tell me now, positive, negative. I'm waiting for your answer on this. O positive. Forward grouping. O positive blood group. कौन सा एंटीजन है? O positive has which antigens? It only has RH antigen. It does not have A or B antigen. It only has RH. So जब मैंने anti-A and anti-B antibody, there is no agglutination. Take it very right. With anti-RH, agglutination occurs. Perfect. I want all of you to tell me this. रिवर्स ग्रुपिंग. ओ ब्लड ग्रुप में कोई एंटीजन नहीं था, तो उसमें दोनों एंटीबॉडी. इट हैज बोथ एंटी ए एंड एंटी बी एंटीबॉडी. सो व्हेन आई ऐड ए सेल्स एंड बी सेल्स, एग्लूटिनेशन अकर्स. ए बी नेगेटिव. ए बी नेगेटिव ब्लड ग्रुप हैज विच एंटीजन? इट हैज ए एंटीजन, बी एंटीजन, डज नॉट हैव RH. सो व्हेन आई पुट एंटी ए एंड एंटी बी, एग्लूटिनेशन अकर्स. RH नहीं था. ठीक है ना. रिवर्स ग्रुपिंग. ए बी ब्लड ग्रुप में दोनों एंटीजन, इट हैज ए एज वेल एज बी एंटीजन, सो इट डज नॉट हैव एनी एंटीबॉडी. रिवर्स ग्रुपिंग में आई एम डिटेक्टिंग एंटीबॉडी ना, so there is no agglutination. Reverse grouping, there is no agglutination. I want you to tell me this. I am waiting for your answer. A negative. Everybody बच्चे, I am waiting for your answer. A negative. A negative blood group has which antigen? उसमें A एंटीजन है, B भी नहीं है, RH भी नहीं है. सो व्हेन आई ऐड एंटी A एंटीबॉडी, एग्लूटिनेशन हो गई. एंटी B और RH के साथ नहीं हुई. ठीक है ना. रिवर्स ग्रुपिंग. A blood group has which antibody? A blood group has anti-B antibody. So when I add B cells, agglutination occurs. With RH it doesn't. With A it doesn't. This is forward and reverse grouping. Any query, please ask me right now. So look at, perfect. So look at this. Recent NEET PG PYQ. I want everybody to tell me this. Patient 1 is. Examiner just told you forward grouping is performed. अच्छा, O negative देखते हैं. Abdullah, let us have a look at O negative. You tell me, O negative blood group. Which antigen? It does not have A, B or RH. कोई antigen नहीं है. So there is forward grouping. There is no agglutination with any. O blood group has both antibodies. There was no antigen, na? So it has both the antibodies, anti-A as well as anti-B. When I add A cells and B cells, agglutination occurs. This is O negative. Perfect. Recent NEET PG PYQ, so examiner can easily give you this question. Easily. He can easily give you this. Patient 1 is, I want you to tell me O positive, O negative, AB positive, AB negative. These are your 4 options, 1, 2, 3, 4. Patient 1 is plain red है, मतलब there is no agglutination. यहाँ पे agglutination हो गई. Agglutination is only with RH. If agglutination is only with RH, very good, very very good. Which is the blood group? O positive, क्योंकि सिर्फ RH एंटीजन था, सिर्फ O पॉजिटिव है, A और B एंटीजन नहीं है. सेकेंड पेशेंट, ना A के साथ एग्लूटिनेशन हुई, ना B के साथ, ना RH के साथ, मतलब देयर इज नो एंटीजन, नाइदर A नॉर B नॉर RH. O नेगेटिव. O नेगेटिव. थर्ड पेशेंट नहीं बच्चे, देयर वाज नो एग्लूटिनेशन विद any. There was no agglutination, it was just a drop of blood, there was no agglutination. Third patient, agglutination occurred. Agglutination occurs with A and RH, not with B. A positive. Yes, bache, yes. This lecture, this session is more than sufficient, remember, for your FMGE. We have covered it extensively, extensively. You do not have time to do more than these seminars because you'll need to revise this, that, whatever. Please do this well. Fourth, agglutination is only with A, not with anti-B or RH. That is A negative. Perfect. Perfect. This is blood grouping. This is blood grouping. Forward grouping versus reverse grouping. Forward versus reverse. I hope everybody is comfortable with this. This was blood group. This gets us to, how many of you have donated blood? I mean, I have. Which is the first question you ask? Where is my fruity? Uske baad, for how long can this blood be given in the relative? So it depends on the preservative. There are 4 commonly used preservatives. ACD, acidified citrate dextrose, ACD, CPD, CPDH, SHEL. Mota hai, we can use blood for 1 month. Shelf life is in multiples of 7. 21 days, 28 days, 35 days, and 42 days. ACD, acidified citrate dextrose. Dextrose to ATP de raha hai. Citrate chelates calcium. Citrate acts as anticoagulant. It removes calcium. It chelates calcium. I don't want कि blood पड़े agglutinate हो जाए. I don't want that, because if blood clots, then the blood bag will get wasted. It chelates calcium. So, shelf life is in multiples of 7. Most commonly used is CPDA. Citrate phosphate dextrose with adenine. CPDA, shelf life 35 days. Remember, it is 1 month. 35 days. Longest shelf life, SAGM, 42 days. Which we don't want to increase the shelf life too much. Normal lifespan of RBC is 120 days. By 60 days, 75% of RBCs will be dead. I want to give fresh RBCs to my relative, not old decaying RBCs. No? So, when we are giving blood, we don't give whole blood. We give the component that is needed. Packed RBCs. Giving 1 unit packed RBC 1 unit packed RBC increases hemoglobin by 1 gram per deciliter, hematocrit by 3%. See the question carefully. Hemoglobin by 1 gram. Somebody has a hemoglobin of 4 grams per deciliter. 4 तो बहुत कम है. Clinician says 7 grams per deciliter हो. 3 units packed RBC will be given. Giving 1 unit increases hemoglobin by 1 gram per deciliter, hematocrit by 3%. Packed RBCs are cold. That is, they are kept in fridge, 2 to 6 degrees. They have to be brought to room temperature before transfusion. Not by putting it in boiling water, no. You just give it to the patient, he will keep below his pillow and he will be very happy. It has to be transfused within 4 hours of collection from blood bank. It has to be transfused within 4 hours. Packed RBC. Next component of blood is platelets. The next component. First was packed RBC. Next component of blood is platelets. Now, platelets. Now we had an awesome score. India mein to we went to Goa to celebrate. Unfortunately, one of us fell ill. Platelet count became very low. Platelet count became 20,000 per microliter. Normal platelet count is 1.5 to 4 lakh. अब 20,000 तो बहुत कम है ना. Clinician says that it should at least be 50,000 per microliter because at less than 20,000 spontaneous bleeding can occur. So 3 of us will donate blood for our friend. 3 unit platelet, 3 unit RBC, 3 unit FFP will be made. Platelet will be given to our friend. That is random donor platelet. Random donor platelet. Random donor platelet. Giving 1 unit random donor platelet increases the platelet count by 10,000 per microliter. So 20 से 50,000 लाना है, 3 units need to be given. Now a nice pretty girl also went with us to celebrate her success. Unfortunately, she got dengue. Her platelet count reduced, so her boyfriend says ki whatever happens, I will not let anybody else's blood go in her. That is single donor platelet. SDP, single donor platelet. Giving 1 platelets are obtained from a single donor only, and giving 1 unit single donor platelet increases the platelet count by 30 to 50,000 per microliter. So platelets, bache, they are of 2 types: random donor versus single donor. In single donor, only platelets were taken out from that donor. Random donor versus single donor. It does not matter whether it was random donor or single donor. Platelets, storage temperature, room temperature. Room temperature, that is 22 to 24 degrees Celsius. They are kept in an agitated state, otherwise platelets will agglutinate. If bananas are kept at room temperature, they will go wrong in 5 days. So shelf life 5 days. Simple. Platelets. Next, the next component of blood is FFP. Fresh frozen plasma. FFP, fresh frozen plasma. Fresh means plasma has to be frozen within 6 hours of collection. Fresh है. Frozen मतलब storage temperature minus 30 degrees Celsius. Please don't say it as 0 या minus 2 degrees. At minus 2 degrees even my ice cream melts. Frozen minus 30 degrees. If it is deep frozen, so shelf life 1 year. Plasma, very important. It is rich in all coagulation factors. Plasma है ना बच्चे? So it is rich in all coagulation factors except factors 5 and 8. It is rich in all except 5 and 8. So what are the indications of FFP? Why do I need to give coagulation factors? Where are coagulation factors synthesized? In liver. If there is chronic liver disease, all the coagulation factors are reduced. So we need to give coagulation factors. I'll give FFP. I'll give FFP in which hemophilia? Answer: hemophilia A or B? Hemophilia A or B? Hemophilia B. because it was rich in all except 5 and 8. 8 nahi hai na, so I will not use it in A. BF, hemophilia B, FFP, hemophilia B. Where was total havoc? PT, PDTK was high, platelet count was low. DIC. Coagulation factors were less, na? DIC, so I will use FFP. Late vitamin K deficiency. First factor 7 will reduce, gradually others will also reduce. Late vitamin K deficiency. These are the indications of FFP. Fresh, so within 6 hours. Frozen, minus 30 degrees. Plasma, it has all coagulation factors except 5 and FFP. And the last component of blood is cryoprecipitate. Last is cryoprecipitate. Cryoprecipitate, the name tells you it has precipitated proteins from FFP. Precipitated hai. Cryo hai to same minus 30 degrees Celsius, shelf life 1 year. मान लिया. Point is, it is rich in 4 things. Von Willebrand factor, factor 8, fibrinogen, and factor 13. It is rich in 4 things. Rich in 4 things. So what will be the indications of cryoprecipitate? This is used in von Willebrand disease because it is rich in von Willebrand factor. Hemophilia A or B? Hemophilia A. So bache, easy to remember. AC, hemophilia A, cryoprecipitate. BF, hemophilia B, FF. Plain and simple पूछा जाता है. These are the components of blood. Packed RBC, platelet, FFP, cryoprecipitate. These are the components of blood. And lastly, you give, which are the diseases we screen blood for? Hepatitis B, C, HIV, syphilis, malaria. Recent FMGE PYQ, we don't screen for hepatitis A. B, C, syphilis, malaria, HIV. Which is the most common adverse effect after blood transfusion? You give blood transfusion to somebody. It leads to fever. FNH-TR. Fever occurs. Did this fever occur because I gave wrong blood? No, I don't give wrong blood. It is febrile, non-hemolytic. Febrile, non-hemolytic transfusion reaction. Febrile, non-hemolytic transfusion reaction, FNH-TR. Somebody got fever. Second unit blood is to be given. Which one will you give? Second unit blood is to be given. You will give leukodepleted blood, meaning fever occurs because of WBCs and donor blood. So when second unit blood is to be given, you will give leukodepleted blood. Most common adverse effect after transfusion, fever occurred, FNH-TR, non-hemolytic transfusion reaction था. Second unit देने हैं तो donor blood से WBC हटा लिए, leukodepleted blood is to be given. Most common cause of death after blood transfusion, TRALI. That is transfusion related acute lung injury. Most common cause of death after blood transfusion, TRALI. Transfusion related acute lung injury, TRALI. Time period associated 1 to 6 hours. Please note it is not less than 6 hours, 1 to 6 hours, because you need time to run off also. Just a way to remember. And recent PYQ, TRALI. These are the adverse effects with blood transfusion. This is about blood transfusion. You need to know this. And lastly, the vacutainous. Sampling करते करते हमें पता ही है, red cap is empty vial. There is no additive. It is used for serum test. All the LFT, liver function test, kidney function test, hormone assay, that is red vial. Purple top. Purple is EDTA, that is CBC. Green is heparin. Cytogenetics. Green is heparin. G for glucose, G for grey top. Please put a star. Recent PYQ, G for glucose, G for grey top. Anticoagulant, sodium potassium oxalate with sodium fluoride. Sodium fluoride, but it inhibits the enzyme enolase. enolase. I have taken blood sample right now. If I take it in purple top, RBCs will keep on using glucose. I want कि glucose use ना हो ना, उतने का उतना ही रहे. Sodium fluoride inhibits the enzyme enolase. Recent PYQ था. G for glucose, G for gray top. Sodium citrate is the anticoagulant of choice for both ESR and PT. PT, while used, blue top. Please note, EDTA is purple top. EDTA is purple, PT blue. All these are PYQs. Sodium citrate is the anticoagulant of choice for both ESR and PT. For ESR, the ratio is 1:4. For PT, the ratio is 1:9. ESR में 3 alphabet है ना, तो 1:4. Just a way to remember. These are the vacutainers. These are the vacutainers which are used for various sampling. A very, very important topic. Hemat, bleeding disorders, blood banking बच्चे बहुत important है, बहुत ही important है. Simple, straightforward topics, but you get questions. And lastly, let us have a look at few salient features of blood cancer also. I'll write within 5-7 minutes. We'll do the most commonly asked questions in blood cancer. Child with acute leukemia. Diagnosis, keep on telling me the answers. Child with acute leukemia. Acute leukemia shows the presence of blasts. Kitne? More than or equal to 20%. You have a history of a child with very high TLC. TLC is 80,000, 70% blasts and bone marrow showing sternal tenderness. This was the exact recent PYQ. Child with acute leukemia, ALL. Acute lymphoblastic leukemia, ALL. Which ALL is more common? BALL. Adult with acute leukemia. Adult with acute leukemia, AML. Acute myeloid leukemia, AML. Adult with high TLC. Adult with high TLC with hepatosplenomegaly. With this question was asked twice or thrice in recent 2 years. Normal TLC is 4 to 11,000 per microliter. TLC is high with hepatosplenomegaly with shift to left. Shift to left matlab there is presence of all the cells. Blasts, promyelocyte, myelocyte, metamyelocyte, band form and neutrophil. Band forms, neutrophils, along with basophilia. There are 5 points written in this question. Adult, high TLC, hepatosplenomegaly, shift to left. That means you see everything: blast, promyelome, myelome, metamyelome, band form, neutrophil with basophilia. There are 5 points written. Out of these 5, examiner can give you 3-4. Diagnosis, CML. बच्चे बहुत important है, बहुत ही important है. Child with acute leukemia, ALL. Adult with acute leukemia, AML. Adult with high TLC, shift to left, basophilia, hepatosplenomegaly, CML. Chronic myeloid leukemia, CML. CML. Translocation 922. Also called as Philadelphia chromosome. When Philadelphia chromosome is formed, it leads to formation of a protein that is BCR-ABL. BCR-ABL. It is good prognosis. Why? Because we have therapy against it. We use first line tyrosine kinase inhibitors. First line TKI, first line tyrosine kinase inhibitors. That is imatinib. Trade name Gleevec. Trade name Gleevec. So adult with high TLC with shift to left and basophilia, C. And lastly, adult with high TLC with smudge cells, with presence of smudge cells. Smudge cells, girls, you know smudging very well. WBCs are scattered, मतलब वो फैले हुए हैं. Mascara smudges ना टूट कर फैल गया है. CLL. Chronic lymphocytic leukemia, CLL. CLL. This is basic. We cannot go wrong in these 4 points. These are the ones which are most commonly asked. Next, image-based questions. Have a look. I need not even talk about RS cells. You know this very well. This is Reed Sternberg cell. RS cell, Hodgkin's lymphoma, CD15 30 positive. But there is a special RS cell called as popcorn cell. This looks like a popcorn cell, seen in lymphocyte predominant Hodgkin's lymphoma. Seen in lymphocyte predominant Hodgkin's, which is 15-30 negative. Guys, you went for shopping. Shopkeeper says 30. You say 15. What will you settle at? 20. I did not ask the girls because girls will settle at 16 rupees. It is CD20 positive. 15-30 negative, 20 positive. Popcorn cell. Seen in lymphocyte predominant Hodgkin's. Next variant of RS cell is the lacunar type of RS cell. Next is the lacunar type. Lacunar cell, seen in nodular sclerosis, Hodgkin's lymphoma. Seen in nodular sclerosis, Hodgkin's. So classical Hodgkin's, mixed LRT. Most common Hodgkin's in India, mixed LRT. We are a secular country, na mixture of everybody. Popcorn cell, lymphocyte predominant Hodgkin's, 15-30 negative, 20 positive. Next, recent image-based PYQ. Recent PYQ. This is the starry sky appearance, where stars are the macrophages. Stars are the macrophages in a sky of Burkitt cells. Starry sky appearance. Starry sky appearance seen in Burkitt's lymphoma. Seen in Burkitt's. Starry sky appearance seen in Burkitt. You already know Burkitt's lymphoma. Translocation 814. MYC. MYC is a proto-oncogene. It is associated with MYC proto-oncogene mutation. Which MYC? c-MYC. c-MYC Burkitt's. N-MYC, N neuroblastoma. L, which organ starts from L? In English, lung. Small cell carcinoma lung. MYC na bache. c-MYC Burkitt's. N-MYC, neuroblastoma. L-MYC, small cell carcinoma lung. L-MYC, small cell carcinoma. Small cell carcinoma lung. This is Burkitt's lymphoma, starry sky appearance, lymph node biopsy. Lymph node biopsy Burkitt. Lastly, an image which you have to know, matlab no topic ever is over without doing this. You are able to make out RBCs are stacked up on each other. Stack of coins appearance. That is, this is Roulet formation. Stack of coins. Stack of coins appearance. That is, this is Roulet. X is silent. X should always be silent. Na? This is Roulet formation. As compared to RBC, you see very large cells. Abundant cytoplasm, eccentric nucleus. Very large cells, abundant cytoplasm, eccentric nucleus. All these are plasma cells. Making this as a case of multiple myeloma. Making this as multiple myeloma. Now listen to this very attentively. If examiner told you this is peripheral blood, all these are plasma cells, they are more than 20%. In peripheral blood, more than 20% plasma cells makes it as a case of plasma cell leukemia. The multiple myeloma is not the best answer. If plasma cell leukemia is given in the options, please mark that, and this was asked recently. Both multiple myeloma and plasma cell leukemia were given in the options. If examiner told you it is peripheral blood and it is full of plasma cells, please mark it as plasma cell leukemia. You know M-band, Bence-Jones proteinuria, elderly with low back pain associated with graft features. We have discussed all that. Metastatic calcification, you know that. You know that. Please give me a thumbs up if you're okay with this. Everybody, देखो plasma cells, multiple myeloma and the features associated में तो कोई गड़बड़ करनी ही नहीं है. There are two variants of plasma cells. This was a plasma cell. This is a plasma cell. If it has a fiery red cytoplasm at periphery, it is called as flame cell. It is called as flame cell. Flame cell. It has red cytoplasm at periphery. Flame cell. Let me do this. If there is red cytoplasm at periphery, it is called as flame cell. Versus if this is again a plasma cell, large cell, abundant cytoplasm, eccentric nucleus with grape-like inclusions in cytoplasm. With grape-like inclusions. Grape-like inclusions in cytoplasm. This is called as a Mott cell. So plasma cell had two variants. Plasma cell had two variants. Flame cell and Mott cell. Flame cell and Mott cell. This is a plasma cell. Perfect. Perfect. And lastly, have a look at this image. Chances are very high you can get such an image also. But this is fish. Not the fish that we eat. This is fluorescent in situ hybridization fish. Last slide. This is my last topic, last slide, but a very high yield slide. Fish. It is the investigation of choice for detection of fusion transcripts like BCR-ABL. I do not know what this is for. I went to the company, I said, give me green color for BCR, red for ABL. Normally I should see 2 red, 2 green. That is normal because in all of us, we have BCR on chromosome 22, ABL is on 9. It is lying separate. If translocation occurs, that is if yellow color is coming, that means red and green are joining together. That means translocation has occurred. So investigation of choice for detection of fusion transcripts, that is for detection of translocations, fluorescent in situ hybridization. Perfect. Thank you, Andy.